to have our next NMSG annual conference. I'm Rick.
I'm Mike. Hi, good morning, everybody.
And so Mike and I are glad to kick things off. And we have the first slide, Gil. Oh, no, we're doing it. Okay, so thanks for Liz and Donna. We'll thank them more as the day goes on, as the conference goes on. But they put these slides together for Mike and I. And I really like this one. 275 registered attendees at this meeting. It's the biggest ever, so let's give ourselves a round of applause. And 74 of the registered are considered young investigators. So young investigators, raise your hand. That's not you, Dr. Amato. No, yes, okay, well, thank you, Dr. Amato, and all the other young investigators for coming. And it's truly an international meeting, so it's impressive, very impressive. All right, Mike, you're next. Are you next or am I next? Oh, it's still me?
Yeah.
Oh, okay, so
I read the brief.
Oh, you read the brief, right. So Liz and Donna put this amazing slide together. So this is for the NMSG historians, or if you've been around for a long time, the MSG as a transition to the NMSG. So this is the history of our organization. And there's a couple of you that were here in the original meeting at the airport in Chicago that Birch Griggs had. Dr. Amato, Dr. McDermott. Anyone else? Yeah. Was anyone else there at that original meeting? I don't think so. And I was there. Dr. Jackson was there. She couldn't make it to this meeting. And so that's when Dr. Griggs told us about his idea to start this muscle study group. And the verbiage we were talking about at breakfast came after the Parkinson's study group, which is already going in Rochester. And so this was the muscle study group. So that's where it all began. And then for many years, we were in our beloved Beaver Hollow location in upstate New York until we got kicked out by the Biggest Losers group because they took over the venue. So we've sort of been moving around since. This is our second visit in Stresa. We're back by popular demand because when we did it here in 2022, people said they wanted to come back, so here we are. We had this interesting blip during COVID, Michael, where the registration went through the ceiling and then it backed down, although it still continued to be an uphill directory, so it's pretty good. You told me you liked this slide.
It's a really good slide, yeah. I mean, it is incredible, actually, how it's grown. And to have 275 delegates here, it's incredible how much it's really grown over this time, and it's great to see so many people here today. So, next slide.
And that's a lead into our mission.
Yeah. So, I mean, Birch's original vision has remained absolutely core to what we're trying to do. So these remain the central goals of the NMSG. It was the MSG, but now it's NMSG, which is great. So it's to maintain a premier position in the annual meeting and in supporting neuromuscular clinical trials, which are now more relevant than ever, as we all know, because of the fantastic advances in preclinical science that's resulted in translation now into new therapies that we're testing. A really key thing, which, as many of you will know, Birch was absolutely fantastic at and central to, was to support, engage with, and develop young investigators in the field. And that's still an absolutely top priority for us. And it's really great to see so many colleagues and young investigators here. Fostering international collaboration. So I feel I should get a little bit of credit with Valeria for bringing this to Europe from time to time, but it's truly an international organization, and there's extensive collaborations, which of course is really important for some of our rarer diseases. And also we're really proud of the connections we've made with preclinical scientists who are developing targets and pathways for treatment. And last but absolutely not least, partnering with our colleagues in industry is absolutely fundamental to developing therapies. So these are the goals, why we exist, and really, I think, are very true to Birch's original vision.
Right, that's right, Michael, and that really, there's so many things we can thank Dr. Griggs for, but one is that he was sort of the great connector, bringing young investigators up. And Michael, I'm just thinking back, the reason that you and I are both standing up here today is because he brought us together. Back in 2000 or 2001, he told me, he said, Rick, there's this guy in London I need you to meet. And that's how this all happened. So, all right, next. Okay, so how does this meeting all happen? Well, one of the things that has to happen is we have to have an annual planning committee. And this year, the planning committee was co-chaired by Valeria Sansone and Emma Cefaloni, our Milanese. Valeria still lives in Milan, and Emma's from Milan, so they knew the area and they knew about Stresa, and so this really was very, very helpful. So thank you, Valeria and Emma. Mike and I are listed here, but actually, I think we had zero role, right? You know, I don't, was I ever on a single call? I don't know if I was the last year. So, and the planning committee then is Michael Hayher, Amanda Guidan, Jose Manuel Sanz Menjibar. Did I pronounce that right, Michael? Close. Karen Sutherland, John Vissing, and Vino, who's not here today, but she was the, she is now the 2026 Planning Committee Chair. And so let's have a round of applause for our Planning Committee.
So then, also, we just really want to thank all of the work that the Executive Committee has done. All of the names are listed here. We're really grateful to all of these colleagues, and we particularly want to say a big thank you to Michael Hayher, who's outgoing, and warmly welcome Valeria, who's entering the committee. So maybe a round of applause for all of the colleagues who've done that.
And I have been on those calls. I have been on those calls. So. All right, then let's have a special thanks to a number of people to really help this meeting happen. And first at the top is our buddy Amardeep Gill. Gill, raise your hand in the back. Yes, so Gill. So Gill has been with us for a number of years as our IT guy. Did we start working with you, Gil, during COVID, or was it pre-COVID? Anyway, my recollection was probably the COVID. Yeah, where we had to go online, and then anyway, Gil's just been an integral part of making this meeting happen every year. And then you can, of course, there's Liz Polk, who we'll have more about to say during the course of the meeting, but she's our administrative manager, and Donna Schwartz is the administrative assistant, who you'll learn is going to be taking over for Liz as she tries to move in retirement. I don't know if we're really going to let her move completely. And then a number of other individuals who were really key to getting this meeting happen this year. So what's next?
So we're really delighted to specifically mention all of our sponsors. We're really grateful for the partnerships with all of the sponsors. So we're just going to specifically go through and thank them. I would strongly encourage you to engage in discussions throughout the meeting with all our sponsors who are central colleagues in this meeting. So the platinum level sponsors are Avidity Biosciences and Johnson & Johnson.
And then we have gold level sponsors, Alexion, Arginex, Catalyst, Merck, Sanofi, Sarepta, and Scholar Rock. And our silver sponsors, Cartesian, Immunovant, and NHTI. And then I guess there's one more, and we'll...
The bronze level sponsors are all listed here, so thank you to Dyne Therapeutics, NMD Pharma, Solid Biosciences, ML Bio, Amgen, Caverna Therapeutics, Optpharma, Lupin, GBS, UCB, Arthex Biotech, and PepGen Bio. So, I mean, it is a dramatic change compared to even 10 years ago, the level of engagement, which is really crucial for us to actually take drugs into clinic. So I think we should...
So can all the sponsors, everyone who's affiliated with one of the sponsor groups, please stand up so we can acknowledge you and give you a round of applause.
That's good.
Yeah, thank you all very much. This meeting has grown because of your involvement in it, and we really appreciate it. All right, so a few years ago when we started this neuromuscular journal, thank you, Gil. A few years ago when we started this neuromuscular journal, we started publishing the abstracts from the meeting in the journal, and so once again the abstracts were published, I think about 10 or 14 days ago in this issue. I want to point out on this on the cover is this amazing painting of Lake Maggiore that Donna Schwartz found for me online, and it's a painting by Sanford Gifford, who was a New York Hudson Valley artist from the early 1900s, and he loved Lake Maggiore, so he painted this, and it's in the Met. And the issue came out, and John Katz told me yesterday, he grew up when he was going to the Met, he always would see this picture and he was in love with it, and then it ended up on the cover of the journal. So I thought it was a great image to kick off the volume in this meeting. And there's something about the QR code I missed on that. So you can, to have it electronically during the meeting, there's a QR code at the staff desk where you can have access to the journal. And if you're not signed up to get the journal, please do, because when you do, then I can use you as a reviewer. So, thank you.
So, just to highlight that the meeting is accredited for international continuing education. You should have received the disclosures and link for the evaluation to complete. And we also offer certificates of attendance so that it can be recorded in your continuing education portfolio. Okay. And then finally, the housekeeping slide. Restrooms upstairs, good to know. Water and coffee all day in the gallery room. Oh, sorry about that. Speakers. So give your slides on a USB drive to Gil, who was just waving his hand in the back. He's the one that you give your slides to. If you have a question after a presentation, raise your hand, and one of the staff will bring a microphone to you. If you have a question not related to the presentation, again, ask the staff at the table outside the conference room. And then hopefully you've all figured out the NMSG special access password, which took me a couple attempts to get, but it works. So, and then finally, I think we skipped that slide. And then this is the last slide. So I've been told by Liz and Donna to phonetically pronounce andiamo, okay, and which means let's go. Andiamo means let's go. So that's it. So I think we're out of here, Mike, and we'll turn it over to Valeria and Emma. Are going to make some comments. So thank you all again for coming.
So we want to extend a very warm welcome to all of you, and we hope that you're going to enjoy the program that we put together. We just want to do a very quick highlight. So today we have the gene-based therapeutic platform presentation, the flash presentation, clinical trials unit set up, and the young investigator session. If you're presenting a poster 6 to 8, make sure that you have your poster up and ready to go by 5 p.m. You can use any board, front and back. There is no number assigned. And make sure that you remove your poster right after the session, otherwise they're going to be disposed. And then, very important, there will be a group picture in the rotunda right at 8:05, so don't miss that. Dinner in the new Liberty Room, and then reception in the hotel bar. The highlights for tomorrow, the general session will have AI health session, regulatory requirement for both both sides of the pond. That's going to be very interesting. New clinical phenotype and industry updates. At 6 p.m., don't miss the NMSG fellow presentations. And then very important, especially this year, since unfortunately this is the first year the Burt Griggs won't be able to be here, unfortunately, the esteemed Professor Valeria Sansone will be giving the Robert Griggs keynote lecture. We're very much looking forward to that one. If you are registered for the gala dinner for tomorrow night, Saturday, be ready to meet the buses at 6:45 right in the back entrance of this hotel. And there will be an aperitivo at 7, hopefully with the sunset. Liz has guaranteed that there will be a beautiful sunset tomorrow at 7, and then followed by dinner and a reception. That should be a really nice event. And then Sunday, the general session will have the Young Investigator Project, the Shark Tank, caution in the interpretation and conclusion of some clinical trials. I think that new this year is that the audience will be able to actually score the presentation for the Shark Tank, which will be adding, I think, a very nice feature about the brainstorming. And then at 12:15, we'll conclude the meeting with the announcement of the Shark Tank winner. Again, I encourage everybody to networking with colleagues, especially the young investigator, and definitely with our sponsor. It's important that in your badge you're going to have a pink ticket if you sign up for the gala dinner for tomorrow night. Actually, that's the green ticket. The pink ticket is for drink, and you're allowed one drink, but if you want a second drink, you will have to introduce yourself to Professor Hanna and Professor Barron and beg for a second ticket. So enjoy the meeting and the beautiful Stresa, and we're glad that you're here.
And just welcome to Italy.
You're going to introduce me?
Good morning, everyone. I'm Sophie Rengarajan. It's a pleasure to introduce Dr. Zaidman today. He's a professor of pediatrics and neurology at Washington University in St. Louis. And he's had an instrumental role in driving care of neuromuscular patients forward. So it's a great pleasure to introduce him today, and the title of his talk is very timely and entitled Management of Selective Adverse Events Following Delandistrogene Moxeparvovec Gene Therapy for Patients with Duchenne Muscular Dystrophy. So please join me in welcoming Dr. Craig Zaidman. Thank you.
Good morning, everyone. I can't tell you how excited I am to be here. Thank you so much for inviting me. This is a great honor. I'm looking out over the faces I know, and I can't believe I'm up here. So thanks very much. I have a few relevant disclosures. The main one is I had a lovely breakfast and slept very poorly. I'm going to try to stay awake at least for the duration of my talk. I want to recognize my colleague, Natalie Gedeker. She works with me as the co-director of our clinical trials group. Some of these slides are hers. Listed up there is a slightly outdated version of our experiences with gene therapy, and some of these things just come from my own experience, and I'll try to point those out as I say them. So the talk is about adverse events of Delandistrogene Moxeparvovec, but in putting it together, I realized I needed to include something about Zolgensma in here as well. So I'm assuming that most of you know what these are, but I'm actually not really sure how many of you have any practical experience with this. I'm assuming most of you are adult neurologists, and so forgive me if the talk sort of meanders up and down in terms of what's relevant for your own experience. But I wanted to point out a few things which hopefully you all know, which is what these drugs are made of. These two particular drugs are intravenously dosed. They're one-time infusions, and I included in here what the doses are, and that's relevant When you're treating neuromuscular disorders, the doses of these medications are much higher than for treating other things such as hemophilia, and obviously much higher than if you're doing an intraocular injection. If you're doing an intrathecal injection, for instance, the dose can also be lower. And because the dose is so high for these medications, we have the privilege of experiencing some of the side effects that are likely augmented or worsened by the very high doses. So dose is important. The type of capsid that's used is also important, and as examples, these two products use different capsids. They're both in the AAV family, but they differ from each other. That's important to also understand because a side effect from one medication may be slightly different or entirely different from another, and the antibody titer that one uses before you give this also depends on which capsid you're administering. So the antibodies are capsid specific or drug specific, and that's also very important to understand. And inside the capsid is the transgene, which of course produces the desired protein. That's different for each medication. And the promoter also is different for each medication. So the promoters are designed to drive production of the protein, and ideally they are, in addition to the capsid, are sort of target specific. So they should turn on where you want them to turn on. They should go where you want them to go. Of course, these things are not perfect. So these are the things to keep in mind when you're talking about the adverse events that one sees, is that each drug really is different in these ways that are unique to these categories of viral vector-mediated gene transfer therapy. And I wanted to highlight that specifically here related to drugs that are in development, or in the case of the Elevidys product that are US FDA approved for use, so that you have a chance to just see visually how these drugs are both similar and different. They use a variety of different AAV serotypes. They each have a different promoter, and the transgene product also differs slightly from each one. And it's entirely possible that we will have a different adverse event profile from one drug compared to another, which makes sense when you think about it. But when I'm working with residents, they see patients of mine and they come out of the room and say, well, you know, Jimmy got gene therapy. And that just drives me crazy, you know, because you can't just say that anymore. It's kind of being like, we put them on an antibiotic. And if you were an infectious disease doctor, that would drive you nuts. So that's kind of how I want you to think about this as I'm going through the things that we've experienced. It would be foolhardy of me to come up here and be the first speaker talking about adverse events and not spend at least one good slide talking about candidate selection. Safety of these medications really relies on optimal candidate selection. In the case of Elevidys, that includes knowing exactly the genetic mutation, and the label, the FDA label, excludes exon 8 and 9, and I'll show you the patient for which that exclusion was derived. We also, and all of us who give this, you check baseline labs, and one of the things to look for is what the heart function is. These drugs do involve the heart, and if you have reduced heart function, that puts you at some theoretical risk for not tolerating an adverse event involving the heart. We check hepatitis labs, and depending on your situation, you have to be very astute with that. For instance, if you're treating a baby with Zolgensma who was born to a hepatitis B positive mother, and you don't know what the baby's status is, or we had a baby hep C positive mother, we had to delay administration of Zolgensma until we clarified that the baby itself wasn't affected with hep C. So it really is very situational what's relevant. This issue of not having any recent vaccines or infections was super annoying during the clinical trial. The clinical trials exclude any illness within 4 weeks of drug administration, and we're trying to give this drug to kindergartners during the winter flu season, and every single mom said, well, he just had a runny nose 2 weeks ago, and we got this whole thing lined up, you know, with like the next 9 months of visits already scheduled. But I think it's real. You don't want to have been recently ill before you give one of these medications, and I'll get into why, and that includes recent vaccinations. And then the last things there, I mentioned the antibody titers already, which are specific for each product. And then the communication and reliability component in the local labs is essential. I'm going to show you a slide of what's recommended for monitoring, and you'll get a sense of the commitment involved here from not just your care team, but the families that are getting these medications. So here I have two nearly cut and paste papers that discuss how to manage these selected vents or how to monitor after giving gene therapy. I'm fortunate enough to be an author on both papers and embarrassed to tell you that both papers say something different. So that's a bit of an awkward position to be in. So I just put them both up here. The one that looks like you're following a study protocol is the more recent one. It was organized by the MDA. I'll kind of just let you peruse it while I'm talking rather than go into each of the details. But the bottom line here is you need to do monitoring of the liver, you need to monitor the troponin levels, you monitor cystatin C, you need to know what the heart function is before you give these drugs, especially in boys with Duchenne, and increasingly I'm become convinced that means a cardiac MRI, although an echo is fine. You need to know the platelet counts, and then there's a whole list of other things on the table there, most of which are involved with monitoring for complement activation and other risks such as HLH syndrome. You can see this is a big commitment, and you can imagine being in a rural community where it's hard to get labs, and now you're taking either a baby or a difficult to stick boy with Duchenne trying to get this done. So this is a all hands on deck sort of endeavor. And here are the common adverse events following Elevidys, and I listed up here also just so you can look, for Zolgensma. And, most of what you see is vomiting or nausea and vomiting. You can have fever, and then you'll see high on the list from both medications is involvement of the liver. We're going to spend a little bit of time talking about that, but Dr. Dawan after me is also going to specifically address it, so I'll kind of get through it. I'm going to talk about some very scary sounding things, but I want to point out, at this point, I think it's over 900 patients have been treated with Elevidys, over 4,000 have been treated with Zolgensma, and a lot of what I'm going to talk about are exceedingly rare side effects, but frightening nonetheless. Here's the list of categories of side effects one can have, and you can see the liver, the GI. We're going to talk about thrombotic microangiopathy. We're going to talk about elevated troponin and myocarditis, and we're going to talk about immune-mediated myositis. Just recently, there's been some allergic reactions that have involved needing to stop or slow down the drug, and that's a big deal because you can't give this drug twice, at least not yet, because you develop antibodies once you've seen it. So if you have to pause the drug, you don't want to wait, we don't know how long until you want to restart it. What's kind of cool in a way is that the side effects follow a timeline, and the timeline in which they happen tells you an idea about how to treat them. So of course the allergic reaction happens in the first day. This is different from enzyme replacement therapy. This is like you get a fever, a little bit of an allergy. You don't get a full-blown drug rash, at least not to my knowledge. The vomiting happens very early, often the next day or the day after. The myocarditis can happen the next day, but it's within the first week. The platelet count usually drops in about a week. And then the liver and immune myositis happens later, so 4 to 8 weeks afterward. And that is probably because those problems that are happening early after treatment are related to the innate immunity or to complement activation, and the problems that are happening later are related to acquired immunity. And so when you're thinking about how to treat these things, that's sort of the idea. You want to treat the innate immune response or something that works in that category for the early side effects, and you want to treat the B cells or T cells. We think it's mostly T cells when you're treating the later effects such as the liver or the immune-mediated myositis. Included in here is the duration in which these adverse events are reported, so it sort of gives you a nice visual, I think, of these clusters of early and late. So how do you do that? Well, it actually pretty simple. You just give them steroids. Steroids is your first thing. It works very quickly. You can use it for all categories. Your patients do need to start steroids before they receive these therapies, at least a day, and if they're steroid naive, as long as a week before. They're going to be on steroids every day for at least 2 months, usually 3, often longer. It's usually around 1 to 1.5 milligrams per kilogram per day with a max at 60. For you adult neurologists, it's 60. And because we have steroid alternatives in Duchenne, like deflazacort or vamorolone, we don't really know how those impact the immune system. So prednisone is what we're talking about. So when I say steroids, I mean prednisone or methylprednisolone. And when you have complications, the first thing you do is increase the steroids, and we'll talk about sort of dosing for that. And then I have in here a comment, you want to avoid missed doses. And that's relevant because a lot of these kids have vomiting. Briefly, I need to talk about the hepatotoxicity, but I'll go pretty quickly through this. It is among the most common adverse events that you see following this. Almost all children with Zolgensma will have some increase in their AST and ALT, 90%, although it's the vast majority, 10 or 15%, in which those elevations are higher than 3 times the upper limit of normal. So usually it's a small bump. We don't know the long-term effects of this, but my experience has been that once the liver recovers, it recovers and you don't have to keep thinking about it. The issue is that 2 children with Duchenne recently reported died from a very rapid liver failure. So they didn't have just transaminitis, they had liver failure, and that liver failure came on really quickly. And the way in which you could tell it was happening was that their bilirubin went up. And so you need to monitor the LFTs and the GGT, but you also need to monitor the bilirubin. And if the bilirubin is climbing, you're in trouble. And these boys, what's scary about it is that they were both recognized with good monitoring and had excellent care and died anyway. And that's really kind of what the frightening part of it. 2 children have died after Zolgensma also. I know the details of those cases a little less well, but they also were receiving good monitoring and routine relevant care, including recognizing it was happening, also died. So I include this slide here, which I know Dr. Dawan is going to discuss this, but I just want to mention, since I am an author also on these recommendations, the first line of action is to increase prednisone to 2 milligrams per kilogram when the liver enzymes start to rise. But I have changed my own practice pattern because these boys are already nearly on 2 milligrams per kilogram per day anyway. They're on 0.7 or so. At baseline for Duchenne, you add 1 mg per kg in preparation for the gene therapy, so they're nearly at 2. So to bump them to 2 really doesn't do it. I'm bumping them closer to 5 because I'm nervous. So I kind of wallop them right away, and I check labs at least twice a week. So I make a kind of a big change and check it quickly. That's my own practice pattern, and I'm sure there's variability there. And here's an example of what it looks like. It's very scary when it happens. The AST and ALT in the yellow and brown go up, the GGT goes up, AST usually goes up first. And I have this slide here because you can see they all go down again, and then you see the AST, ALT go right back up. And that's when we admitted the kid to the hospital, we gave him IV methylpred, everything dropped, and then we put him back on oral steroids, and he went home. And you see the AST, ALT go right back up again, so you think, oh, it's just rebounding. And rebound does happen, but you see the GGT barely moves, if you see there on the bottom. And that's because when these boys go in the hospital and they lay there all day, their CK goes down. And when the CK goes down, the AST and ALT will go down. So the AST and ALT also come from the muscle, and many, many people forget that. I know you all know that, but you have to trend the CK. If the CK goes down and the AST and ALT go up, it's the liver. And the GGT is your friend, because that is just the liver. So vomiting, that's the most common thing that we see, and vomiting's pretty easy, actually. You warn them about it. You just give them some Zofran. It's very responsive to Zofran. For whatever reason, in Elevidus, they tend to vomit first thing in the morning, but they don't have anorexia. So they wake up, they throw up, they eat breakfast, and they go to school. But it's like annoying for everyone in the family because you have to clean it all up. So you give them Zofran prophylactically. We have had a few kids with prolonged vomiting, 2 or 3 weeks of everyday vomiting, and we put them on scheduled Zofran. You need to be aware of the risk of a long QT, so it's nice to know what their EKG is before you put them on that. The main issue with vomiting is you need to redose the steroids. You don't want to miss the steroid dosing. And if they can't keep the steroids down, then they got to come in and you give them IV steroids. So that's simple enough. Here's a Zolgensma-associated vomiting case. This little girl here, 7 months old, one of the last patients I saw who did not get newborn screening. She was born across the river in Illinois where they weren't doing newborn screening. We were doing it in Missouri. Very unfortunate. We treated her with nusinersen first and then Zolgensma for a variety of different reasons, and she developed some pretty bad vomiting. Had to go to the emergency room. She was dehydrated. They gave her IV fluids. They gave her a bolus of methylprednisolone, and we sent her home. Vomiting went away for a day or so, but then came right back, and it was a lot of throwing up. She was really intolerable, irritable. And so we brought her back into the hospital. I mean, what else are you going to do? And it turns out, actually, she had developed proteinuria, she had hematuria, she had thrombocytopenia. And she didn't have vomiting. What she had was thrombotic microangiopathy, which is a complement-mediated activation syndrome. She was hypertensive. You can see there, it might be a little hard to tell, but if you look at her ankles, you can see where the band was around her left ankle. She's swollen. You see her cheeks and face look swollen. I have her eyes covered up, but they're nearly swollen shut. Turns out she had a UTI, probably didn't have a UTI, honestly, but she had a positive dirty urine. And she was pretty sick. We had to give her packed red blood cells. We gave her a dose of eculizumab, but it was probably too little, too late. We gave her a lot of steroids. She has ongoing hypertension. I just saw her. She's in first grade. She got her spinal rods put in. She's got hypertension again identified in the hospital after a very slow wean. She probably is predisposed to hypertension. I think it's true and unrelated. I don't think it's related to the TMA. It's really hard to know. She did recover. She survived. But not everyone does. There have been 2 reported deaths from thrombotic microangiopathy related to Zolgensma, and you can get this from the drugs for Duchenne as well. The Pfizer product had 3 children in the phase 1B, and then less commonly in the phase 2 trial developed thrombotic microangiopathy. And it's worth mentioning, unless I'm getting it wrong, that Elevidys hasn't had any cases of thrombotic microangiopathy. So thinking back to that first few slides I showed you with the differences in the drug product, Elevidys, for whatever reason, hasn't experienced this. I have in here the list of the details, and you can see in here the recent infections and the recent vaccinations, and so that's the reason you don't want to give this to a child who's been recently ill. We think it might prime them for this, and I would readily admit that we don't know about candidate selection to reduce the risk of thrombotic microangiopathy. And I don't want to miss the chance to talk about Jesse Gelsinger, who died from what sounds an awful lot like a complement activation syndrome 20 years ago for treatment of his ornithine transcarbamylase deficiency. He probably developed like a hemophagocytic lymphohistiocytosis picture. He was jaundiced very early. It's also a complement-mediated phenomena, and he died very quickly. I'll let you read about it while I have it up there. Seems like a great young man, very sad story. Was into racing bikes, apparently. He died really fast, and that's what's frightening about this, is it's not all about just knowing it can happen, because once it happens, it's really hard to shut it down. I think we just get lucky that some of them survive and some don't. And so what is it that we can do about it? This is a bit of a complicated slide from Barry Byrne and his team, but the long and short of it is they have had experience with a lot of different trials in gene transfer therapy for a variety of different disorders, some experimental, some not. And I think out of happenstance in the different protocols, about half of their kids have gotten rituximab and sirolimus as part of their pre-treatment protocol, and about half of the kids did not. All of the kids got steroids. The kids that got rituximab and sirolimus are represented in red, and what you can see is that they have a reduced rate of antibody production, and that the IgG and IgM don't go up as much, and then the slides over here all show you that the complement-related things and the thrombocytopenia all are lessened. So that may be a way in which we can reduce the risk of these complement activation syndromes. And here is Sarepta's approach, which is to add sirolimus in order to try to prevent the liver failure, which has recently happened. And I include this slide to demonstrate that in the green bars, gene expression actually goes up. And this is in an animal model, and the liver enzymes don't seem to increase. So adding sirolimus and or rituximab might be helpful. And then here is Solid's approach. Solid also had a lot of thrombotic microangiopathy, and they changed their capsid, and they also changed the manufacturing so that most of the capsids had gene product in them, and they have not experienced any thrombotic microangiopathy in their first 15 patients, where previously they had had 2. So these are some ways to try to avoid it. So is it vomiting, or could it be myocarditis? Here's an 11-year-old with an elevated troponin, which was incidentally discovered when he started throwing up after getting a levatus. And nothing else was wrong with him. And this is the kind of myocarditis that we've seen. And you can see there on the graph 2 cases. It happens very quickly, but you see the one in the middle, there's an elevated troponin that happens long after gene therapy. And that's because troponin leaks in boys with Duchenne. And you can see that here, lots of elevated troponins, most of it at the lower levels, but some really gets high, including in the placebo group. So monitoring troponin is tricky in Duchenne because it leaks out of the heart. Of course, if you have symptoms like vomiting, GI distress, fatigue, chest pain, you need to check a troponin. It can be pretty subtle. And here's some examples. Elevated asymptomatic troponins in Duchenne also happens in SMA, funny enough, probably because it is present in infants. You can see the blue dots are very high in infants, probably related to birth. So not all troponins are the same. Troponin T comes from muscle, and not every outpatient lab can turn around a troponin very quickly. So if you're having people get checked at Quest or LabCorp or wherever, you need to know the turnaround time before you treat them. And if you have an elevated troponin, what you should do really depends on how high it is. This is a busy slide, but it's very simple. If your troponin is over 3-fold increase, you need to do something. Bring them in, get an echo, get an EKG, and if there's any changes on the echo or the EKG, you need to be more serious about it. Remembering that they're at risk for arrhythmia, more so than reduced cardiac output. So it's not all ejection fraction. It's risk of arrhythmia with an inflamed heart. I think I'll skip this one. So here we have a 7-year-old after getting a levatus, and he was improved 4 weeks afterward, walking up hills, and then he got worse. And you can see the slower steps there is after treatment, about a month later. He had an exon 8-9 deletion. So this was a relatively abrupt, subtle decline. And it turns out that he had developed immune-mediated myositis. We were on the watch for this because he's in the at-risk genetic category. What's unusual about this is the CK may not go up. The lips can swell. So you need to be aware of that. And they get weaker pretty quickly. And they need to be admitted to the hospital, and they get aggressive support. It's probably a T-cell mediated phenomena. So IVIG, plasma exchange, high-dose methylprednisolone, and tacrolimus. He improved. These are the 5 original descriptors, and you can see the bar of their common deletion overlap, which is somewhere between 8 and 12 in terms of their exon deletion. And here is the expanded version of that, where some kids with 8-12 deletion don't get it in the pink, all those boys in the red, that's their deletion syndrome. So we think this is a response to the transgene product, not complement activated. It's a T cell. I'm almost done. Sorry, 1 minute over. I knew I would do it. So here he is, got better. And this is the last thing I want to tell you. A year later, I weaned his tacro, and he got worse. We had to bring him back in the hospital, and he also developed myocarditis. So you have to think about these things for a really long time. He's back on sirolimus. He's doing better. And here is my closing slide, just so you can review everything I had to talk about. And thank you.
We have time for one question.
Sorry, I always go over.
And if there are no questions, my quick question is, where are we on the state of predicting which patients might be at risk for specific adverse events?
Yeah, the risk is you got to know your antibody titers, you have to know their genetic profile, and you don't want them to be sick. I mean, I think beyond that, I can't tell you.
Oh, one more question.
So, Greg, great talk. So, at least in the adult side, when we do gene therapy, there has been, most of the companies are now thinking of not only having steroids, but adding tacrolimus. And somehow tacrolimus seems to be the preferred immunosuppressant over all of the others. Is there a difference other than the side effect profile between tacrolimus and sirolimus in terms of how you do it?
Yeah, I don't know the answer to that. I mean, they work slightly differently. Sirolimus is an mTOR inhibitor, if I'm remembering correctly, and Tacro is a FKRP. I can't remember. They work slightly differently. I don't know why Sarepta picked sirolimus. I picked Tacro, and then I had to switch because he developed some problems on Tacro, so I switched him to sirolimus. I don't have a personal opinion about it. I'm sorry. I wish I knew the answer to that. I don't.
Thank you so much, Dr. Zaidman. So our next speaker is Dr. Anil Dhawan. He's a professor at King's College Hospital in London, where he is a pediatric hepatologist, and he also runs a lab where he investigates the use of hepatocyte transplantation for liver injury.
Thank you
Please
very
join
much.
me in welcoming.
Ladies and gentlemen, so I'm an imposter. I have nothing to do with neuromuscular disorders. Only time I see neuromuscular disorder when somebody, and that happens once a year, sent a patient to me with elevated liver enzymes because they think something wrong with the liver. Then I say, not really, need to see a neuromuscular person because there's something wrong with their muscles, not with the liver. So that's my DMD experience. So the reason I'm here today is 3 years back, I was rabbit under the headlights. I got a call, oh, we have treated somebody SMA. First of all, I need to understand what SMA means, and his liver enzymes are elevated, and this is yours now. And I have no idea, okay? So then we said, okay, well, we have to take it forward. So these are my disclosures. So what I'm going to do over this 15 to 18 minutes is, I want to introduce you to what is the liver dysfunction associated with gene therapies. There are broader gene therapies, okay? What do we know? Why do we think it happens? And what can we do to change it? However, we all start with, histories. Medicine is hundreds of years. We have a data over data over data. Here, I have no data. I was given to say, this is yours now, okay? Now, then I looked at it, what are the problems? Okay, the animal data which the companies produced didn't show hepatotoxicity, okay? No surprise. Every company used a different immunosuppressive protocol, so no similarities. Everybody shies away from a liver biopsy, but they want us to answer. You can't do it. There's no systematic post-marketing data collection. After drug is licensed, you're on your own. There are no unified protocols for liver toxicity monitoring. And there is, even in the clinical trials for toxicity, if you read it, liver toxicity management is left to the local gastroenterology skills, which may vary from, as you know, in any institution to institution. So these are the caveats before we go any further. But liver is a wonderful organ, okay? Liver is the second organ in the body that sucks most of the blood. So when you put anything into the vein, it's end up going to the liver. Liver also has its own immune system. Its own immune system, Kupffer cells, and it can make you tolerant. So that's one positive side of liver. When you give gene therapy, some people think their gene products could become tolerant. So liver become an innocent bystander when you treat somebody. We have gene therapies for liver disease, which I won't be talking much, but when you do a gene therapy with an intravenous injection, liver is an innocent bystander, but a serious one. As you heard from the previous speaker, there has been some deaths reported. Okay. So what do you expect out of a liver when gene therapy is given? What can happen? You can see mild elevation of liver enzymes, and I will show you very common. Okay. Less common is jaundice and prolongation of prothrombin time. So if that happens, then you really need a liver doctor. Okay. Mostly they will get better with increasing steroids. We will come to sirolimus, tacrolimus, and other big guns. Okay. It is uncommon, but not unreported. There are several deaths. And the problem is now, I'm going to be contentious, the deaths that are reported, that are in literature, there are deaths that I got a phone call from corner of India, from Middle East, from Russia, from Kazakhstan. They are not reported. I know that. Some of them, my other colleagues will be getting it. So that's a problem. Now, this slide just gives you an idea that liver disease, liver involvement could be fatal. Okay? But this is the reported data, and most of the trials have reported deaths because of the liver involvement. It does not include recent fatalities from other treatment trials. Okay. Now, we had a previous speaker elegantly spoke about, how to risk assess it. In gene therapies, unfortunately for some of your patients, I will give you an example, liver disease appears to be part of the disease process, and that is a high-risk situation. Then the injury from gene therapy comes, which we believe is more or less immunological, and then we think we know how to deal with it. X-linked myotubular myopathy, I only got introduced to it a few years back. But when I found out that they have a myriad of liver dysfunction, which we can't put it together, so we did some lab work looking at what could be the presentation, but they vary from mild abnormality to severe liver disease. Unfortunately, the disease is so bad, they needed to do something. So even 90% of the patients had abnormal liver test when they went into the trial. So unfortunately, the trial did suffer one after the other setbacks. And this is one of the disease where more than one attempt has been made to go back and restart, stop, restart, stop, restart. And that's because of patient selection has been a difficult problem. 3 deaths in this one of the very small group of patients they treated. SMA you already heard, and the biggest experience in my experience is SMA, and they have an invariably elevation of liver enzymes. Up to 60% will get elevated liver enzymes. Most of them respond, but 10% become the difficult ones. So now we know that irrespective of whatever capsid, whatever virus, whatever carrier you're using, there is a variable degree of liver involvement. And the next question comes, so why does liver get affected, excluding the patients who do have inherent liver disease like XLMTM, okay? Take that off, but if you're speaking of children like DMD who do not have liver disease, or SMA who don't have liver disease, okay? So now this is all thinking. I don't think there is a lot of data on it, okay? We believe that there are both the capsid, the genome, and the transgene product, all 3, which you saw in the previous speaker's talk, they contribute to the innate and the adaptive immune response activation. And I'm going to just test you for a few seconds, your attention span, in the next slide. Okay? Now, you don't need to just look at these slides and look at 2 things here. There is a number 7 and 8 is humoral response, which is predominantly B cell. And then you're looking at 5 and 6, this is cytotoxic T cell response. And then you look at 1, 2, and 3, that's going to be your innate immune response. Okay, if you remember that whatever we are giving is causing activation of innate and adaptive immunity. And now, how do you address that? Now, if you do a liver biopsy on somebody, which is liver disease that we know because of what? So this is a a normal liver tissue. Okay, now you say it all looks the same, but if you look a bit closer, there is a bit function difference. So what you start seeing is these cell populations, this blue and the red, they keep coming. Now, if you look at from a distance, and even for me, they have similarities. And the similarities are, this person had a liver transplant, okay? This person has autoimmune hepatitis, this person has a gene therapy for SMA. Okay, so there are similarities at the level of what's happening to the liver. Now, once we know it, that they could cause this, what can we do to avoid it? So the risk mitigation for these patients, how can we avoid it? Previously, speaker said it, very nicely. You need to exclude, a sneeze, a cough, a virus, everything you can minimize, you should be doing it. Baseline test to see what is the baseline situation is. So that's not your job because drug companies already done that screening for you. Okay. Now this slide may not be coming out very well, but it's an important slide which over time we have identified the risk factors. The risk factors are twofold: patient-related risk factor and the treatment-related risk factors. The patient-related risk factors are very much you can do. So higher weight children, young children, as I said, XLMTM, very high risk, genetic predisposition, IL-6, particularly polymorphism, and concomitant viral infections. So these are the risk factors which we need to minimize. Now, these are the risk factors that come with the drug or the gene therapy product that you are giving, and they will vary from type you are using, the dose you are using, self-complementary vector genome design, how much dose you are giving, and a transgene that's not supposed to go into the liver, that's supposed to go into the muscle, but create a product in the liver which liver has not seen. So these are all provoking our immune system. So all these factors are provoking the immune system, and there is what can you do to minimize it. We saw in the previous slide also, what do you do as a baseline? So this all we introduced in UK after the SMA patients were given the treatment as a treatment because clinical trial did not have much of a hepatological involvement in it. So GLDH was talked about it. GLDH we don't do routinely, but DMD people, those who are working on it, apparently they say it's a great marker to differentiate liver from the AST/ALT from the muscles. So take-home message is exclude underlying liver disease. That is the whole message. And then there are liver doctors, they do it for a living, and they will do it. Okay. Now, we believe, as I said before, all these vectors are provoking innate and adaptive immunity. So now, if you look at this slide again, these slides are from the patients with SMA, and their liver biopsies are consistently showing lymphocyte infiltration, some bile duct injury, some eosinophilic infiltrate. And these are the markers of activated immune system. Now, to introduce the concept, how we are brought in the immunosuppression, I wanted to introduce you to what happens in liver, which we think we know reasonably well. So you get a graft from somebody, it's a foreign HLA, it activates HLA class 1 and class 2, Th0 cells primed by IL-2, and you get a clonal expansion. Th1, Th2 means lymphocytes, other macrophages, and you get infiltration and inflammation, and that's where you get the damage of the organ or the product that you have given. We believe that the similar thing happens here. So if that is the parallel, how do we manage that? Liver transplantation, kidney transplantation has survived because the use of immunosuppressive agents. 1984, before 1950s, these were not possible because immune system, we did not have effective immunosuppressive agents. So now with these agents, what I wanted to introduce you to is, gentlemen ask a question, sirolimus, tacrolimus, differences, and I will introduce you to where they act, mechanism of action. So this was the old drug after steroids, but what we are mostly interested here is steroids, glucocorticoids, prednisone. Now, what you remember here is this is a shotgun. This will calm down your immune system everywhere. So macrophages, it will inhibit antigen presentation, inhibit primary antibody response, inhibits inflammation, and that's what you get when everything calms down. So steroids, no wonder they treat everything, but steroids come with their own problem. Hence, in the transplantation field, we use tacrolimus, cyclosporin, and they are the ones, they are called as calcineurin inhibitors, and ultimately what they are doing is they are stopping the clonal expansion. That is the ultimate aim from any immunosuppressive agent. So if you look at mycophenolate, which is purine and pyrimidine analogs, they also reduce. What happens here is this particular arm of the immune system is affected and you don't get expansion. We talked about sirolimus, which is again a mTOR inhibitors after the IL-2, after the calcineurin inhibitors, but we talk a little bit about side effects of this drug and why I'm cautious in young children. And there are several others. So they never made to the market, but these are the another one, antibodies. Everybody is going antibodies, these MABs and etc. So tacrolimus, you heard about rituximab, basiliximab. So these are the drugs, they will act here at the receptor level. Now, what we are going to talk now is, after this, is these antibodies can also inhibit activation of lymphocytes, ultimately dropping proliferations and decreasing immune injury. So in the transplantation field, we have two approaches. What we do is we call induction immunosuppression, while the gene therapy field is calling it prophylactic immunosuppression. So we cause induction, which you call interchangeably prophylaxis, because you sometimes start a week earlier, okay? Then there's a reactive immunosuppression that we don't use reactive, we say when the need arises. So, or maintenance immunosuppression. So prophylaxis, steroids, people have started before, a week before sometime, and continue after that. Reactive is mainly going to be when the patient gets a side effects or adverse incident. So here, the difference slightly here is we are managing something unexpected. While in liver transplantation field, we know they are going to get rejection intermittently, and how are you going to manage that? Now, in this slide, it's very busy, but again, just focus on the left and the extreme right, okay? Left is innate immunity. Steroids will calm it down, okay? Acutely, all the inflammation will go down. If you go to the adaptive immunity, that predicts the long-term outcome. And you need to calm that down, and for that you need the drugs like here, which is sirolimus, mTOR, calcineurin inhibitors, and azathioprine and MMF classes. Now, what is the literature at the moment? So this is a paper which came from China, Lancet Hematology 2022, and what they showed is they gave steroids a week before in hemophilia patients, and what they showed is it suppressed the antigen-presenting cell function, promoting regulatory T cell activation, and most of their patients didn't require much. So this is a unique paper where immunosuppression was minimal, just steroid for a few weeks only. So very lucky patients and the doctors. This is a paper on Crigler-Najjar syndrome, which is a liver disease, or not liver disease, but seen as a liver disease, where gene therapy was used. But if you see, most of these patients had sirolimus and prednisolone as a continuous therapy. But they're going up to 2 years, and you see the response is not consistent. So they're losing the effect as the time goes by, despite sirolimus on the board. So if you were to use reactive immunosuppression here, so currently, steroids is the mainstay, okay? But most of the companies or the new products are using tacrolimus or sirolimus at start, not waiting for something to happen. And then if things go wrong, then we introduce other agents at a different dosages, okay? So high dose of methylprednisolone up to 10 per kilo. So that is here, if you're looking at. But if the liver enzyme go up and the time from gene therapy goes up, then you need a escalation of immunosuppression. So that's where tacrolimus and sirolimus comes into picture. Sirolimus has got a more attraction because it's seen to be causing tolerance. It has seen to be some antiviral effect. That's why it's favored over sirolimus, tacrolimus. But the problem with sirolimus, it's still a new boy in the town. Tacrolimus has got about now 50 years of experience. Sirolimus has a lesser experience. And in my experience, young babies, young children, they don't tolerate it. They get mouth ulcers, they get painful aches and pains or neuropathy-like pictures, and hyperlipidemia. So we don't use sirolimus as a first-line drug. So we stay with the tacrolimus, hence our bias is for tacrolimus. Renal toxicity is less with sirolimus, more with tacrolimus. Here are the bigger drugs then. So when you get somebody here and is not doing well, then you can consider basiliximab, rituximab, ATG. That's what we regularly use. But they are toxic drugs also. So there is a lot in the pipe, our armamentarium, if we need to use it, if the patients are not doing well. Okay. What is our current approach? So after that happens, UK has a benefit because it's a centralized system. So we set up a central national MDT. So once a week, because you have so many new patients, and I chaired the meeting every week, and we have a unified immunosuppression protocol for all of these SMA patients in all the 6 centers that are treating SMA children in UK. What we crafted is, it's not science. It's just crafting by so-called eminence-based. It's not evidence-based. So what we did was, we said, okay, start the steroids. If it goes up, if the liver enzymes are less than 3 to 5 upper limits of normal, increase it to 5. If they are more than 20 times, increase it to 10, 20. But increasing steroids has a downside. Steroids toxicity can start becoming apparent after a few weeks. They are catabolic. These patients of yours mostly are not mobile. You start getting another loop of complications there. So hence, we introduce steroid-sparing agent within 8 weeks. If patient is not coming off immunosuppression, we introduce tacrolimus. If there is a mild elevation and you are reducing to do the steroid, then younger children I use azathioprine. And that has worked in an OTC trial also. This has helped. So we are making a tailor-made to the patients, but mainstay of treatment is a tacrolimus after 8 weeks if the things are not settling. So, ladies and gentlemen, to conclude, I think these therapies are there to stay for patients who have nothing else for them. Animal data is not very representative of what happens in humans. I think we need a better liaison between the companies or the pharmaceutical or the academics who are producing these things. Earlier on, a collaboration with hepatologists in this context to understand what more, and we need to learn from you because for us, it's a totally new field. Better immunosuppressive agents, and be careful and be selective, and it could be personalized medicine for every patient. Not one size fit me all, okay? Some may respond better to tacro, others may to sirolimus. One thing, if a message I can send, liver biopsy, everybody's dreadful. It's a relatively safe procedure, we do it for a living. But when we talk liver biopsy, everybody runs away. Can we do something else? We are not getting any information. There's no data. If you want to do spatial data on microRNA, everything, there's nothing. So we continue to shoot in dark with the fear of liver biopsy. So my advice, my recommendation would be that consider liver biopsy. It may not help the patient that you are treating, it will help the next generation. That's how we learned in liver transplantation. So if that is the message I can send, that will be really impressive. This is my lab. My main field is regenerative liver therapies, so that's why it's nearer to gene therapy, but I work on regenerating livers with liver cells, avoiding liver transplantation. I thank you very much for your patient listening.
Thank you so much, Dr. Dewan. We have time for a few questions in the back.
Hi, I have a very kind of like a geeky immunology question. So from your hepatology perspective, we're doing right now all the gene therapies based on antibody ELISAs. So basically AAV9, it's 1:50. Do you see any value in adding either neutralizing antibodies or adding other capsids, taking into account that the epitopes are around at least 50% similar around all naturally occurring serotypes?
So sorry, because this is a very, very specialized question. And I think I'm going this afternoon to another meeting in neuromuscular. They are only talking about toxicities, and there are several talks on immunologists coming in doing it. So forgive me, I have no idea. You can ask them. Yes, that's what thank you for giving me the question.
Hi, thank you for a great talk. On your right.
Oh, yes, thank you.
So I'm practicing in the Netherlands, and in the Netherlands for autoimmune hepatitis, cyclosporin is often used. Do you see any indication for cyclosporin in gene therapy-based liver injury?
Very good question. So cyclosporin is a poorer sister of tacrolimus. Cyclosporin changed the world of transplantation, but when the tacrolimus came, which is about 20 times more potent than cyclosporin, similar side effect profile, but the efficacy is lower. So the world has moved from cyclosporin to tacrolimus, but mainly for those reasons: potency, toxicity slightly better, and particularly in females, the cosmetic side effects of cyclosporins are quite distressing. If you ask me a question, exam question, can you do a randomized trial on tacrolimus, tacrolimus cyclosporin? The answer would be they will both work. But cyclosporin, slightly cosmetic and other toxicity, less potency, tacrolimus patients will do better. So in liver transplantation, head-to-head trials have shown superiority of tacrolimus over cyclosporin.
And then one more question. What do you think about the contribution of fatty liver disease to hepatotoxicity?
So fatty liver disease, obviously, a good life comes with other things also. So fatty liver disease is basically an oxidant injury to the liver, whatever there is. So that puts, for everything, patient as at risk. So when we are trying to minimize risk mitigation, that will be a factor, because a normal liver can handle an immune injury. But if the liver is already stressed with oxidative risk to mitochondria, that liver is not going to do well. And we learned from XLMTM patients. Some of them have fatty change also in the liver. Some SMA patients have some microvesicular steatosis, and they don't do well. So the answer to your question is yes. Can they lose weight? Can they reduce fatty liver before that? I doubt it. So, but the risk mitigation is you already know the risk, you are not going to do well. Like in the Zolgensma, so the bigger patient didn't do well. The weight went up, the dose went up. Here, their weight is going against them maybe, and the liver toxicity. We can stratify it. Just pure steatosis may not be that much, but if it's with fibrosis, that causes more problems. So that there are a lot of non-invasive tests now. Fibroscanning can minimize that. So in the newer MTM, on the advice in the MTM committee, we are introducing fibroscan to those patients so that we learn the natural history of those patients.
Great. Thank you so much, Dr. Dewan.
Thank you.
So our next speaker is Dr. Bo-Hoon Lee, who's an assistant professor of neurology, child neurology and pediatrics at the University of Rochester. And she's going to speak to us today about newborn screening for pediatric neuromuscular diseases.
Hi, thank you so much. So my name is Bo Lee. I am from the University of Rochester, and I'm going to be talking about newborn screening. Here are my disclosures. Okay, so I'm going to be talking a little bit about each of these disorders, Pompe, SMA, and Duchenne, and that's because they have some representation in terms of newborn screening, at least in the US. So just to give you sort of an idea, Pompe has been on our recommended uniform screening panel, which is sort of our federally recommended list of disorders to screen for since 2015. So we're about 10 years into screening for Pompe. We don't have universal screening across the United States, but we have about 49, 50 states that are currently screening for Pompe. Then we have SMA, which was added to the RUSP in 2018, and last year in January of 2024, we reached universal screening across America. And then Duchenne, which is not yet on our recommended uniform screening panel, has been nominated and recently just completed evidence review, and so we're waiting for a decision on that. But what do these disorders have in common, and why have they been disorders of interest for newborn screening? And that is that all of these disorders have a diagnostic journey or delay in time to diagnosis. We just are not that great as a society at diagnosing them early enough. And we've certainly seen in disorders like SMA, type 1 SMA, that there's a very narrow therapeutic window sometimes, and catching these disorders earlier can make a huge difference. So as a child neurologist, I cannot give a talk about newborn screening without talking about SMA. It is just too good of a story, and so you may have heard it before multiple times, but you're going to hear it again. And SMA really ushered in that era of gene therapy in newborns. No better way to tell this story than with patient examples. So this cute little couple here are Owen and Addie, and if you treat SMA, you likely have sibling pairs just like this. I'll start with Owen on the right. He is now 11 and a half years old. He was first noted to have delays around 12 months of age, and we usually have our well-child pediatrician checks every 3 months, between 3 months and 2 years of age. And so it was noted, and they said, hey, let's wait and see how he's doing at 15 months. He might catch up. He did not, and so he was finally referred to a neurologist at 15 months of age, and it takes a little bit of time to see a child neurologist sometimes, but he finally did get his diagnosis, genetic confirmation, at about 23 months of age, and so that's over a year after his delays were initially noted. He was confirmed to have 3 copies of SMN2, and then he was referred to our center to Dr. Tefaloni, actually, for consideration of starting nusinersen at the time when he was 3. And at the age of 3, he was not, still not pulling to stand. He wasn't standing without support, certainly was able to do a little bit of crawling and cruising on his knees. And then on the left, you see Addie. She's 5.5 years old now. By way of her brother, she was prenatally known to be at risk and tested and was diagnosed prenatally. Newborn screening was active at the time that she was born, so she did screen positive on the newborn screen, although we already knew. She was born at 38 weeks of gestational age. She was induced actually for maternal preeclampsia, so unrelated to her SMA, and then had an unremarkable postnatal course and was treated with SMN1 gene replacement at 6 weeks of age. And at the time, she was noted to be pre-symptomatic. I'm going to let Owen introduce himself.
Hello, I'm Owen. I'm 11 years old, and I have SMA. And I've been getting treatment for my SMA for 8 years.
And then I'm going to play one more video of him, maybe, while I talk a little bit more about him. So again, he's 11 and a half years old, in this video. He is still able to get to sitting independently. He has had scoliosis rods placement, and uses overnight CPAP for several years now. His most recent FVC was 72%. He's not required any feeding assistance, though, and he's not had any hospitalizations for respiratory illnesses or decompensation, which is something that we might expect for someone with progressive SMA without treatment. And then here is Sister. She achieved all of her early motor milestones on time. She rolled at 4 months. She was sitting by 5 months independently, walked at about a year. She runs, jumps, dances. She does all the things, and you wouldn't know that she has SMA. So we know that in SMA, particularly in those with less copies of SMN2 or 2-copy SMA, a predictor of clinical outcomes is the time to treatment. This is just a look at what we've done in New York State. We've gotten, over the years since we started screening in 2018, and on the right, you'll just see for reference the dates when we saw approval for the different treatment modalities. And you'll see that our mean and median ages of treatment have declined over the years, so we've gotten faster with time to treatment. But we've also narrowed the range at which we're treating. So in 2020, that was the year of COVID, we saw a really wide range, 18 to 94 days between treatment centers for various delays in treatment. And then more recently in 2023 and 2024, if you look at the bottom number of the range, we see 4 and 5 days of life. I think that's reflective of a couple of things. One, including that we have seen an increase in prenatal diagnosis and prenatal planning for treatment postnatally. But we've also seen that There are plans for risdiplam, for example, bridging. We saw the approval of risdiplam for all ages, not just over 2 months of age in 2022. And so that has been a strategy that clinicians are using as well. We saw early on that gene therapy is preferred by patients and clinicians. Here are two publications from 2022. The real-world data showed that most newborn screen-identified infants were getting gene therapy. And when making those decisions, parents weighed treatment frequency and mode of delivery heavily. A broader survey of screening states in the US by Dr. Zaidman's group showed this as well. And there are numerous other publications with similar findings and kind of demonstrating the success of newborn screening for SMA. So there's no doubt that gene therapy after newborn screening is a game changer, but the question is it enough? So I'm going to introduce you to Will. So Will was I met his parents at around 20 weeks gestational age. They were diagnosed prenatally with having an affected child with SMA by way of carrier screening. He was born at 37 weeks and 4 days in early 2021. I just mentioned that because we did not have risdiplam for infants less than 2 months at the time. And he was treated with Zolgensma at 12 days of life. And at the time, I mean, that was a lot of things had to align in order for that to happen. One, we had to have a prenatal treatment plan. We've already had the discussions about the risks and the benefits and what choice was going to be made. And then also, the mom texted me on her way into the hospital when she went into spontaneous labor, so I was expecting for him to come within a few days. He was born on a Sunday, which is great, because Monday, the hospital is active, running, all the labs can be sent out, and those labs can often come back within, before Friday. When you're sending out on a Friday, we hate getting newborn screen positive call-outs on Friday afternoon, and we hate that because on the weekend, nothing happens in that sense. And Dr. Cefaloni will likely talk about sort of the infrastructure needs of gene therapy, but I just wanted to make the point that, again, a lot of things have to align in order to really get rapid treatment. Here's a video of him at 4, navigating some stairs on his own, and you can see just kind of the time frames at which he achieved his major motor milestones, as well as his early CHOP intent. That's a motor scale that we use in infants with SMA. And just for reference, most typically developing children would achieve a 64 out of 64 or a max score, probably around 3 months of age. So he took some time after that to get there, and the sort of drop that you see at the end actually doesn't reflect his loss of skill, but he became a toddler and no longer wanted to do the things that we were asking him to do. I have 2 more videos. I show these for a couple of reasons. One is just who doesn't want to watch a cute video of a child eating M&Ms and gummy bears, but also because the first video at least demonstrates his fine motor delays, and I'm not sure if you can quite appreciate it, but he has a tremor. And then also to point out that this family and many families with SMA, they celebrate the little successes, and it's probably every 2 to 3 months or so that I get a video from this parent to be like, look what he did today, and we love to see that. But patients like Will, they showed us that unplanned early gestational age can be advantageous, especially if we're not met with those barriers from insurance and other sort of medical and technical reasons that delay treatment. There's a recent publication from the Australia group that showed earlier gestational age correlated with better outcomes. So what is the optimal gestational age? And I think that's a question that's not fully answered yet. I don't think we know. But we do know that the magnitude of benefit that we see from newborn screening in SMA is not going to be the same for all patients. And for some, particularly, again, those with 2 copies of SMN2, that treatment window before they become clinically manifesting is very narrow and often begins before newborn screen identification, which typically happens on average between 7 to 9 days of life is when we will get that positive newborn screen call out, at least in America. And so this cheeky little girl here, she was born earlier this year. She was also diagnosed prenatally. She, by way of parental carrier identification, I met them during the pregnancy. We talked with their OB team. She was a planned induction at 37 weeks on a Sunday. She was started on risdiplam at 36 hours of life. She did have positive anti-AAV9 antibodies, which delayed her treatment with gene therapy, but she did receive that at 6 weeks. And I wish this was a video, but it's not. But just believe me when I say that her reflexes are normal, and she maxed out her CHOP about a month ago at 4 months, and she's doing really well and looking clinically like she's not manifesting. Okay, so now if you needed convincing, hopefully you didn't, but I've convinced you that screening for SMA is a successful endeavor. We should be doing it. And here's how we're doing from an international standpoint with SMA treatment access and newborn screening. So this is a map from a 2021 publication by the SMA Newborn Screening World Study Group. And on the top, the greener you are and the darker shade of green you are, the more access to treatment you have. On the bottom, the red and orange countries are countries where there is some newborn screening to some capacity, and then the blue are places where we have treatment but no screening. This is an updated map from 2023, and what we can see is that the world has gotten greener from a treatment availability standpoint for SMA. The color coding changed a little bit for the bottom map, but we've also seen an expansion in newborn screening. But it's also worth noting that we still have regions in blue and green where we see either treatment without screening or both no treatment and no screening. So we do have some places and things that we can improve on in terms of SMA newborn screening. Okay. So there's likely there definitely is way too much to cover in a few minutes, but I just wanted to set the stage for newborn screening for Duchenne. Again, in America, this is actively in consideration for addition to the recommended uniform screening panel. You don't have to be on the RUSP in order to have a state screen for the disorder, but it definitely accelerates the pace at which states will pick up screening for certain disorders. We do have 2 states actively screening for Duchenne in the US, and that's Ohio and Minnesota. We have an active and growing treatment landscape for sure. Here are the drugs that we have and the ages that they're approved for in the US. But despite this, and I won't go through each of them, what we lack is data or even expert consensus, certainly in the infant and toddler age group. And that's going to come with challenges and considerations as we think about newborn screening and more widespread implementation of newborn screening for Duchenne. Firstly, it's a CK-based screening, likely without molecular genetic testing when it comes to implementation. Many of the pilots had obviously molecular genetic testing built into it, but that's going to be a cost barrier for many places. And when you have that, you get unintended targets. So we'll have carrier identification, adult onset, milder forms identified, as well as other neuromuscular disorders. And there's a complex genotype-phenotype correlation in Duchenne, and so we can't always predict the phenotype. Certainly can become tricky at the pre-symptomatic stage in infants. And there's a relatively long clinically pre-symptomatic period following newborn screening. I think it's not even clear yet exactly when the majority of babies with Duchenne become clinically manifest. We have an idea of around the time based on studies that are more retrospective, but we're still learning about this. And there's a lack of evidence to guide consensus, again, on who are we going to treat, what are we going to treat them with, and when. And finally, there's some limited infrastructure currently to collect the long-term clinical outcomes data that we're going to need in order to inform all of these questions. One of the things that we learned with Pompe is that newborn screening identifies late onset disease. And we started to find these quote unquote patients in waiting. This editorial, it's titled, "I'm fine, I'm just waiting for my disease." And this was in reference to the growing class of pre-symptomatic patients diagnosed as infants with late onset Pompe disease. And when you ask moms of children who are identified with LOPD at birth about this experience, they identify emotions of grief, fear, devastation, and relief. But that relief is often coupled with worry about the future. We see these same themes come up when we ask parents of children with Duchenne, but those same parents actually identify far more positive effects of early diagnosis. And I'm not going to go through all of these in detail, but you can see sort of the scope of what parents are saying they see as a positive thing that can come out of earlier diagnosis. And I think this is where we kind of come full circle back to the fact that not for lack of effort, we just haven't overcome that diagnostic delay in any of our disorders, but certainly in Duchenne. And newborn screening, I think, hopefully will reduce this considerably, but we have a lot of work to do still in Duchenne and newborn screening to figure out what that's going to translate to in terms of outcomes. And so this is an area I think that's ripe for additional study. I just have a thank you slide. Believe it or not, that top picture is a photo of Rochester, New York. And then I have my patients here, as well as our team, our pediatric neuromuscular team at Rochester. Thank you.
Thank you so much, Dr. Lee. We have time for a couple questions.
Well, very nice talk about two topics. In 2017, I asked the question and received a particular answer, but I'll ask it again. When are we going to move beyond just testing for particular disorders and just move to whole genome sequencing at birth?
So I just want to make sure I heard the question correctly, but when are we going to move from individual disorders to whole genome sequencing?
That is correct.
Okay.
In 2017, our children's hospital said 2022, and that's when they started.
Yeah, that's a great question. I think it will vary a lot by, every place will have different capacity to integrate whole genome sequencing. I think that is probably where we're headed in terms of the future. I don't know how far in the future, but with whole genome sequencing will come a lot of those things like what do we report and what do we not report, and there's also a question about consenting parents. In America, we don't consent for newborn screening, and so all the disorders are just done universally. And I think with genetic screening for disorders at birth, there's always those same sort of conversations to be had.
And what are your thoughts about in utero gene therapy, when that might happen, and any concerns?
Yeah, I think that's definitely something that is also coming. We have seen at least a case report of in utero treatment in SMA, but we certainly don't have the data and the safety profile to support it universally at this point, but it's definitely an area of interest, just kind of as I was also kind of alluding to, is early induction for the purposes of treatment, and how early is too early, when do those risks and benefits cross in a way that you shouldn't do it. I think those are questions that we still are answering.
Thank you so much.
Thank you.
And Our last speaker of the session is Professor Emma Sheffaloni, who is a professor of pediatrics neurology at the University of Rochester. And her talk today is entitled Building an Infrastructure for Safe and Efficient Gene Therapy Administration.
So thank you. This is a brief and very practical talk, so a little bit different, but I think that it speaks to what we as Center of Excellence Neuromuscular, who wanted to actually provide early access to the gene-based therapy, had to actually fight for in terms to be prepared as institution to really be able to have our patient be able to access this treatment. And we talked a lot about what goes into the medical expertise and the clinical team, but we're going to be talking a little bit more about the practical infrastructure. I apologize in advance because I think that some of the issues that I will be discussing are very specific to the US system. As you know, our health system is very different than in Europe, but hopefully there is enough shared concept also for other health system where you actually operates. Many of you might have seen this panel before. I think someone showed it at, last year at the meeting, but you know, this shows you the incredible amount of products, gene-based product and gene therapy coming down the pipes from phase 1 down into the center circle, where we're starting to really see quite a number of FDA-approved gene therapy. More recently, you know, 2 gene therapy have been approved for sickle cell. And I think that as neuromuscular champion for our diseases over the right for neurology and neuromuscular, we really need to think about this and the future and what this means in terms of us championing our diseases and access at our institution for gene therapy, because we will be in this landscape where a lot of treatments are going to come down, and how do we make our system sustainable as the number of available gene therapy keep growing. And of course, we had some disappointments recently with certain gene therapy. We certainly had some major wins, especially in neuromuscular. We've been leading the way, but there is no question that this is going to continue in terms of increased number of approved gene therapy. Many of our diseases, like, of course, SMA and Duchenne, Pompe, Rett, CMT, Friedreich ataxia, and many more. So this is an interesting survey that was carried out. What is the question that was asked was the top 3 issues that will affect your organization within the next 5 years. And these were really expert with managed care, pharmacy, pharmaceutical industry, people in academia. And interestingly, beside federal and state policy changes impacting managed care, the number 2 issue was cell and gene therapy. So this clearly is in the mind of how we're going to sustain this continued increase in number of gene therapies. And I think that really the current landscape, there are about 46 FDA-approved cellular and gene-based therapies. This is just as August of 2025. There are about 270 products in various phases of clinical trials in human, and there is a projected number of about 10 new products per year that will receive FDA approval, which really predict about 70 approved products by the end of 2027. And most diseases treated with approved gene therapies are really rare or ultra-rare diseases, certainly in our fields of neurology. And centers like ours are really expected to be the center of excellence for gene-based therapies, but we really need to proactively think about what is a sustainable business model and how can we sustain the core infrastructure and to support the clinical expertise. And the difference is really about gene therapies that, like we have heard from the previous speaker, is really the administration of gene therapy really requires an incredibly complex infrastructure of coordination across different clinical teams and expertise and subspecialties, but also your clinical outcome. We have seen how the clinical outcome of this baby treated early can really be life-changing, but in order to do so, if you don't have the right infrastructure that include also pharmacy, finance, relationship with payers and all that, that's really going to affect your clinical outcome. There is a very important issue also that we have to figure it out in our system, is how to balance the challenge of expertise and infrastructure versus universal access to gene therapy, right? Not all centers, regional centers, are able to provide this kind of treatment. So how do we balance that justice of, access and expertise? And, unlike other therapeutics that we use in neuromuscular, I think that we have heard that determining which patients are really best candidate for gene therapy is a very complex thing that we need to optimize, because we have heard about the safety issues, and I think it's really start before treatment and how to really determine who are the best candidate for this therapy. And institutional readiness really can make a difference in outcomes, and we're learning SMA that really time is muscle, and when you can treat a kid's, at 7 days of life versus, 3 months, that makes a huge difference, but it takes a lot of practical know-how. In clinical practice, these are some of the things that if, you want to create a center of excellence for gene therapy, there is a readiness, and you really need to probably start planning at least 6 months before an expected FDA approval for a gene therapy, before the launching, to really have all the ducks in a row to make you ready to go as soon as the product becomes available. You're going to have to figure out how to manage your capacity internally, your patient selection, pre-dosing activities, the day of dosing procedures, and what it takes in those 3 months post-dose. And like we have heard, that's really all hands on deck for safety. And really prepare for complication and emergency. And also, like we heard before, the long-term follow-up. This is not a one expert type of team. You cannot have just one person doing this. You really need enough redundancy in your team in order to do this in a timely but also in a safe fashion. And these are really all the components of infrastructure that's going to take you to get there. But I want to emphasize that all these different group, team, and expertise should really be on top of comprehensive care for rare diseases. Like, you're not going to be a center for gene therapy in Duchenne or SMA unless you have a well-established, also multidisciplinary program for rare diseases. So they really go hand in hand. And starting from the neuromuscular physician leadership, obviously there is, as you have learned, there is a lot of expertise that goes in. And as neuromuscular doctors, we have become also hepatologists and immunologists, and especially early on, when I will go to my liver expert about elevated liver enzyme in gene therapy, they will look at me and say, they will do their workup, but they didn't really have much to offer. So there has been a very steep learning curve. But really, the neuromuscular physician leadership is really crucially important to develop your internal protocols and the education for the teams in your institution, but also for the family. And really, this is business that is a 24/7, all hands on deck. Like you've heard, once you dose a number of patients, those following 3 months is really 24/7, and reviewing those labs and the safety. So again, you really need to make sure that you have enough coverage in your team to really react quickly to any safety issues. The patient selection and eligibility is very nuanced, and especially for individual cases and sometimes subgroups, you really have to have probably a multidisciplinary team to review in order to decide if they're a good candidate. And then, you know, the network of experienced care centers for gene therapy, we have all learned in real time pretty much from each other. So having a network of high dosing, high number centers where you are going to share your experience in terms of safety has been incredibly important, because we have learned way before things get published about safety is really by talking with each other. And then really to program and plan for how many patients can you be dosing per month and what will that require in terms of staff and facility capacity. So that's really where the neuromuscular leadership is going to be leading. The infusion side and stuff, you will find that depending where you are, most likely you're going to have to have a good relationship with your oncology colleagues, because usually the infusion centers are very heavily busy with oncology gene-based treatment. You will need to have a very proactive planning for expected volume of patient and really to advocate for your rare diseases. What we did in our institution is to preventively kind of reserve certain spots or day each month, because obviously we had high volume, for example, for Duchenne to get through, and you really will have to collaborate with those team. The post-infusion care we have heard about, you're gonna, usually what we do in our institution, we have a primary assigned physician, a nurse practitioner, and a nurse has a primary team for those 3 months post-dosing, and it's really focused on safety. And there are many issues, like if patients are traveling to a center of excellence for gene therapy, you know, how long are you gonna keep them locally to really, you know, monitor for safety? Are you gonna send them back home? Is this more of a spoke and hubs type of model? It's also important to understand that if you have dosed someone with gene therapy, can you really send them back to a more regional center where they might not have the necessary expertise if complication happens? So these are all practical issues that you really need to have. Probably it's not one model fits all, but depending where you are geographically, you will have to create a certain collaboration and infrastructure. And then, you know, like we heard before, there are not really a definite guideline for certain concepts. For example, the level of isolation and time off school after you dose somebody. And this also has to do with equity. You know, many families, they cannot isolate their kids for 3 months to stay off school because they have jobs and they don't have 2 houses to isolate the kids. And so really, how do we balance that attention to not expose these kids who are immunosuppressed to other viral infection, but also not to completely disrupt life in those 3 months post-dosing, so that we're going to limit access to patient and family that can actually afford that kind of setup. Pharmacy is going to be your best friend, and it takes a lot of coordination for dosing, because you're going to have to order these very expensive individual doses weeks in advance, and you really have to coordinate with all the preclinical screening and labs. But also storing and preparing these drugs takes a lot of space, a lot of hoods, and you know, I don't know if you've ever seen gene therapy, but it comes in vials and is based on weight. So as we dose heavier children, you know, we're talking about hours of preparation to really transfer the vials into injectable syringes. And really, this coordination between the infusion pharmacy and clinical team. And our pharmacy, you know, they've been very proactive, like I said, prior to FDA approval to be ready to go once the product is approved. Hospital administration, it's a new concept that as neuromuscular champion, we had to go and really advocate for our rare diseases and really make gene therapy for our rare diseases a prioritized service line. But really, you're going to have to advocate to hire a number of staff for gene therapy. You're going to need, prior authorization specialists, nurses, clinic coordinator, and really making a case that is this the right thing to do, and is this a sustainable plan in terms of budgeting and a business plan for creating and sustaining really an infrastructure for your team. And the finance part of all this, although, I particularly don't enjoy thinking about that aspect, you cannot be a center of excellence for gene therapy unless you understand the finance burden for your institution and be successful in making a case. You're going to need a lot of specialists for prior insurance authorization and appeals for coverage, but really this requires a single letter agreement and contracting for different payers. I know this is different in Europe. This is kind of a US specific issue, but in our situation in the States, the hospital risk tolerance is really going to dictate how many patients you can dose each month, right? If I want to dose, 5 or 10 Duchenne kids per month, my finance people at the institution say there is no way that we're going to put up, 30 millions to treat this many kids this month. So it's really, you're going to have to coordinate that. And also it depends what kind of payer mix you have at your institution. Leverage the 340B discount pricing, because these are therapy that are given as outpatient is crucially important, and it really is going to make a difference in your success in sustaining your infrastructure. So in the States, we have two options for gene therapy acquisition. One is buy and bill, where your institution is going to buy upfront the drug and take advantage of the 340B if your institution is a 340B institution. And then white bagging. White bagging is really you use a purchasing specialty pharmacy, but your institution is not responsible for any of the cost of the drug, but you're just handling the drug. So, you don't take the upfront financial risk, but you also don't get any of the reward of potential financial reward of this. Most of our institutions a buy and bill situation. And 340B, always a risk of changes right now in our federal government, but it's really a program that allows a deep discount for expensive drugs if you are an institution where you serve a large number of low-income or uninsured patients. So this is something that if you're building your gene therapy program, you want to be aware of, because that could be your financial leverage to really plead your administration to really allow you to hire more staff for your gene therapy team. And of course, this program really impacts the potential revenue generation for your hospital. So something that you definitely need to be aware. The ethics committee is something that is extremely helpful if you do run a gene therapy program. And when we had to create waiting lists and even think about setting up lottery, I wasn't familiar at all. We haven't had that issue in neuromuscular, but certainly the ethics committee can help you in how to set that up, because they're very familiar for other programs like in cancer. There are also issues with equitable access. If you do have a global program where you also treat global patients that are going to pay privately, how do you do that in an equitable fashion versus your local regional patients? How do you do with parents that refuse therapy? For example, we've seen SMA. We had certain cultural group in the United States where, you have newborn screening, you call them, and they refuse treatment. Where do you go from there, Do you go straight to a judge and impose treatment, or do you work with your ethics committee? And then really vulnerable group, and how to do that in the right way of provide treatment to all patients that deserve it, but understanding the complexity of post-dosing monitoring What do you do with certain groups of patients that, for example, they might be homeless or, have other issues of not being able to cooperate with the intense post-dosing monitoring. So ethics committee, very, very important. So ultimately, there has been a very, very steep learning curve for all of us, and sharing this knowledge has really been a good exercise. But be aware that gene therapy programs really require a wide array of resource-intensive administrative work in comparison with other treatment. And there is really a unique financial risk due to the very high cost. We're talking about millions for each dose with very variable reimbursement model. So is this sustainable as these programs are going to expand in the next several years? And programs in the United States have been usually of two kinds: the early movers that were proactively ready to go from day one, and the ones more of wait and see. And so how do you figure out access to all patients with center of excellence that might be geographically more limited? But onboarding of gene therapy really takes a whole village. And then really the regional gene therapy program leaders should really be partnered with more local provider to maximize access, but also safety, as we have heard. And how do you set up that kind of partnership depending where you are geographically? This is obviously very variable if you are in the United States versus other country. And I think that's all I have. Thank you very much.
Thank you so much, Dr. Cefaloni. We have time for questions.
Thank you, Emma. Very nice presentation. You mentioned in your program the possibility to organize at-home delivery of this treatment, or at least a program to follow up patients in everyday life conditions. At which extent GPs, general practitioners, are involved in this program, thinking about the possibility to get in touch with the reference center and to timely have the possibility to exchange experiences and the follow-up of the patients?
Yeah, so it's very tricky. Obviously, dosing needs to be done in a center that, like we show, has all this kind of infrastructure and team. But what happened post-dosing is, all these weekly labs for safety, can they be done locally and at home? Having the hub center be responsible for the review, I think that's still a kind of a variable system depending where you are regionally. I think that right now, whoever dosed this patient feels very much the ownership of what happens in the next 3 months, so it's a little bit tricky. And certainly to expect that the PCP is going to handle elevated liver enzyme, I think that at this point would be very, very unfair and not practical. But what you can find is that maybe not having the patient stay for 3 months in a big center where they get dosed, but go back home and find a way to receive the labs and monitor from a distance. Telemedicine visit is something that we have used quite a bit for monitoring, just for safety, because you don't really need to do a neurological exam. You just need to check for nausea, vomiting, and other things in the labs. But also to make sure that if they go back to their home, that there is a way to bring them in quickly if they get into trouble. And like you heard, sometimes these side effects happen very, very rapidly. And the least thing you want is a kid in liver failure that ends up in a regional emergency room where, they might not have the GI expert and the immunologist. So it's still a kind of in progress, this type of model, but I think that it's really very important. We all need to think about what is the best different model to do this safely, and also not to make the family's lives so completely miserable that, then you make it less accessible to all who deserve the treatment.
Looking to the future as we dose more patients, and we also have more patients who are kind of in a very long-term post-gene therapy era, and as new components of treatment arise, how do you envision our interactions with primary care? Do we need to build kind of a network of providers who are comfortable managing these diseases? What are your thoughts?
I think that, at least I feel strongly that we want the long-term follow-up for this patient that we treated, because that's where the field really learns about long-term, right? Efficacy, but also safety and learning about new things. So even for patients who you have dosed from very long distances, even if you can follow them still once a year to really own that kind of data and long follow-up, I think that's the best. But also to make the primary physician and the local team aware that they've been treated with gene therapy is obviously a good thing. But I think that this is still relatively new, and I think we really need to own those patients for the long term. That's the way I feel.
Well, thank you so much.
Thank you.
So this concludes the end of the first session, so we're going to break until 10:20.
So without further ado, do we have Dong Chong Duan to join us at the stage for a talk, side-by-side evaluation of systemic AAV8, 9, and RH74 transduction in human muscle. Just one second. So I'll just fill for a second. So the talks will be about 15 minutes or so, if that's okay.
Thank you. I want to thank organizer to give this opportunity to present work on comparing different AAV serotype in the human muscle following systemic delivery. So this is my disclosure. And we have heard that there are several different AAV serotypes, in particular AAV8, 9, and RH74 have been widely used in neuromuscular disease gene therapy. And for Duchenne, we have used all three serotypes. For dysfolin deficiency and sarcoglycan deficient muscular dystrophy, we used AAV-RH74. And for Fukuyama and the spinal muscular dystrophy, used AAV9. For X-linked multiple myopathy, used AAV8. So those AAV serotypes were chosen because they performed very well back in the early days of the systemic delivery in mice. But this mice AAV that works in one species works for another species. So here's an example that we delivered AAV9 to the mouse. You can see very robust gene transfer in the mouse heart. But when you switch the dog, you barely get any gene delivery in the dog heart. Clearly, there are dramatic difference between different species. So what we learn in mice may not work in humans. So to study AAV delivery, systemic delivery in human muscle, we need to have an intact circulation system so we can do systemic delivery. We also need to have a muscle that's composed of human muscle. There are several options once human muscle tissue explant or organoid. Those are composed of human muscle, but they don't have circulation system. We can also inject human myoblasts to the mouse muscle. But a lot of those myofibers will end up with fused human and mouse hybrid fibers, so not good for our purpose. Another way we're thinking maybe we can use human muscle xenograft. And in this, we're hoping human muscle can be fully regenerated, and also we're hoping that all the regenerated muscle will be composed of human muscle. So this is our thought. We took muscle from human, grafted in mice, and then let that regenerate. And this is the muscle before grafting. This is at 1 month post-grafting. You can see all the myofiber died. By 2 months post-grafting, you can see a lot of muscle coming back, and they all stand for this pink embryonic myosin heavy chain, suggesting that robustly regenerating. By 4 months post-graft, we can see the grafts packed with muscle, and there are very few embryonic myosin heavy chain, means they're fully regenerated. Here's a full view. You can see the mouse muscle on the top and the human graft on the bottom. And on the very left-hand top panel, you can see the myofiber type standing. And on the top, in the mouse, you see the green and red, the type 2A and type 2B. In the human, you can see red and blue. Blue is for type 1, and red is for type 2A. And human muscle does not contain type 2B. And on the bottom, one side is the embryonic myosin heavy chain. The other side is using a human dystrophin-specific antibody. So all the human muscle fiber are in the graft. And so we collect tissue from 19 patients and made 222 grafts. To analyze those grafts, we come up with 2 parameters. At the middle of we cut the graft in the middle of section, and we quantify the graft area and the myosin positive muscle area. And so we're thinking most time we have a large graft, you may have a large muscle, small graft, small muscle, but there are also situations that you may have a large graft area, but very few muscles. So to understand this, we come up with this new parameter we call regeneration index, so percentage of muscle area in the graft area. So this is looking at all the 222 grafts. In general, graft area and the muscle area, they correlate very well. But occasionally, you will see the muscle with large graft area, but small muscle area. So we collect the graft between 3.5 months up to 16 months post grafting. And we look at the muscle area, graft area, and regeneration index to see if our regenerated muscle will be stable. Over time, they're pretty stable. And we have the muscle from patients as young as 30 to 39, as old as 80 to 89. And all the different age group, we don't see a big difference. Initially, we thought maybe old patients will have poor regeneration, but that's not the case. And we have the muscle from both male and female patient. We don't see a difference in the graft quality. And also, we have the muscle from tibialis anterior. We have bicep femoris and vastus medialis, 3 different muscles type. They all have a similar quality. And also, those patients have a different pre-existing disease. Some of them have peripheral vascular disease, some has osteomyelitis, some have necrotizing cellulitis. But comparing those patients with or without this particular disease condition, we don't see a difference in the quality of the graft. And also, we look at the mice. So we graft immune deficient mice at different age. The youngest mice is about 6 weeks old. The oldest mice is about 7 months of age. Over the time, there's no difference in the quality. And we also graft in both male and female. We don't see a difference in the graft area and the muscle area, and also no difference in the regeneration index. And we want to ensure that our graft is indeed fully composed of human muscle. So what we did is that in a subpopulation of our grafts, we specifically graft human muscle in the GFP immune deficient mice. So if there are mouse muscle in human graft, we'll see GFP positive myofibers, and we don't see any, and confirming that all human muscle graft indeed composed fully of human muscle. And this is comparing these two different strands, either NSG, which is purely immune deficient, or immune deficient NSG plus GFP transgenic. There's no difference in the quality. And this is our thinking that we can package a virus we called AP, that's actin phosphatase, into 3 different AAV serotypes. And we take human muscle, graft in mice, and then about 4 months post-grafting, when muscle becomes mature, we can do a tail vein injection. At 1 month post-injection, we'll be able to collect graft, analyze the graft quality, and also analyze AAV transduction. And I want you to take a look at this enlarged high-power image of the graft. The green, the human dystrophin, and the blue are the nuclear, and the pink are the human lining, stay for human nuclear. So when you look at the inside the myofiber, all those nuclear have pink. They're human nuclear. But outside the myofiber, in the interstitial, we do see blue only. That means mouse fiber. So although the myofiber are completely composed of human, but interstitial may have fibroblast from mouse. So to analyze this, we design a strategy so we can quantify the amount of human tissue in the graft and the amount of mouse tissue in the graft by using species-specific PCR. And so to quantify the the AAV DNA copy in the graft, so we collect both graft side and contralateral side. From contralateral side, it only have mouse tissue, so we'll be able to get AAV vector genome copy per diploid of mouse genome. From outside, from the graft side, we get AAV genome copy number, and we can also get a human diploid genome copy number and the mouse diploid genome copy number. And from this, we'll be able to quantify the amount of AAV vector genome in the mouse tissue of the graft by multiplying mouse diploid genome copy number and mouse VG per diploid genome. So mouse diploid copy in the graft and the VG per mouse genome. And the AAV vector genome in the human tissue can be derived by total vector genome in the graft minus AAV vector genome in the mouse tissue. In the end, we'll be able to quantify AAV vector genome per human diploid graft. And to quantify the RNA transcript, it's a little bit more complex. And from the mouse tissue, we can get AAV transcript per nanogram of mouse cDNA. From xenograft, we can get AAV transcript copy number per nanogram of cDNA, but this cDNA composed of mouse cDNA and human cDNA. So we calculate mouse cDNA by total cDNA used in the xenograft, multiplied by the percentage of mouse tissue in the graft, and we can also similarly calculate the total amount of the human cDNA that used in the PCR reaction. And we can get the AAV transcript in the mouse tissue by multiplying mouse tissue cDNA used in the graft with AAV transcript per mouse cDNA. And we similarly get AAV transcript in the human tissues, and in the end, we'll be able to get AAV transcript per nanogram of human cDNA used in the graft. So to compare, we want to make sure we have a fair comparison. So we made those 3 AAV vectors. We want to make sure they're of similar quality, and this is by transmission EM, there's no difference. This by mass spectrometry, there's no difference. And this is by amount of full particles and empty particles, there's no difference among those 3 serotypes we analyzed. And also, we want to make sure that when we perform systemic delivery, we don't want to have too high a dose that get our graft saturated. We also don't want to have a too low a dose that we can't get enough expression. So we did dose response for, this is just example RH74. We've found that this dose is appropriate. You get some muscle transduced, some not. And now, so this is our finalized plan. So we have this vector package, and we have human muscle grafted, and we're going to quantify a lot of more data. So we evaluate those 3 different serotypes in graft that we derived from 5 patients. In each serotype, we have 5 patients. And in 4 of those patients, they have graft from same patient was tested for multiple serotype, and they have a different pre-existing condition, male, females. In total, we have 20 grafts that were treated, received AAV8, 20 received AAV9, and 21 received AAV-RH74. So this is looking at, we want to make sure when you compare, your graft should be of similar quality. If one graft is better than the others, then you won't be able to reach an accurate conclusion. So this is looking at the age at time of AAV injection. They're about same age. All those 8 or 9 RH74 have same graft area, same muscle area, same regeneration index, and the number of dystrophin positive myofibers is similar, and among the human tissue is similar. And here's an image showing the HE staining and myosin staining and human dystrophin staining. So all grafts we used for 3 comparison, they are indeed of similar quality. And this is what, it's a low power view. You can see that AAV8 have minimal ARC-fast positive cells. AAV9 has much more, and AAV-RH74 was also much lower. And this is high power and more ARC-fast positive cells in the AAV9. So this is looking at the percentage of positive myofibers in the graft. We can see that AAV9 was clearly much higher than AAV8 and AAV-RH74. Those are statistically significant. Don't know why they lost this asterisk. And but what is interesting is that although the positive cell is dramatically different, but the vector genome copy was only slightly different among those 2. And if you look at the transcript, this is around 100 copies. This is almost 800 copies. The transcript is much more. So per DNA copy and how much transcript do we got, AAV9 also was much higher than AAV8 and RH74. So more human muscle take more AAV9, and also this vector that produce more transcript in the context AAV9 capsid. So capsid apparently not only affect the uptake of the genome, but also expression from this genome. And so, as I mentioned, that those 4 patients, we have this different serotypes, received muscle from the same patient. We want to make sure our conclusion is not only for the population, but in the case of an individual or donor, they're also we can reach a similar conclusion. So this is looking at, you can see that this is 4 different patients, AAV8, AAV-RH74, they have low performance, and AAV9, they have a high performance in terms of ARC-fast positive cells, vector genome, transcript, and relative transduction. So what we see is not due to one particular patient outperformed, but all 4 patients that we see, we get similar results. And it has been well established that AAV8 and RH74 transduce liver much higher than AAV9. And we indeed confirm this is the case in the mouse liver, AAV8, RH74, AAV9, and 8 and RH74 much higher than AAV9 in terms of VG copy and transcript. And so in summary that we have developed this model system to study systemic AAV transduction in human muscle. And also we have developed the strategy to evaluate AAV transduction in the human muscles. And AAV9 clearly outperformed AAV8 and AAV-RH74 in human muscle. And in the liver, 8 and RH74 is better than AAV9. And I want to thank the funding through the NIH, Department of Defense, the Friedrich in Canada, Michael's Cause, Ryan's Quest, and Jackson Free DMD Research Fund. And this work was led by Matt Burke. He's a graduate student, and Yongping Yu, and she did Med AAV prep and all the xenograft. And our collaborator, Ronan Herzog at Indiana University, Ren Srivastava at University of Florida, and Gao Yang at the University of Missouri. Thank you.
Thank you very much. Any questions from the floor? Just stick your hand up and a mic will be with you. Anything? How hard are these xenografts to produce? Do you get a lot of graft failures? Do you need a lot of technical expertise?
Yeah, it's not that difficult if you have good hands, surgery hand. And in general, Yongping, in her hands, 95% muscle graft recovered back.
Okay. And one question just here.
Dr. Wan, great presentation. I have a question. Will you expect these results to hold if you switch from IV to intrathecal?
We did not do intrathecal, but we believe that IV and IM could be different. And in terms of intrathecal, and you have to get from CNS fluid to the peripheral. So it has been known that AAV9 can penetrate the blood-brain barrier more efficiently. So it's very likely AAV9 may outperform the others.
Thank you very much.
All right, thank you.
So the next speaker is Julia Hartman, speaking on the role of epigenetic regulation of DMPK in congenital myotonic dystrophy from Virginia Commonwealth University.
Hi, everyone. As I said, my name is Julia Hartman, and I just want to give a big thank you to the NMSG for allowing me to give my talk today, which is on the role of epigenetic regulation of DMPK in congenital myotonic dystrophy. So, as many of you are probably familiar, myotonic dystrophy type 1, or DM1, is actually thought to be the most prevalent form of muscular dystrophy nowadays, with an estimated prevalence of about 1 in 2,100 people, at least in the United States. And it's actually a disease spectrum. So you see patients that can present at birth with congenital myotonic dystrophy, or CDM, and we can see patients that don't present until they're 70 years of age. And one of the interesting things is that the symptoms actually tend to vary depending on the subtype. And a fun fact is that CDM was actually not recognized as part of the DM1 disease until the 1960s, just because the symptoms look so much more different than the adult DM1, than the adult DM1s. So a little bit about the molecular pathogenesis. So on chromosome 19 is the DMPK gene, and within the 3' untranslated region, there are these CTG trinucleotide repeats. And everyone actually has these, so all of us in the audience have them. However, when you get above 50 repeats, that's when it becomes pathogenic. And this is important because when the DMPK gene gets transcribed, this forms toxic RNA. And this is because those repeats, they form a hairpin structure. And I actually liken this to a sticky ball of tape. So if you think about it and you have a ball of tape, it tends to attract lint, dust, things like that. Same thing is actually happening here. But what's being kind of sequestered is really important RNA binding proteins. So one of these is MBNL, which actually has a pivotal role in regulating alternative splicing and RNA translation in general. And so you can imagine that when MBNL is being sequestered and is not free to go out and do its job in the cell, we see pretty severe differences in the splicing of various transcripts, and these have been linked to various phenotypes in DM1, such as cognitive impairments, cardiac conduction defects, myotonia and muscle weakness, and insulin resistance. And so I think one of the things that the field has done a really good job of in the past 20 years or so is looking at what is driving disease severity and age of onset. And so one of the things that obviously comes to mind is it CTG repeat length? So the more repeats you have, does that mean that you're going to have a more severe form of the disease and an earlier age of onset? And the answer is kind of. So the repeat length actually tends to overlap pretty significantly across the various subtypes. So you can see in this graph here that someone with CDM, while they can have much higher repeats, they also tend to have repeats. I've seen CDM patients that have as low as 300 to 400 repeats. Same vice versa for the adults, where they might even have upwards of over 1,000. And so we know that it's not a direct correlation between repeat length and age of onset or disease severity. And this is just, again, recapitulated in this study from Pearson et al., where it's showing that your age at symptom onset and your repeat length is only correlated with an R-squared of about 0.2. So I think the main takeaway from this, right, is that there are other factors that are driving disease severity and age of onset. So things like modifier genes, environmental factors, there could be repeat interruptions, the rate of somatic instability, so how quickly the repeat is expanding over time, and even things like epigenetics. And I think this really comes into play when we think about congenital myotonic dystrophy, right? So these are the patients that are often thought of as the most severe. They present at birth with symptoms such as respiratory failure, oftentimes requiring invasive ventilation, feeding difficulties, musculoskeletal deformities such as clubfoot, and hypotonia. But what's really interesting about these patients is that they actually have a disease progression that's unique from adult DM1. So that's a slowly progressive disease. CDM patients, they present really severe, and then they actually improve. So a lot of this phenotype tends to regress or hold flat. And what we really tend to see as they progress into childhood is more of the CNS phenotype. So intellectual impairment, autism spectrum disorder, ADHD, as well as some mild GI issues. And then interestingly, as they get a little bit older and progress into adolescence, this is when they start to resemble their adult counterparts more. They can develop myotonia, distal muscle weakness, and even fatigue. And so one of the first things that I wanted to do when I started my graduate work was look at how this is affected by splicing. Our group loves to talk about splicing, as you guys have probably heard. And so what we did is we took all the patients and we performed RNA-seq on muscle samples. And basically, to simplify this, the y-axis just shows the degree of splicing dysregulation plotted against age. And so that you can see in our children with CDM, who are the youngest, those CDM infants who present pretty severely, they have the worst splicing dysregulation down in that left-hand corner. And then as they age to about 1 to 2 years of age, it drastically improves. And our CDM children, so anywhere from 2 to 8 years of age, they actually are doing pretty well in terms of their splicing. They're not really experiencing as bad of dysregulation as the infants. And then this mimics what we're seeing phenotypically too, where as they progress into adolescence, they start to stratify more and resemble their adult DM1 counterparts. And we also have access to a few longitudinal samples from the same patients, and so you can see this kind of just recapitulates this idea that missplicing is dynamic, and it does tend to mimic the phenotype that we're seeing where they start off pretty severe, they improve in childhood, and then they really start to kind of stratify in adolescence to resemble the adult DM1s. And so obviously one of the first things that I was interested in doing, let me go back 1 second, is what is happening at that 1 to 2 year of age? Why is splicing changing so dynamically? And the first thing I thought to do was look at DMPK expression, because if you have more DMPK, potentially that is resulting in greater splicing dysregulation. And so we took the same RNA sequencing data and we pulled out DMPK, and we found that in our newborn group, so children from 0 to 6 months of age, they have much higher DMPK expression compared to their pediatric controls. The other groups weren't significant. I mean, you can see a general trend maybe with some of the adult DM1s, as well as some of our CDM adolescents. And we wanted to recapitulate this using another method. So we did PCR, and we found similar results where newborns, again, are having much higher DMPK expression. And so kind of taking all of this data together, I think the main thing that I want to highlight for you guys today, we are seeing this really interesting dynamic triphasic pattern between phenotype changes, splicing dysregulation, and DMPK expression. And I really want to know what is causing that. What is driving this? Why are we seeing such a dynamic kind of pattern? And one of the things that I thought of could be potentially explaining this was looking at methylation patterns. So the field in general has briefly looked at epigenetics, and I'll take a step back and actually, for those of you who are not familiar, epigenetics is actually when you are able to change gene expression without modifying the DNA sequence itself. So there are various kinds of it. The one that I'm interested in is methylation, so where you're chemically modifying the DNA to add a methyl group, and basically that can just block gene expression. And if you don't have the methyl group, you can actively transcribe the gene to simplify it. And so what the field has found, they've really focused only on the DMPK disease, or the DMPK gene itself, so directly around where the disease occurs. And to briefly summarize, in controls, we really aren't seeing any sort of methylation in the DMPK locus. In our adult DM1s, we see a little bit of hypermethylation more upstream in the DMPK gene locus, but we're really not seeing a ton of methylation directly surrounding the CTG repeat. And then in our children with CDM, this is where we find hypermethylation directly surrounding the CTG repeat. And so to kind of talk you through our study design, we're really lucky at Simmer. We have access to a lot of blood and skeletal muscle samples, both from adults with DM1 and from children with CDM. And so we took two approaches to kind of get at our question of looking at if epigenetics are influencing this kind of triphasic pattern in CDM. So the first one was we decided to look at global changes in methylation using MBD sequencing. And I won't bore you guys with it too much, but basically you use beads to capture anything that's methylated and pull it down, and then you just perform a normal library prep next generation sequencing. And then we also chose to follow that up with a targeted bisulfite sequencing to give a little bit more resolution for specific loci. So some results. Here you can see the QQ plot, which just shows after we correct for covariates, those 4 dots up in the top of the red line, that's just showing significant hits, which you can also see on the associated MWAS plot. I think one thing that I do want to note, I am only finishing my second year of grad school, starting my third, so I've only done about 60 samples, and I'm really hoping to get this up to at least 200, 300 samples so that we can increase our statistical significance and just confirm that we're capturing everything that might be occurring. And then the next thing that I wanted to do is to take that global MBD sequencing and pull out just the DMPK locus itself. And one thing I think that's interesting is you can see that the CDM infants, they have higher methylation here, and then it starts to decrease as you progress throughout childhood and adolescence. And I think one thing that's really interesting that we were just talking about with some of this data is that there are clearly some outliers in this group that have low methylation, and I think there are a couple of reasons that could be. One, this is from genome-wide methylation data, so it might not provide as good of clarity of this locus as we would like. And that's why we followed it up with the bisulfite-treated sequencing, which I'll show you that data in a little bit. And the other thing is that epigenetics can be heritable. It can be changed due to your environmental, due to the environment that you're in, things like that. And so we're going to go take a look back through our phenotype data and see if there are other things that we can control for that would maybe clarify some of this data as well. And then we also zoomed in further to the various CBG islands on DMPK. And so basically these are just regions within your genome that are more prone to being methylated than others. And you can see that up here. We're looking at the locus. And there's about 4 islands, but 5 sites of interest. And so here, we're looking at CBG43. And this site is interesting to us because this is actually an alternative transcription start site for DMPK. So the thought is that if this is methylated versus being unmethylated, maybe this is affecting the DMPK expression levels that we're seeing. And then here, this is CBG36, our CTCF1 site, again, which was hypermethylated according to previous studies, and CTCF2. And again, because we weren't sure this was giving us the best clarity because it is genome-wide, what we decided to do is follow this up with that targeted bisulfite sequencing. And so here it's the same schematic again. And this is from blood samples. So what you can see is these dots, the dark ones represent hypermethylation, the white ones mean there isn't methylation currently at that locus. And the one of interest is CTCF1. So you can see for our youngest samples, really interestingly, from 0.04 years to 1 year of age, they're hypermethylated at CTCF1, and we're not seeing that same trend in our adolescent and adult DM1s or our controls. And we also are really lucky to have access to muscle samples. And so we repeated this using muscle, and we actually found that the methylation profile changed between blood and muscle samples. And so for CBG Island 43, which again is that alternative transcription start site, we're actually seeing lower methylation for our youngest CDM kiddo versus the ones in adolescents and even our adult DM1s that have hypermethylation of that region. And then again, for CTCF1, we're seeing hypermethylation in our youngest CDM patient. Okay, so to wrap up, I think hopefully you guys got from this talk that there are dynamic patterns in CDM, both phenotypically and molecularly, that we don't really understand. We're not sure what's driving them. And we know that repeat length alone is not fully explaining this. And it appears from some of this preliminary data that DMPK methylation is differing between our CDM and our adult DM1 patients, both globally and by specific CBG islands. And as I mentioned, I'm really excited to do more sequencing runs and hopefully bulk up some of the statistical confidence by processing more samples. And then the last thing, since I know this is a little bit more of a clinical focused conference, what I think would be really interesting is to take any significant loci that we find and see if that correlates with some of our clinical outcomes and if that can explain some of the variability in our DM1 patients, because as we know, it's pretty heterogeneous. And so I think that would be a really interesting next step as well. And with that, I would just like to acknowledge the Center for Inherited Muscle Research, as well as Dr. Nick Johnson, my advisor, and I am happy to take any questions.
First question.
Yeah, that was great. I think, see if I understood right, I think a dynamic is changing an individual over time, as opposed to this group at infancy, this group in young childhood. And so did you do individuals sampling at different periods of time? Because is that what you did, or?
Yeah, so I'll explain. Sorry if I didn't make this clear. The splicing data where we looked at over age, that was cross-sectional with a couple longitudinal samples. Those are those red arrows that I showed on the screen to confirm that pattern. We have a couple more longitudinal samples that we're hoping to process to kind of further bulk up that hypothesis that it is changing like that. But we do see cross-sectionally over time there's pretty dynamic changes between those various groups. And then in terms of the methylation data, yeah, that is absolutely an aim of mine, is to include all of those longitudinal samples and see how that is changing over time as well.
Oh, there's a question just on the right there.
Thank you, Julia. Great talk. So I was wondering, so one of the thoughts about congenital myotonic dystrophy is that the early development of symptoms is more driven by DMPK expression, and that the later symptoms are more repeat expansion driven. So how does that relate to your findings here?
Yeah, I think that's a great question, and something that we're actively discussing is how to control for one, repeat length, and then changes in repeat length potentially over time. And so our group is really lucky. We have an interesting method to be able to look at repeat sizing, and so I think that's something that I'll be able to do is take all of that repeat data, load it in as a covariate, and account for that in my analyses, but then also using those longitudinal samples, see how that's changing over time, and perhaps also include like a delta repeat length change as a covariate as well, to hopefully capture some of those effects.
There's another question at the, on the left.
That was a great talk, thank you. Forgive, this might be a stupid question. Is it possible that the repeat length differs in different tissues and you're sampling the blood and that might be why the phenotype and the results that you're getting don't exactly match up? Or is it more challenging to interpret, or am I off base?
No, I mean, I think that's totally plausible. One thing I will say is that when we are thinking about samples that are accessible to us to be able to do some of these analyses in, blood is obviously the one that comes to mind. And so I think given that this is just kind of getting off the ground, the logical step for me was to try this out on our blood samples because they're a little bit more easily used than some of the more precious muscle biopsies, as you can imagine, especially from children with CDM where we're only doing a single muscle biopsy pass most times. So we wanted to start out in blood, see what we could find, but given some of the prelim data from our targeted bisulfite sequencing showing those changes in specifically the muscle tissue, I think logical next steps would be to introduce some of those muscle samples into the global MBD sequencing and see what comes out of that as well. But yeah, good question. I think that's definitely a possibility.
I wonder if I could ask a broader question, actually, because you were saying some of the variation that you might be seeing within the sample, within different samples, could be due to environmental or heritable factors. Are you collecting information on differences, particularly in the environmental factors? What sort of things are you collecting to understand?
Great question. I think we have access, so a lot of these samples are from studies that Dr. Johnson has run, and so we have access to a lot of the phenotypic data that are associated with them. And so I think we can control in that way, and we're also lucky we have families too, so some things like controlling for potentially like maternal smoking, like I know smoking has a really big impact on epigenetics. So being able to go back through the phenotypic data I think is a strength that we have that potentially others might not. And one of the reasons that I felt excited about this project is because we could potentially control for some of that. But yeah, good question.
Thank you.
Very good.
Yep.
Thank
Thank
you.
you very much. So we'll move on to our next speaker. Again, if there are people struggling for space to sit, there is some space here at the front. But now I'll introduce this to the stage Rebecca Johnson. Is Rebecca around? Oh, good. So 100 adults with spinal muscular atrophy at the dawn of treatment, a bone health focus, and Rebecca is joining us from the National Hospital for Neurology and Neurosurgery in London. So thank you very much, Rebecca.
Thank you. Good morning, everyone. I'm really honoured to be here today to speak on behalf of our team from the National Hospital of Neurology and Neurosurgery in London about 100 adult patients with spinal muscular atrophy at the dawn of treatment with a bone health focus. So the advent of disease-modifying therapies has really transformed the treatment landscape in SMA. So this includes Zolgensma, risdiplam, and nusinersen. Given this is an adult cohort, we're focusing on patients who are being treated with risdiplam and nusinersen. These were both recently licensed in the UK, and due to a treatment provision programme, these are available to all SMA patients with SMAs type 1, 2, and 3 that are not at the final stages of disease. The advent of disease-modifying therapies has also led to an increased appreciation for some of the comorbidities that can exist in patients with SMA. One of these comorbidities is bone health. Patients with SMA have a number of risk factors for poor bone health. So lower limb muscle weakness can result in reduced weight bearing and therefore reduced bone loading. In addition to this, gait difficulties can increase the chance of falls and therefore fractures. Beyond these known risk factors for poor bone health, there's also evidence that the SMN protein, which is ubiquitously expressed, has a role in bone remodeling. So in mouse knockout models, mice with a SMA knockout genotype have an osteoporotic phenotype and increased osteoclast activity on immunohistostaining compared to wild-type mice. It's also important to consider the consequence of the overall disability burden and disease progression that fractures can have on SMA patients. So despite these number of known risk factors, there's currently no consensus regarding both the management and then also trying to maximize bone health in patients, especially adult patients with SMA. So we therefore aim to quantify some bone health specific parameters in our cohort of SMA patients. We quantified fracture prevalence, we also looked at the location of fractures, and then we considered prevalence whilst also considering SMA subtype. We also looked at the current implementation of bone density scanning and bisphosphonate prescription, and then finally at vitamin D status and supplementation. So just in terms of our methods, this was a retrospective case note review of 100 adult patients at the National Hospital for Neurology and Neurosurgery. All of our patients had genetically confirmed SMA, and when data was missing, GP records were reviewed. And then we've just got a bit of details about our cohort demographics. So the average age of our cohort was 32 years, with quite a range of 17 being our youngest, and then 67. The vast majority of our cohort was on treatment at 87%, and the most commonly prescribed treatment was risdiplam. So 67% of the whole cohort were on risdiplam, and then 20% on nusinersen. And now just a little bit more details about our cohort demographics. So as expected, we've got a roughly equal split between males and females. So 51% of our cohort were males and 49% females. And again, as expected in an adult cohort, the vast majority of our cohorts were either SMA3 or SMA2, with the majority being SMA3 at 55%, and then we had a single patient, SMA1. Unfortunately, we only had the ethnicities available for 80 of our 100 patients in our cohort, but when available, the majority of our cohort at 71% were of a white ethnicity, and then the second biggest proportion was 16% of an Asian ethnicity. So now if we just go on to our results. So in terms of fracture prevalence, so in our cohort of 100 patients, there were 25 patients who had a history of fracturing at least one bone. There were 8 patients who'd fractured multiple bones, and 2 of these patients fractured bones in 2 separate incidences, and 6 of these 8 patients fractured multiple bones within one episode. So therefore, although we have 25 patients that sustained a fracture, 34 bones were fractured. Then we've got a little bit more details about our subset of patients within our cohort that sustained a fracture, and we compare this to our overall cohorts. So the average age of the patients that sustained a fracture was 34 years old, so that's just 2 years older than the average age of the whole cohort. There is a slight female predominance in our cohort of patients that sustained a fracture, so 60% of the patients sustaining a fracture were female. Interestingly, there's no difference between the treatment status of our patients that sustained a fracture versus the treatment status of the cohort overall. So then here we've got just further details about the treatment status of just our patients that sustained a fracture. The treatment status of our patients that sustained a fracture. So again, the vast majority of these patients are on treatment at 92%, and again, the most commonly prescribed treatment was risdiplam. So next we looked at the location of fractures. So here we had 34 bones were fractured in total, and then we've split this into fractures occurring in the upper limb and the lower limb. So the vast majority of fractures occurred in the lower limb at 85%. And the most commonly fractured bone was the femur. This was by quite some margin, so fractures in the femur accounted for 38% of overall fractures from our cohorts. Next, we looked at the prevalence of fractures whilst considering SMA subtype. So here we had 25 patients that sustained a fracture. 20 of these patients, so 80%, were of the SMA3 subtype, with the remaining 5 patients of the SMA2 subtype. We then looked to see if there was any change in the patient's mobility status post-fracture. Strikingly, in our SMA3 patients, 50% of these patients then lost the ability to ambulate post-fracture. I think it's important to highlight that we cannot conclude that this was a causal effect. However, it is a striking finding, so I think that we can postulate that the fracture likely contributed to this decline in mobility. Next, we looked at the implementation of bone density scanning. So 23 of our patients had a bone density scan performed. And then on our graph here, we then split the patients that had bone density scans performed into those that had a history of fracture and those that did not have a history of fracture. So within our 23 patients, 10 of these patients had already sustained a fracture, somewhat suggesting that this scan was performed in response as a reaction to the occurrence of the fracture. We had the results of our bone density scans available in 21 out of 23 of the cases, and in the majority of these, at 57%, the finding was that of a low bone density. This was based on a Z-score of less than -2. Despite these findings, only 4 patients in our whole cohort were prescribed bisphosphonate therapy. Next, we looked at the implementation of vitamin D testing and supplementation. This was definitely the most widely applied element of bone health that we investigated. So we had the vitamin D status available for 94% of our cohorts. And the majority of our cohort, at 52%, were defined as having a normal vitamin D status. I would also highlight, however, that 40% of our cohort did have a vitamin D status that is suboptimal, so less than normal. Overall, 60% of our cohort were also prescribed vitamin D replacement. So now just a few take-home messages to summarize those results. So we've got a high prevalence of fractures identified. These mainly occur in the lower limb, and they're predominantly occurring in patients with SMA3. Consistency in the implementation of bone density scanning is lacking, and this is frequently reactive to fracture occurrence. And finally, vitamin D testing and supplementation was the most widely applied element of bone health that we investigated. So I'm now just going to go into each of these 3 points in a little bit more detail in our discussion section. So our finding of a high prevalence of fractures. Having a hereditary neuromuscular disease, it's known that you have risk factors for poor bone health. This is particularly well characterized in Duchenne muscular dystrophy patients, where notably we have the second hit from corticosteroids. However, it's important to highlight that in this whole group of patients, traditionally used risk factor scores, such as the FRAX scores, are not currently validated. However, the findings that we report are in keeping with findings from across the literature. So in a recent nearly 500 patients retrospective case analysis that included patients with a range of hereditary neuromuscular disorders, including 44 patients with SMA, they identified that the conditions with the highest incidence of fractures were Duchenne's muscular dystrophy, myotonic dystrophy, and SMA. They also reported that the majority of fractures occurring in SMA patients were in the lower limb, and they also found that a significant proportion, so they report 30% of their SMA cohort, then lost the ability to ambulate post-fracture. In this study, they also looked at the etiology of fracture, and they identified that the most common mechanism of fracture was a fall from standing height. Secondly, we identified that there's inconsistency in the implementation of bone density scanning, which is frequently reactive to fracture occurrence, and then when the results were available, the majority of these results were either low or borderline low. So in all populations, having a low bone density increases your risk of fractures. As already highlighted, SMA patients have both intrinsic and extrinsic mechanisms that are feeding in to a dysregulation in their bone metabolism. This can lead to a vicious cycle, which is why we feel that bone health is such an important consideration. These patients have an impaired weight-bearing status. This impairs their bone growth and remodeling, which increases their chance of fracture. Fracture further impairs these patients' mobility and weight-bearing status. Not only is this on a sort of long-term perspective, but we also think it's important to consider the acute time post-fracture. Actually, in this cohort of patients, even a small period of reduced mobility or decline in their weight-bearing status is likely to have a greater impact. And then finally, as highlighted, vitamin D testing and supplementation were more widely applied than the other elements of bone health that we looked into. So there are some current guidelines regarding bone health in SMA patients. These mainly focus on pediatric cohorts and young adults, and they're mainly from the pre-treatment era. However, these do encourage the supplementation with vitamin D, and they also encourage the prescription of bisphosphonates if there's any evidence of osteopenia or frequent fractures. So interestingly, despite this, only 4 patients in our cohort were prescribed bisphosphonates, which suggests that this is not universally applied and there's no consensus currently on when to prescribe bisphosphonates in these population of patients. Finally, just a few limitations of our study. So although we do have a good sample size of 100 patients, there's still some limitations that this has resulted in. We've got a very limited range of ethnicities represented in our sample. And also, the majority of our sample resides in a very small geographic area in the south of England. Secondly, it was beyond the scope of our study to look into the etiology and the mechanism of fractures, which I think is a really important consideration. And finally, we didn't factor in additional risk factors for poor bone health within our cohort, such as steroid status, dietary status, and also postmenopause status. So, just in conclusion, bone health is an important consideration in SMA patients, particularly given its potential long-term implications for fracture risk, functional disability, and overall morbidity. Further research in SMA patients with a focus on bone health is required in order to create robust management guidelines. And just in terms of some next steps, so this work has actually since expanded in a soon-to-be-published UK-wide cohort encompassing several different sites within the UK. And actually, this does tackle some of the limitations of our current study that I described. So this includes a greater range of ethnicities, geographical diversity from within our cohort, and does factor in some additional risk factors for poor bone health. I would just like to make some acknowledgements and thank our whole team that was involved in this project at the National Hospital for Neurology and Neurosurgery, and then also to acknowledge the team at the Neuromuscular Centre in Sheffield who are leading the multi-site expansion from this project. Thank you very much.
Thank you very much. Great talk, very clear. So we've got a question over here.
Thank you for a wonderful talk. It's David Dickoff from New York. It certainly points out something we should all be aware of as neuromuscular clinicians. In a clinical practice, the one major risk factor for fractures, empirically, is prior falls. You need to look at prior falls. And other than pharmacological intervention like biphosphonates, the occurrence of prior falls should alert all of us to the need for ambulatory assistance, devices, walkers that are probably more effective in preventing the fracture fall than other interventions. Thank you.
Yeah. Thank you. I mean, definitely completely agreed. That's something we've discussed in our team. And also it's definitely demonstrates really the importance of the MDT and the involvement of the physiotherapy team in particular to exactly try and mitigate falls as much as possible.
That's also probably why some 50% of patients, not only with SMA, but all of these adult neuromuscular diseases, lose ambulation after a fall, not only disuse atrophy and other causes, but the fact is their walking may have been very tenuous, predisposing to the falls in the first place.
Yeah. So we've got a question over here at the back.
Hi, thank you for an excellent talk. I was just wondering if you feel there's a role of strengthening exercises for bone health in this type of population, and if there was any literature about that. Thank you.
So I don't think I'm fully qualified to answer that question. I think, again, that would be definitely something that would be more of an MDT involvement and discussion, probably our physiotherapy teams. But I do think that's definitely embedded in our structures at Queen Square, the heavy involvement of the...
Yeah, just to give a bit of insight, that I mean, bone density isn't a normal outcome for strength training trials, but it goes back to the gentleman's comment there earlier, that if we can optimize strength, then it helps to reduce mobility issues and balance issues across neuromuscular diseases, and actually tailoring training interventions for strength and balance training as well. So I get the thumbs up over there. But I think also the issue around post-fracture rehabilitation is a real challenge, and certainly we find that in London, getting people into rehab, acute, inpatient rehab afterwards is very challenging, because once the disuse atrophy kicks in, that's when they lose ambulation. But of course, that's something we can do something about, but you often need support and intensity to do that. So that is something I think we still need to try and crack. Excuse the pun.
Yeah.
And it's interesting because the patients essentially of the cohort of SMA, the ones with the healthiest bones amongst the cohorts, are actually the ones that are at the highest fracture risk because they're the ambulant ones and the ones that are falling over. And these are long bone fractures rather than vertebral fractures, and we see a lot more vertebral fractures in the patients with Duchenne, for example. In the non-ambulant SMAs, did you see any vertebral fractures?
No, so we actually didn't have any vertebral fractures, which I agree is an interesting finding, something that I felt was quite striking as well. Yeah,
very interesting. Sorry, Gita.
Sorry, just one last question. Sorry, this is so interesting. Obviously, you look between the different SMA types. Did you actually see whether or not the disease severity on some of the functional measures correlated, or just to see in a slightly more granular way at what point of difficulty that people are facing mobility, or may they be more prone?
So that's not something that we've done in this current study, but I know that's part of the wider study that this has now been expanded into.
Any other quick questions before we move on? No? Well, thank you very much, Rebecca.
Thank you.
So just to invite Andrea Barp to the stage, who's going to speak on nutritional and swallowing assessment in patients with myotonic dystrophy type 1, a cross-sectional study, and who's from the Nemo Center in Trento.
Thank you. Good morning, everyone. So, as you know, nutritional status has a direct influence on muscle function and disease progression in myotonic dystrophy type 1. Dysphagia is very common in DM1, with about 55% of patients reporting swallowing difficulties. And it increases the risk, this increases the risk of malnutrition, dehydration, and aspiration pneumonia. Previous studies show that nutritional abnormalities are frequent in DM1, with about 90% of patients who are underweight, nearly 60% of patients who are overweight. This is a paradoxical situation where both extremes of malnutrition can occur in DM1. So the aim of our study was to characterize nutritional status, feeding behavior, and swallowing difficulties in people living with myotonic dystrophy type 1. And to do this, we used a combination of tools with clinical interviews, body mass index, the malnutrition universal screening tool, the functional oral intake scale, and the eating assessment tool, or E10. And let me briefly explain the tools we used. The body mass index was calculating the standard weight that allowing us to classify patients as underweight, normal weight, or overweight. The MAST is a screening tool that scores malnutrition based on body mass index, unplanned weight loss, and acute illness, with scores ranging from 0 to 6, where 0 corresponds to no malnutrition and 6 with high risk of malnutrition. The FOIS measures the level of oral intake from total oral intake, so score 7, to full tube dependence, score 1. Instead, the E10 is a self-reported questionnaire that helps to quantify the impact of swallowing difficulties on daily life, with scoring range from 0 to 40, where 0 corresponds to no perceived swallowing difficulties, to 40, that is severe dysphagia symptoms. So these are our results. We have included 74 adult patients from Nemo Clinical Center in Milan and in Trento. The average age was 45.6, ranging from 21 to 76, with a slight female predominance. The majority of our patients fell in the E2 mutational class, with a small proportion distributed across E1 and E3 classes. Most of patients were ambulant, with about more than 370 meters walked at the 6-minute walk test, and the average peak calf expiratory was about 340 liters per minute. That indicates a borderline calf efficiency and the potential respiratory risk. So, regarding the BMI, the average value was 23.2, which falls within normal weight. But if we look more closely, we see that 23% of patients were underweight, and instead 30% of patients were overweight. And the majority, interestingly, the majority of them were both underweight and overweight were female patients. And this highlights that weight management is a significant issue in this population. According to the MAST, the average value was 0.5, that we can consider a low risk of malnutrition. But within the group with a high risk of malnutrition, identified as MAST score of 2 or more, we found a female predominance with about 71% of patients with a high risk of malnutrition. On the FOIS, the average value was 6.3, that corresponds to a full oral intake without restriction. Most of patients maintain a normal intake, but 20% of patients need modifications such as chopped food, thickened liquids. Only one patient saw severe dysphagia that required a complete tube dependence. And again, so overall, most of the patients maintain a normal oral intake, but modification of the food were often necessary. Regarding the IT10, the average score was 3.9. That indicates a mild swallowing difficulty. Half of our patients reported some degree of dysphagia, while the other half did not. And interestingly, again, there were some patients who didn't report any dysphagia that actually still showed mild to moderate dysphagia at the instrumental evaluation with FIS. This again underlines that sometimes patients can underestimate their swallowing problem compared to the instrumental assessment. So to conclude, 1 in 4 patients were underweight in our core, but however, the malnutrition risk was low. Most of patients maintain a food oral intake, although a significant proportion of them required texture modification of the food. Dysphagia was highly prevalent in our core, with about 50% of patients that reporting swallowing difficulties. And so we found a lack of awareness as some patients underestimate their swallowing troubles compared to the FIS results. And so to conclude, our findings support the use of multidimensional tools, including nutritional and swallowing assessment, to have a comprehensive and non-invasive evaluation of dysphagia in DM1. And we encourage also a proactive and personalized approach in patients with DM1 in order to prevent events like aspiration pneumonia, malnutrition, and inhalation. So I would like to thank my colleagues at Nemo Clinical Center in Milan and in Trenton, and thank you all for your attention.
Thank you, Andrea. Any questions from the audience? Just one question I had. So you noticed that there was a difference in between females and males in terms of the malnutrition risk. Yeah. Any thoughts on why that might be?
There is probably a hormonal component that can have an effect on not just on the phenotype, the motor phenotype, but also in dysphagia and in the swallowing trouble. It has been described actually, for example, in a French study, I think. So probably there is a hormonal component that influences this difference. Actually, it was not statistically significant in our work because the cohort is smaller, but it has been described, the hormonal component.
That's great. Are these patients just from Trento, or are they from all the NEMO centers?
From Milan and Trento. It's about 60% of patients from Milan and 40% of patients from the mountains.
Did you find any other factors that were associated with or predictive of the presence or the severity of the dysphagia?
That's an interesting question. Probably the mutation, the class mutation is involved, but I'm not sure. There is a component related to weakness and myotonia as well. I think that also myotonia have a role in the dysphagia, because, especially for the oral phase, right? Because there is tongue myotonia probably has a role in the dysphagia. So it's a combination of weakness, class mutation, and myotonia as well, I think.
Did you correlate that then? How do you know that there's a relationship?
We have 72% of patients in E2. We tried to have a correlation with mutation class, but we didn't get any significant correlation, unfortunately. The majority was in E2 class mutation.
There's a question.
Thank you for an excellent talk. Another important point we should all be aware of. The lack of self-awareness, I think, has to do with the slow progression of the dysphagia and compensatory mechanisms in many patients.
Yes, thank you for this observation. I'm not sure it's just for the slow progression. I think it is included in the personalities of this kind of patient, I think. It's not related only, because we have other neuromuscular disorders where the dysphagia is low. For example, in SMA is low as well. But we have not this underestimation of the symptoms. Okay, I agree partially with you.
I have a comment on the lack of awareness. I don't dispute that, and obviously it's in the data, but I share the frustration with the E10 as a tool for DM1. And if you look at the questions, they're not, if we created it ourselves for DM1, it would probably not look like this. And so I think that when I have a medical interview with patients about their dysphagia, it comes out pretty quickly, showing awareness. It's just that they will answer, for example, well, yeah, I drink liquids all the time, I wash it down, and then I'm okay. And so that way they fill out the survey with that in mind. So I think it's just there's a problem with our outcome measures.
Yeah, it's true. Yeah, E10 is a self-reported questionnaire, so I agree with you that it's not a screening of dysphagia, it's how the patient perceives, and actually, there is a great mismatch from how patient perceive and the instrumental assessment that is true.
Very interesting. And where there was dysphagia, were you seeing this causing a problem? Were there poor outcomes? Were they having chest infections? or other complications? Is it something that we need to do something about to prevent these complications happening?
So which kind of complication happen?
Aspiration pneumonia, these
sure.
sort of things, yeah.
Yeah, you have to monitor it, so during time and to look for any aspiration, inhalation. You have to choose, I think, after this screening, you have to choose which patient goes to an instrumental assessment or not. So this is the first level of assessment.
Great. I think that might be us. Just, should we get a mic for Valeria?
So the thing about the progression or something to do about that. So people with DM1, as we know, die from aspiration pneumonia or pulmonary things. So definitely. The thing is, which is critical to the field, is how are we measuring progression in this field? Because like John, I think, was stating the limitations of the tools.
Yeah.
If we look at the fee studies, we have data under submission with 5-year follow-up using the fees, and very few are changing even instrumentally. So there needs to be a way of stratifying the patients and looking at the predictors and how we can act there, because we need something simple if we have drugs acting on these symptoms to monitor, which is still something we need to look at. Just a quick comment. Thank you.
No, thank you. Very interesting. Brilliant. So, well, thank you very much. That's great. So now we invite Arya Puanant to the stage, uncovering brain structure and cognitive dysfunction in myotonic dystrophy type 2 from Wake Forest University School of Medicine. Thank you very much.
Sorry. Have to come down a little bit. Let me make sure. Okay, here's work. All right.
Working. Great.
Is that good? Okay. Thank you. So we're going to take a little bit of shift from all the muscle, go back to the brain, right? So good morning, almost noon now, and thanks the organizer for inviting me for the talk. So the talk today is I'm going to share my work, that related to my K23 study in myotonic dystrophy type 2. So this is my disclosure. So we all know that, myotonic dystrophy type 2 is autosomal dominant, is pretty late onset muscular dystrophy. And there are some hallmarks that share between DM2 and DM1. There are progressive muscle weakness, although it's a different pattern. Some of them have myotonia, some of them don't, although they do have myotonia electrically. And of course, they have multisystemic features. So one thing that is actually based on study of Chad Hidwell, that almost 2/3 of the patients with DM2 report experiencing cognitive symptoms. So what they describe is they have some kind of brain fog. They used to do very well early on, in their career and their life, and suddenly they couldn't do a lot of things like multitask, a lot of things that represent executive function, and also, some of them describe episodic verbal memory loss. So what we know based on the literature is that DM2 is primarily affect white matter. That was, back then since the German study, and we don't know much about it. However, the mechanism that related between the abnormal brain structure and cognitive symptoms is not really well, investigated. So I just want to kind of, go back a little bit to RNA-mediated disease mechanism in myotonic dystrophy and thank the former speaker who went through this, so I don't need to talk a lot about it. Just want to focus on something that's very relevant to the brain. Okay, so the splicing abnormality, we know exactly that they splice in the tau proteins, right? And in the tau proteins, it manifests as neurofibrillary tangles in the brain of DM1 and DM2. And without amyloid plaque. So this is one of the evidence of abnormality of splicing, in the brain of myotonic dystrophy type 2. We also found that, in DM2, in the brain, there's a lot of finding that is called Marinesco body, which is found in healthy aging, but is in very aging. But we found a lot of them in substantial nigra in the brain of DM2, which is kind of filled with the concept of premature aging model. And the last that we found that, there's a concept of RAND translation, which, a group in Florida has demonstrated that there is a tetrapeptide toxic accumulation of ALPAC and QAGR. They're both toxic to neuron and glial, and, accumulated in the DM2 brain compared to the control. And, they do a white matter staining, H&E, and this is, the immunohistochemistry, and it's showing that, obviously, that is affecting white matter in DM2. So these studies stem from the idea of how we know little in DM2 and the brain. So this is my, mentoring team. Primary mentor is Peg Nobolos, who has done a lot of work in the brain and cognitive dysfunction in myotonic dystrophy type 1, and two people at Wake Forest, Suzanne Kraft and Michelle Milke, who's the international expert in fluid biomarker in Alzheimer's diseases. So the specific aim of my study is, aim one is we want to look at brain structure abnormality in DM2, and we focus on white matter integrity. Aim two, we want to evaluate the relationship between abnormal MRI measures and clinical endpoint, which include cognitive and motor function. And in aim three, we want to establish proof of concept that tau misprocessing is associated with brain pathology in DM2. So this is a cross-sectional study recruiting 40 DM2 genetically confirmed and 40 age and gender match control. So everybody come to Wake Forest. We flew them. And we actually completed the study. We got everyone in. We're just chasing the control. So everybody has brain MRI. It takes about 50 minutes. And with that, we looking at T1 MP range. We got the brain volume, and we have a little bit side project, which you can find in the poster this evening. We look at masseter muscles, and we try to see if this opportunistic marker could tell us something about the brain and the cognitive function. And we focus, of course, on DTI measures. And everyone has a cognitive assessment, and we use NIH toolbox, and which is because we are not behavioral neurologists. We want to make sure it's done effectively. And we validate that with subset of the ADRC Unified Datasets version 3, so we at least has a pencil and paper, some of them to validate. Half of the subject generously give us the CSF, and as of today, we already have more than 20 CSF of DM2, and we have some in the control. So we will analyze that as a CNS biomarker. And we're also looking at all those motor endpoint, and because of DM2 looks like a premature aging, so we also add this SPPB, which is looking at all the, gait, chair stand, and, tandem walk. It's very validated in aging research. So let's look at the data. This is analyzed in about April, so right now we probably have more. So if you look at it, DM2 and control, they about a little bit lower than 60 years old, and they're pretty tight match in terms of age and gender. And I want to make sure you think about the education. They have done very well. This is very different from DM1. Many of them are 2 master's degree, retired physician, PhD, have a lot of good job, and then suddenly when they're about 50, something happened. So we're also looking at the brain volume. So when we look at brain volume, we need to, correct it with intracranial volume, because of brain, men's and women's brain is different size, right? So we make sure that the number is proportionate, corrected with the ICV. And as you can see that, The ICV between DM2 and control and the CSF is not significantly different. This is the same thing with the brainstem, hippocampus, and cerebellum. So it's just saying that this is not developmental abnormalities like DM1, so it's different. And when you look at the gray and the white matter is not significant, but the gray matter is significant. I'm hiding this result for the next slide. And you look at this, the midline is the control. And then you look at the bar of the standard deviation, you can see that, you know, the gray is lower, it's reduced in DM2, particularly with the cortical gray. And when we look at the regional, it's not significantly between, you know, different regions, but it looks like the parietal is affecting the most. So taking you back to a little bit of DTI. So DTI is the way you're looking at, you know, direction of water molecule moving along the white matter. So there are multiple metrics, but I just want to focus on two metrics. One is fractional anisotropy, which is an FA, which is an index of how the water molecule moves. So it's ranging from 0 to 1. The higher the FA, the healthier white matter. So meaning that we are all sitting here, we are not perfect, we probably have FA of 0.5 or 0.6, okay? So DM2 is gonna be lower. And we wanna look at all the diffusivity. So meaning that we track the direction of the water movement, and this diffusivity index is, value is opposite with the FA. So meaning that the higher the FA, the healthier, the lower of the diffusivity, which meaning that white matter tract is very dense and it's very organized, is the healthier. So going back to the DTI measures that we measure, so you can see that even though the number looks very small, but this is the nature of the DTI. So you can see that, you know, the white matter volume is not significant, but the quality of the white matter volume, basically its microstructure pathology, is significant between the two groups. And you can see that the most significant is the RD and the FA. So this is the DTI map of the FA compared between DM2 minus control. So you can see that all the orange and yellowish area is the area that DM2 has worse white matter health compared to the control. And you can see its global effect, it's not regional. Same thing, right? So you see that all these, you know, orange and all the blue, which is FA and RD, is basically diffusely abnormal in DM2. So moving on to the cognitive function. So like I said, we use the toolbox, which is an iPad, and it's very user-friendly. They are all domain that we wanted to test. And this is showing you that the top is the toolbox domain and the name of the test, and the bottom is the pencil and paper, which we use it to validate in this study. So here's the result. So it's very clear. I mean, of course, that people have been talking about executive dysfunction, but in our study, it's very clear that, you know, DM2 has issue with executive function, confirming by NIH toolbox and the pencil and paper test, which is trail B. And not only that, they have problem with episodic memory domain. They also have problem with verbal fluency, with people consider it as part of executive function. But if you look at the working memory and the processing speed, they are deficit. It's just almost there. So how these correlate between the brain and the cognitive dysfunction? So we picked some of the most abnormality from the, you know, MRI measures, and we see very clearly that the superior frontal FA strongly correlate with the test of executive function. And we look at superior parietal, that is the most effective part, and working memory, and is tightly correlated. And this is processing speed, trail A, and the superior parietal. And like I said, we're very interested in looking at white matter health, how it's affected motor function. So you can see that the frontal RD is strongly associated with step test and gait speed, which is correspondent with all the aging study, right? People have a lot of white matters when they get older. So this is the last data I'm going to show today. We also take all the blood. It's plasma biomarker that We run it. We also have CSF. I'm not presenting it today. So we use this and we run the novel ultra-sensitive NULISA platform to look at different proteins. So it's 120 CNS proteins biomarker. And all the protein level is reported as a log transformation. So it's come into the standard unit. And just to give you an idea that on average, 1 unit change is about 2-fold change of proteins. So this is a volcano plot, and you can see that, A beta 42 and 40 is down here, so it's no amyloid plaque. And then there are about 18 proteins that overly expresses in DM2 compared to the control. And we use FDR rate and we adjust it for age and gender. So there are 18 of them, and among all those, this is the biomarker of interest, right? You can see that we have a total tau, we have NFL, p-tau 181, 231, not quite p-tau 217. But many of them kind of confirm us that there are some tau misprocessing there. Of course, this is plasma biomarker. So keep in mind, because of we're dealing with multisystemic diseases, right? So how do you know that this plasma biomarker is not peripheral source? We don't know yet the answer, but we are kind of concerned because of, recently there are a couple papers from ALS that's showing that elevated p-tau 217 and 181 is actually the sources from the muscle. So the other way to deal with this is to validate with CSF, or we do something that called neuron-derived extracellular fluid that basically is a plasma, it's non-invasive, but it's pretty specific to the brain. In conclusion, so our study showed that there's a strong correlation between abnormal, brain, both gray and white, and clinical endpoint in DM2, elevated plasma protein. It just supports the idea of, tau misprocessing, and we need longitudinal data, and we need CSF biomarker validation. So with that said, I thank all my team, collaborator, mentor, and I want to encourage you to stop by tonight to see a poster of number 1248. Diana Madrid is PhD student from biomedical engineering. She's gonna show you about how we get little things from the brain. It's about masseter muscles and how it's connected to the brain and the motor. With that said, I thank your attention and I'm ready to take the questions.
Thank you very much. Great talk. So we have a first question from Valeria here.
Yeah, thank you. Very nice talk. So not to add to the complexity, maybe I missed it. So all the patients here were walkers?
Yes.
Yes.
Yes. So they're all genetically proven, and they're all ambulatory.
And did you look at the correlation between the cognitive and their motor abilities?
We actually not looking directly between the cognitive score and the motor, but we know that there is a lot of raised concern that how this motor impairment have influenced the cognitive function, right? Yeah. We did look at the two things. We do 9-hole peg test to make sure that the motor function when they do the iPad is not different. And we use the measures that been widely used in Alzheimer's disease field. We use trail B minus trail A. And it's showing that the trail B is basically far beyond the motor impairment.
The comment was not that no, thank you, yes. It's not that the motor was impacting the cognitive. What I was thinking about was that with the trials that are upcoming, they will try to look at something that we can measure, and we have heard from you and from the literature that the cognitive function is very important for these DM2 patients, but at the same time we are behind with measuring again. And while we can maybe look at some motor functional measures, and if we can extrapolate the motor to the brain and vice versa, that could be of help. If you have a trial focusing on motor, you don't want to waste the information on the CNS. So
yes.
That's what was the comment about.
Yes, thanks so much. We haven't looked at that directly, but we will.
And we got a question over here.
Thanks for your talk. I just had a question about practical testing. At our site, I often test biomarkers, the LabCorp ones. So we have the tau, the 217, the rest of the ones that we can test commercially, and neurofilament, but they rarely come back positive for me. And I was just wondering if you think that's about the lab that we're doing. Do you think it's serum versus other testing? I mean, do you think it has practical utility testing it in the serum right now? Or it might be where we're testing or the labs that are testing it that may not come back positive?
You know, like I said, I really think you need to interpret, the finding with caution, right? We all know that NFL is pretty non-specific. It's telling you like axonal degeneration is increased with CMT, different other thing, ALS, Huntington disease, and so basically, the reason why we design this and we make sure that we have all CSF to validate, although it hasn't been analyzed yet, but I said that, DM1, DM2, we don't have a good CSF study to confirm. I mean, even though it's confirmed, it wouldn't exclude it that it's not coming from two sites, to be honest with you.
And another question here.
Thank you. Do you have any functional MRI data to link to your DTI?
We do. We do resting state functional MRI. I just don't have the data at the moment. And we actually do more. We will do NOD, which is ultra-sensitive DTI. It's also detect beta gray structure.
And do we have any final questions before lunch? No? I think we'll leave it there then. Thank you very much for your excellent talk. Thank you.
All right. Thanks, everyone. You enjoy your lunch.
So thank you. Yeah, that was a great session. We leave for lunch now. Thank you for the speakers for sticking to time. And we're back at 1:15. So thank you very much.
Afterwards. Our first presenter is Dr. Buster Roy. He's a neurologist at Yale University, and his research focuses on immune mechanism underlying neuropathies and related conditions. He's interested in biomarkers and the use of advanced electrodiagnostic tools in neuromuscular disorders. Today, Dr. Roy will discuss B cells tolerancy, checkpoints, and insights from single-cell analysis.
Thank you for the kind introduction, and thanks to NMSG for giving me the opportunity to present our work on B-cell tolerance. Am I doing something, or it's just like that? Okay, B-cell tolerance in autoimmune neuropathies. So, these are my financial disclosures. Nothing is directly related to this presentation. So as you are all aware, B-cell development starts in the bone marrow. It goes through the pre B cells, and then the mature B cells leave bone marrow, go into the bloodstream, and eventually finds the antigen, gets activated, and develops either into plasma cells or memory cells. The process of B-cell development is complicated, and it involves random rearrangement of VDG gene segment. What happens, because this process is random, you generate B-cell receptors, a lot of them, which also attacks your own antigens. We call them autoreactive or self-reactive B-cells. Overall, at early stages of development, about 75% of the B-cell clones are autoreactive. So we have B-cell tolerance checkpoints, which helps to filter out these autoreactive B cells. In a healthy individual, most of these autoreactive B cells are filtered out by a central and peripheral tolerance checkpoints. Whereas in autoimmune diseases, many of these autoreactive B cells circulate in the bloodstream. What we can do, like how we test for a B-cell tolerance checkpoints. So we can do a flow cytometry to take out all the new immigrant and the mature naive B cells, and then PCR to isolate the heavy and light chains, clone them, eventually express monoclonal antibodies from those individual cells. Now we can test these monoclonal antibodies against different antigens, insulin, lipopolysaccharide, and dsDNA, and if they are reactive to all three, they are potentially autoreactive B cells, or these antibodies are coming from autoreactive B cell clones. From previous work, we know that there is a checkpoint tolerance defect in several autoimmune and rheumatological diseases, including myasthenia. So all of you are aware that autoimmune nodopathies are particularly interesting because often a time they are IgG4 mediated disease, they have very distinct clinical phenotype, and they do not respond well to IVIG or other standard immunotherapies, and they do respond better to B-cell depletion. So we looked if there is a checkpoint tolerance defect in autoimmune nodopathies, and we found that there is a higher percentage of autoreactive B-cell in the new immigrant and transitional compartment, as well as the mature naive B-cell compartment. Moreover, a lot of BCR clones in the new immigrant and mature naive B cells are actually anti-nuclear antibodies. Now, to study further regarding what might be the potential pathomechanism of these, we looked into individual immune cells and looked at their entire transcriptomics. Afterwards, you can use statistics to reduce the dimensionality of the data, create some clusters, and further look into the details of the transcriptomics profile. In this image, you can see the clusters of different cells. The bottom one showing the percentage of different types of cells in autoimmune nodopathies. We had 4 patients with autoimmune nodopathies and 7 healthy control. And we further looked into the B cells and also checked some conservative B cell markers between different subset of B cells in this patient. And I'll particularly highlight that the plasmablast in patients with autoimmune nodopathies had higher IgG4 expression, which is expected. We also ensured that we have equal representation from different types, disease types, and also from different individuals. So when we looked into the differential gene expression, several genes were differentially expressed between autoimmune nodopathies and the control group, and some of them are highlighted in these violin plots. Among them, I'll particularly talk about CD79B, which is a critical component of the BCR complex, which was significantly low in patients with autoimmune nodopathies. Now, I cannot cover this slide within 5 minutes, so I'll just be super quick. CD79B is a critical component of BCR. It is required for normal BCR functioning. It has different phosphorylation sites, which leads to activation of different pathways, which gets more complicated, and it gets more complicated afterwards. So the point is, a lot of the genes we talked about in these slides are actually related to BCR activation and B cell differentiation. So that is further confirmed by the pathway analysis. As you can see, several B cell activation pathway and differentiation pathways were different between AIN and healthy controls. Now, CD4 T cells play an important role in terms of peripheral B cell tolerance and also normal development of B cells, particularly Treg cells. So we looked into the CD4 T cell compartment in patients with AIN as well. And there are different types of genes which are differentially expressed. And this is some of the conserved T cell markers. Among them, I'll particularly highlight low FOXP3 expression in patients with AIN, which is critical for normal Treg function. Now, the question is, are these changes specific to AIN, or it can happen in any autoimmune disease or autoimmune neuropathies? So we looked into the B cell compartment between CIDP, another autoimmune neuropathy, but not nodopathy, and these changes appear to be specific for AIN. And we found very similar result even in that CD4 T cell compartment. Afterwards, we looked into the communication between immune cells in autoimmune nodopathies and healthy control. And you can see different pathways were activated in different way between AIN and healthy control, shown in the bar plot and also in the heat map, which is showing different pathways by individual cell types. Now, communication between B and T cells were also different in autoimmune nodopathies, healthy control, and CIDP. Among all the pathways, I will briefly highlight ADGRE5 and CYP-A. As you can see, they were more activated in AIN compared to healthy control and CIDP. Last, we checked if there can be a commonality between IgG4-mediated diseases. So we used patients with mask myasthenia, which is another IgG4-mediated disease, and it seems there is possibly a commonality between the development of IgG4 autoantibody-mediated diseases. So in conclusion, there is an early B-cell tolerance checkpoint defects in autoimmune nodopathies. For this study, we only have focused on neurofacin 155 autoantibody-mediated diseases. This is possibly mediated by an abnormal BCR signaling, and there is a potential commonality between different IgG4 autoantibody-mediated diseases. Thank you, everyone, for your attention. These are my collaborators and the people from my lab and clinical research group. Thank you.
Thank you. That was excellent. We have lots of questions for you at the break, so thanks for doing that. We have our next speaker here. We welcome Dr. Carleen Mul she's a neurologist at Radboud University Medical Center. She's in the Netherlands. Dr. Mul's work focuses mainly on myotonic dystrophy and FSHD, including natural history, imaging, clinical outcome measures, especially facial weakness. And she'll present to us on deep learning models to assess facial muscle function in patients with FSHD.
Thank you.
And please try your best to keep it to 5 minutes. That's interesting.
I have 4 slides, so I should be good.
Excellent.
So let me briefly tell you something about the deep learning algorithm that we developed to measure facial weakness in FSHD. So as you are all aware, facial weakness is one of the major symptoms in FSHD, but we don't know a lot about this symptom. And one of the things that is still a knowledge gap is the rate of progression of facial weakness in FSHD. And so that question was why we started developing outcome measures for facial weakness. And so we started out with a physician-reported score, where we'd have physicians rate various facial tests that are depicted here on the right. And so the person you're seeing here on the right is not an FSHD patient. This is my colleague Tom Lonen, who actually did all of the technical work for this study. So this is my way of thanking him. I'm not sure how grateful he is. But the main thing with the physician-reported scoring that it's subjective and that there was really poor inter-observer agreement of only around 0.4. So we figured, let's have a computer do this, because if a computer scores everything, we don't have any inter-observer variability anymore. So we include 122 FSHD patients, 56 healthy controls, and we had them perform those 7 facial tasks and then have those tests video recorded and have those videos scored by 3 independent observers. Then we used deep learning, convolutional neural networks to train on start and end frames and the difference between the neutral position and the maximum position for every single task. And here you see a very charming healthy control that you might recognize. For an example of a neutral image, the maximum movement image, and then how we create a difference image between those two. And so what we found was a strong correlation between the manual scoring that was done by the 3 independent observers with the deep learning algorithm scores with a mean correlation of around 0.8. But more importantly, we also found excellent reproducibility with an ITC of 0.9. And that was what we were aiming for, because we wanted to take that inter-observer variability out of the equation. And then what we did to check if these results made sense is that we created attention maps. So what you see here, so these images are based on all of the 122 patients altogether. And what you see here are the regions in the face per task that the algorithm focused on. So this is actually quite intuitive. If you look on the right to puffing of the cheeks, you see that the algorithm actually focuses on the cheek area. We had follow-up data, 5-year follow-up data on 64 FSHD patients, and we didn't find any significant progression of facial weakness. The one task that showed some trend was showing the teeth, so raising the corners of the mouth. But I do have to say there are other papers published on this cohort, MRI and clinical features, and this is a really stable cohort overall. So I'm not sure if it's the cohort, if it's the measurement score, or if facial weakness is not that progressive overall. I don't know. So in conclusion, we now have a deep learning facial weakness score that is objective, reliable, and reproducible. And importantly, it overcomes the limitations of manual scoring, specifically the inter-observer variability. That makes this a promising outcome measure for clinical trials and other longitudinal research studies. But next important steps would be to validate on other independent cohorts of patients and also to make implementation a bit easier, for example, by smartphone-based applications. Last but not least, I want to thank the whole team that has worked on this project with me, and I'm happy to take any questions later tonight at the poster session. Thank you.
Thank you very much. Our third presenter is Dr. Sharon Owen from Keele University in the UK. Her interests include proteomics and biomarkers discovery and better understanding neuromuscular disease mechanisms. Her presentation today will explore molecular mechanisms of spinal muscular atrophy and how ionics-based approaches can reveal differences in disease severity.
Thank you. Many thanks for the introduction and also for the organizers for giving me the opportunity to talk about my work today. An omics-based investigation of molecular changes in spinal muscular atrophy. This study is a collaborative effort involving researchers from Cologne, Ulster, Oxford and St Andrews and others at Keele. Just a quick overview. Without treatment, spinal muscular atrophy was the leading genetic cause of infant mortality. It's classified by severity, with the primary types ranging from type 1, most severe, through to type 4, adult onset. Current genetic therapies have changed outcomes, but they are not curative, and they tend to be less effective in adults. Our question was, do molecular pathways differ according to SMA severity? And if so, this could inform severity-specific treatments. We use 3 cell types: fibroblasts, induced pluripotent stem cells derived from motor neuron cells, and myoblasts across SMA types 1 to 3. Mass spectrometry generated the proteomics data, while the transcriptomics data was derived from RNA sequencing. The profiles were compared to age-matched controls, and the impact on molecular pathways assessed using the AI-driven curated bioinformatics tool, Ingenuity Pathway Analysis. Our key findings were that not one single gene protein was altered across all SMA severities. There was some overlap across cell types with genes, proteins impacting mRNA processing in type 1 cells, ciliary signaling in type 2 cells, and metabolism in type 3 cells. To further our understanding at the molecular level, we focused on the broad pathway changes and not individual genes. These bubble charts help us to visualize the overall impact of our omic datasets. The larger the bubble, the more genes or proteins significantly impacted within that pathway. A blue bubble means that the associated pathway is predicted to be inhibited, whilst orange indicates that the pathway is predicted to be activated. When we looked across all severities, we found consistent disruption in several core biological pathways. These included biosynthesis, cardiovascular signaling, cellular stress and injury, growth and proliferation, and multiple signaling pathways. This suggests that, regardless of severity, SMA shares a common molecular foundation. Despite these shared mechanisms, we also saw differences by severity. In type 1, the Warburg effect, a metabolic shift, was particularly evident. Type 2 showed only limited unique changes, but in type 3 we found Ephrin B signaling, a pathway important for neuromuscular junction stability and neuroinflammation. Thus, our findings indicate both overlap and divergence across the severities. To conclude, SMA has a set of core disruptive pathways across all severities, but each severity also carries its own molecular fingerprint. In particular, Ephrin B signaling in type 3 could represent a novel therapeutic target, especially as it's known to contribute to stabilization of synaptic connections and regulate the architecture of the neuromuscular junction, and could ultimately represent a modulatory target to slow disease progression. Overall, our work supports the idea that maybe treatments need to be severity specific, especially for adults with milder forms of SMA. Many thanks to Sparks and Gosh and the Orthopedic Institute for funding, and to my colleague, Professor Heidi Fuller, and all our collaborators for their vital contributions. Please visit me at the poster session, number 1230, if you have any questions or suggestions. We'd like to see you. Many thanks for listening.
Thank you for a great talk. Next, we have Dr. Nathan Staff from the Mayo Clinic. His research extends to biomarker development in peripheral neuropathies, and his talk will highlight results from a phase 2 open-label trial of intrathecal adipose-derived stem cells in ALS. Thanks.
All right, well, thank you, and thank you for the introduction and the invitation to present our data here today. I'll be telling you the results from a phase 2 open-label trial of repeated intrathecal autologous adipose-derived mesenchymal stromal cells in ALS. So why use MSCs or mesenchymal stromal cells? Well, they're known to secrete neurotrophic growth factors that may promote neuronal survival. They've been shown to attenuate neuroinflammation, and they're easily accessible, so they can be harvested easily, expanded in vitro, and can be autologous. A number of groups have looked at MSC therapy for neurologic disease, specifically in ALS. There have been large phase 2 and phase 3 trials using bone marrow-derived MSCs, most notably the Neuron group out of Israel through the company Brainstorm, and CoreStem in South Korea. And as I said, it's being used in other indications under experimental conditions in MSA, spinal cord injury, and multiple sclerosis, to name a few. We've been involved in this for over a decade. We've done preclinical safety studies using MSCs, completed a phase 1 dose escalation trial, and have been studying the mechanisms of MSCs in vitro. So the design of this study is open label. So we designed that explicitly with the goal of trying to maximize the number of responders. In cell-based therapy, there's been kind of a general thought that there may be people who respond to the therapy while others do not, and so we wanted to be able to explore that further. Patients underwent up to 4 intrathecal MSC treatments spaced 3 months apart with multiple biomarker collections in between. They received between 10 and 100 million MSCs. The enrollment criteria for the study are those typical for an ALS clinical trial. So we accrued 57 patients, and those were enrolled both at Mayo Clinic Rochester in Minnesota, Mayo Clinic Arizona, and Mayo Clinic Florida. The baseline data is outlined here, which is typical as we might see in ALS trials, except for perhaps The patients were a bit more affected and more severe at the time of their first injection based on the ALS functional rating score. There were adverse events associated with the therapies. Many patients had back pain and radicular leg pain. For most of it, it was mild and tolerated. Other people, it was more moderate or severe, requiring medication. So something to keep in mind with this sort of therapy. In terms of efficacy, we compared the slope of the ALS functional rating score, both in the pre-treatment period, which is in blue, with the post-treatment region, which was in red. And as you can see here, there was no statistical significance in the slopes between the pre and post-treatment. Furthermore, serum neurofilament light chain did not change over the period of the trial. As you may know, neurofilament light chain has been used now as a surrogate biomarker endpoint in clinical trials and drove the approval of tofersen for SOD-related ALS. Because this was an open label trial, we partnered with the company Origin Biosciences to develop virtual twins for each of the people who were in the trial. And so with their data that was developed from the PROACT data set, they could give us a slope and development of the ALS-FRS that would be expected based on the patients that were enrolled in the trial, which was a combination of their baseline demographics, the time of diagnosis, age and sex. And as you can see here, the predicted ALS functional rating score based on the Origin data sets did not differ from what we saw from the patients in the trial, suggesting, again, no effect, substantial effect of the MSCs on our patients. As previously said, we designed the trial to maximize the number of responders that we may encounter during the course of the trial, and we defined that as a 25% improvement in their ALS functional rating score between the pre and post period, and we did find 21 of our 57 patients met that criteria. That group, however, did not show any difference in terms of their neurofilament light chain levels throughout the period of the trial, suggesting at least at the biomarker level, while they responded on the functional rating score, they didn't show any improvement in their functional, in their serum neurofilament light chain, and that again was out over a year period from the treatment time. In the lower right, we did a comparison, again going back to all of the patients now, where we show the Kaplan-Meier survival curve of the patients who were in the trial. That's the blue curve. Compared it with the Origin virtual twin expected death rate, which is in the red. It's a little bit like comparing apples to oranges from a statistical standpoint, so there's no real test we can do for that. But at least by eye, it shows us that there wasn't a clear worsening of death rates in the patients in the trial compared to the virtual twins. So in conclusion, in our trial, back and leg pain were most common. We didn't see any changes in the slope of the functional rating score, either during the trial or compared with the virtual twins. We didn't see any changes in the neurofilament light chain, but we have further biomarker analyses ongoing to help tease this out further. And obviously, this is a large group effort and list collaborators in Rochester, Florida, Arizona, and the Origin Data Sciences. Thank you.
Thank you very much. Our final presentation of this session will be Dr. Sara Sagostino, medical student at the University of Vermont, who has been involved in a collaborative research on novel strategies for managing myasthenia gravis. Today, she will present analysis exploring the potential application of artificial intelligence in the real-world case of conditions.
Good afternoon, everyone, and thank you for sticking around for the last of the flash presentations. As you know, diagnostic and treatment decisions in neuromuscular medicine are basically becoming very, very complex due to the new advancements in the field, which is great. But on the other hand, we have a shortage of neuromuscular specialists, which leads to delays in care. And so AI has been essentially tested across every field in medicine as a potential tool for real-time clinical support in decision-making. And so we wanted to see if AI could be helpful for non-neuromuscular specialists when answering questions related specifically to myasthenia gravis before they can consult with an expert. So today I'll walk you through our pilot study, which compares the performance of 3 large language models, which are ChatGPT, Gemini, and OpenEvidence, when asked about different aspects of myasthenia gravis. At the UVM Medical Center, we had one of our neuromuscular physicians develop 5 sets of questions, which consisted of 1 main question and 2 or 3 following prompts with increased complexity. And the questions were designed in a way that basically were mimicking what a non-neuromuscular specialist would ask related to myasthenia gravis. So you can see that the topics that we mentioned were essentially related to appropriate diagnostics, treatment strategies for different subtypes of myasthenia gravis, as well as management of exacerbations. And our expert also developed an answer key to which we compared the AI answers, and the answers were essentially scored based on accuracy and on comprehensiveness. And the accuracy score was between 1 and 6, with 6 being the maximum completely correct answers, and comprehensiveness a score from 1 to 3, with 3 being fully comprehensive. And so if we focus on the accuracy first, on the left-hand side here, you can see that essentially none of the AI platforms scored 6, which was the maximum achievable score. They were basically between 3 and 5, and among the 3 platforms, Gemini, which is reported in red, scored best, and especially for questions with increased complexity, versus ChatGPT and OpenEvidence, they scored generally around 4. And for comprehensiveness, a similar trend, none of the platforms scored 3, which was the maximum achievable score. But among those, OpenEvidence, which is here in blue, scored best with a score of 2, versus ChatGPT and Gemini mostly scored 1, so mostly non-comprehensive answers. And just want to give you a brief example of how the scoring was made. So we asked the question, what is the best treatment strategy for new-onset ocular myasthenia? And you can see here 2 answers, one that scored 3 out of 6 and one that scored 5 out of 6. And both of them, they touched upon treatment strategies like acetylcholinesterase inhibitors, they acknowledged corticosteroids, non-steroid therapies, but the one that scored 5 out of 6 also mentioned azathioprine and also used citations that were valid. They were expert consensus, they were clinical studies, review articles, versus the one that scored 3 out of 5 failed to address the uncertainties around thymectomy for ocular myasthenia, and also reported treatments that were not standard practice, in addition to failing to cite scholarly sources. And just to talk about sources a little bit more, we did an analysis of the sources that the different AI platforms used when answering those questions, and you can see that there was a difference between them. And OpenEvidence, mostly on the top here, mostly used sources that were peer-reviewed, journal articles, review articles, versus Gemini had a tendency to cite work that was non-scholar, and we're talking about scientific blogs, healthcare informations, but again, non-peer-reviewed, versus the main issue with ChatGPT, which has been reported before, is the fact that this AI platform had a lot of incomplete citations and a lot of non-existent citations, which is definitely a concern. And so just to sum up, what does it mean for the clinical utility of AI? So our study highlights several limitations. And first, all tools performed better when topics were well established, but they all struggled when the topics were complex or there were nuances, which again is a problem because for those type of topics, you need an expert, and AI is not an expert. And this platform relied on freely available sources most of the time, but because the information were taken out of context, sometimes this led to misinterpretation. There was also important information that was left out, what we called error of omission, which again, if you're an expert, you can pick up on those things. If you're not an expert, you're likely gonna miss it. And again, another concern was that there were controversial practices that were actually presented as established practices, which again is misleading for non-specialists. And so in conclusion, while AI is a promising technology, the current clinical utility to bridge the gap between non-specialist and specialist care is not ready to be bridged. So thank you so much for your attention, and please stop by the poster tonight for questions.
Thank you to all our speakers. Please find them again at the poster sessions or at the break. We're going directly into our next session for clinical trial units. Please welcome Doctors Emma Ciafaloni and Jasper Morrow.
So the first talk, we have Dr. Yasser Hussain and Aziz Shabani, and they're going to talk to us about establishing a clinical trial site from A to Z. So welcome.
Good afternoon. So I'm Yasser Hussain, a neuromuscular specialist from Austin, Texas, and the director of National Neuromuscular Research Institute. And I'm here to talk about establishing independent clinical trial site in neuromuscular medicine, and with the help of Dr. Shaybani in this talk. First, I would like to thank Dr. Shaybani and for his mentorship and the help throughout the path of establishing our center. And you will know throughout the talk that to achieve such a goal, mentorship and collaboration and networking it is very important to achieve such a goal. So, when we started, when we opened first our neuromuscular clinic in 2015, we had a vision that the clinical trial site will be important for local access for patient care, in addition to the financial diversity for the practice, advances therapies, and the goal was to establish a reputable clinical trial site that our vision was the patient come first, the data have to be rigorous, and we needed to establish a very good reputation with the sponsors and collaborating clinics and sites. There we go. So in 2017, we had a simple, humble start. So we had 1 or 2 exam rooms in our clinic. I was the principal investigator. We had a part-time sub-I. It was a 1099. It's covering us from time to time as needed, and 1 research coordinator. But that was, expanded very quickly. First, we tried to pick a trial that fit our infrastructures. And then we start building SOP. We are hiring more staff. And we expanded with our clinical trials. By 2018-19, we had our first audit that we passed successfully, and we opened an infusion suite to include infusion trials. And then by 2020, we started including ALS trials, where we integrated our ALS clinic and added our labs, pathology lab, and the pharmacy to our site. And then between 2023 and 2025, we reached to a multi-site collaborations, investigator-initiated trials, and then we increased our portfolio. At any given time, we have 25 to 30 clinical trials specialized in neuromuscular disorders. I can't see from here. Is that okay? Can you hear me? Okay, I'm sorry. All right, so it's really, this talk will be, I don't want it to be boring, but it's quite basic common sense, but it's, how can I say, you have to be smart, especially when you start. We have to look, what do we have actually that we don't need to spend effort and money with? So we start looking at space, people, what process do we need, what system do we own, how much do we have, like how much budget do we have? And what's our goal once we start this project so we don't go underwater very quickly? 30 days, 90 days, 6 months until we actually start having clinical trial and start enrolling. So first is the space. And as many of you who deal with the clinical trials, the space is really a burden. Like they deal with papers and binders, and you have to save them for 10 years, 5 years. So we started modifying our clinics, research space, secure storage. We started even having contracts with outside storage places once we expanded, places for the lab, blood draw. What about the small pharmacy? Every clinical trials that use an investigator products, they need a small pharmacy space, temperature controlled, access controlled. What about the monitors? Monitors need their own space, and that was part even of the design later when we expanded. If you decided to start infusion suite initially, if you have the infrastructure, also you need to take this in consideration. I put it in the bottom, the backup power. I learned this the hard way. I started a clinical trial, and then suddenly the audit said, "Where's your plan for the backup power?" I said, "What plan? I don't have a plan." They said, "Well, you're not part of a hospital. What are you gonna do if the electricity goes up?" Then we have to develop SOP, we get a generator. So these part of things you learn as you go, but it's achievable, and it's easier if you think about it earlier. So for the lab, it's with a lot of sponsors, they help you and they give you the requirements. And the requirements are basic for any lab processing: centrifuge, refrigerator. Some of them require -80. It could be -80 centrifuge. Not all of them required really physically, but to be a highly competitive site, it's nice to have them during the site selection visits. And then you have to do the temperature logs, and there is a lot of software now. It helps you. The IATA shipping, relationship with couriers, and so on. The pharmacy is, the initial headache was when a licensed pharmacist is required, and I couldn't take a clinical trials when they need an on-site licensed pharmacist. But majority of them, they wanted a trained, quote-unquote, pharmacist. Could be the PI, it could be the nurse. The other thing is it has to be temperature controlled, access controlled. So the demand is not super high. The most initial challenge was having a licensed pharmacist. Infusion suite. I recommend through the path of establishing or expanding the clinical trial, having infusion suite. And you know why. There is a lot of clinical trial requiring it. You will be more competitive. Just like any infusion suite, like for standard of care, you need the infusion pumps and so on. I've been with the clinical trial. I mandate they provide the pump. Then it sounds it's easy, but when I start avoiding headache with audits, when is the calibration? Who calibrated that? So I will just move these on them, and it will be easier. So you have to pay attention if the clinical sponsors say, I need a crash cart, or they say per state requirement for infusion. So for example, in Texas, crash cart is not required to be in an infusion suite. Now, you could have it as your standard of care, but you need to pay attention to these details. And also they will ask you if an AE or SAE happen in the infusion, how is the communication will be. So it's a matter of SOP. Safety infrastructure is really, really important. And this is one of the early SOP you have to develop. So as we know, part of the serious adverse event, as any investigator here or anyone involved in clinical trials, have to be 24 hours, 7 days a week. Now you have it to be clear, how is that going to happen? What if there's no internet? Is the fax, the phone number, who's gonna do it in the middle of the night? If I'm traveling or I'm at home, and someone call me from the hospital and I have to submit it, how is that will happen? What's the protocol? What about in the weekends? So you have to make it clear, and that will make it easier for you. Now, again, clinical trials, they need a staff who trained with BLS or ACLS, and we do it only per sponsors, not just for every employee for employee in the clinical trial. So anyway, so we started really small, and then because of the financial restraints, and I was doubting this will be successful because neuromuscular clinical trials, they are kind of very hard to recruit. If you recruit 2, 3 patients in myasthenia gravis, it could be a success. And so I was, hesitant to move forward in a bigger scale. So we started a part-time research coordinator, and this is the key, having a really experienced, open-minded, team player research coordinator. Why? Because they could easily say, I'm not involved in developing your SOP, you figure it out. Or they will say, I'm not processing your blood work, near taking the blood samples, you have to bring more. Or they will say, I do only full-time research, I cannot help you with other aspects of the clinic. So I needed to really find someone, check the boxes. You start part-time in the research, and maybe for the rest of the time I still pay you, but help me look with other aspects of the clinic. Now, for the infusion, I contracted with local sites, 1099 nurses. Some clinical trials, as you know, with muscular dystrophy and IBM, they sometimes require PTOT, and that's another challenge that we overcome it, but just do it PRN. And over the time, we expanded to part-time pharmacists and a dedicated regulatory person, and now we have research assistants that could save us time and money by processing basic things like the shipping, the blood collections, and so on. So the higher paid research coordinator can invest their time in a better way. And then within 1.5 to 2 years, really, we couldn't keep up with the expansion. We have a full-time infusion nurse and a backup infusion nurse, and both of them also work as research coordinator, and the practice kept expanding. In the beginning, it was confusing, so I had to put a plan of who does what. And then very quickly you realize, and when you get audited or monitored, PI is in charge of everything. When I say in charge of everything, we talk about if something lost in the mail, it's your responsibility. Or the home nurse from a third party not doing her job didn't collect the correct vital signs, what did you do about it? So then you are the top of the pyramid who have to supervise everything, down to the budgets and contract, even if you have other department, but it boils down, it's yours. So I developed this, the diagram, who's in charge of who, and then I start delegated the task that I cannot afford to hire a budget person who will do that. So then we looked at our clinic, the practice manager who does the billing for the clinic, does the billing for the research. Regarding the itemized reviewing the budget, it's me and the clinic to see how many minutes or what's the overhead, how much does it cost to actually be with the patients or in a room. SOP was part of the CRC initially, the development, and it's an evolving process. And then the other PRN jobs like PTOT, there is no other way around them. You have to get a license, one of the required by the sponsor. So I put the slides for PTOT, just I want to highlight, because sometimes it's not really because there's a training gap. It's more of a consistency of the data, and I understand that. But some of these examples I listed that were our PTOT doing, and there is more than that with some clinical trials, but I just wanted to show you that PTOT also required, and they add more challenges in terms of overheads for the clinical trials. So the SOP that was initially a challenge, and I learned the hard way. I really wish I had ChatGPT at that time. I really do wish. But I was very thankful to know a lot of you here who I call, I email, Dr. Shaybani guided me down to the budget and what to look in the contract, and a lot of you guys helped me in the process. And I reached to these top 10, 12. If you start with it, that will be an easy, like how to obtain informed consent. And now when you can run this easily with online, AI, and you can develop, they're quite simple in development, but that's a good starter. And I've been with the clinical trial like now 8 years or so. 2 days ago, we developed a new SOP. You keep evolve as you keep audited and monitored. And there was one strange one a year ago. I remember they said we were putting the time for the PK, and then the monitor said, "What time you're looking for?" And I said, "What do you mean?" She said, "You're not saying, is it an iPhone? Is it a computer? Is it some clock in the wall?" And then we had an SOP saying we have to look at our iPhones for the PK, and it is Central Time. So it's an evolving process. Compliance and training really, they are basics like GCP, ICH, and 1572s, but the sponsor really give you a list, and this is nice. Most of them guide you, they provide you what's needed, and the website you get certified with, even though it's redundant or you've done it before, but it's nice. It's a good safety blanket, and it was relatively easier than the rest of the requirements. Now we're done. We said, all right, how are we going to recruit a study? So I used to attend every meeting, trying to get to know, networking, email Dr. Barron, do you have any clinical trials you can help me with? And then Dr. Shaybani, and then start getting bigger and bigger and bigger. So networking is number one. I hired a third-party companies that I advised against to get you a client, because your networking is supersede everything. Your reputation, it ended being financial burden on liability. Each one of our research coordinator quarterly have to submit a report. This report saying they reviewed clinicaltrial.gov, they reviewed the sponsor website, and what's in the pipeline. They have a list of diagnoses. They have IBM, they have FSHD, they have a list of them, and they say, okay, Dr. Hussain, there's a phase 1 trial. I will contact them in case they go to phase 2. So they send me a report, who they contacted, and then we start collecting more, and this is still ongoing. And then when we email the sponsor, we don't just say, hey, we introduce our site, and there is a fact sheet talking about who we are, how many trials do we have, what's the turnaround, we are the highest enroller, like just stats about our site, like are we able to provide PTOT infusion studies, these kind of things. And then I realized the feasibility questionnaires, initially I used to kind of not ignore it, not give it a priority, and then this is my prior responsibility. If I see feasibility questionnaire, I take care of it myself, because I think this is the gate to having an accurate expectation, and also also the sponsor to know us. And what I would highlight is like what makes us different? What can I actually provide to make myself more competitive? Not just the infrastructure, what about my history? Passing FDA audits in the past, X amount of studies, we are higher enrollers, the screen rate, failing rate, that much. I know what they're looking for. The turnaround of the contract and budget, what is it, 6 months or like 4 weeks? So I know they look for that, and I will try to improve these metrics. Then we're done, we go to patient recruitment, and that's challenging for all of us. We have rare diseases. So since I started the clinic in 2015, I have my own database. Very simple, spreadsheet, the confirmed diagnosis, and we list patient names and the ID number, and we go through them. So I would say 90% of them are our patients. And then we kept it alive, it's in the cloud. And then we use the social media, we use ads. Support a group is a must. We reach to them, we give lectures, and we try to be very closely integrated. And then sometimes the enrollment plateaus. For example, myasthenia gravis was easy to enroll a few years ago. Now you have many therapies available. Really, it's hard to conduct the study now. So then we had to think outside the box, we all get together, and then we develop metric programs. Metric to the research assistant, you approach clinics, you approach support groups, and you get rewarded financially by the end of the year when you get your raise on metrics, how many you actually successfully brought someone for screening. So these kind of incentives we implemented, and it's really boosted our recruitment. Oh, okay. So let's leave this one. I want to touch base the budget. And this is because initially we kept losing and we didn't know where was the problem. So here was the problem, commonly missed items. And anyone who's in clinical trials, I barely can see it. I hope you guys can see it from here. As you know, the sponsor pay you automatically, but there is the missed items, they're billable. And there is a lot of missed items I didn't know I have to focus on, or I trusting my staff to bill. Like, for example, consent, reconsenting, reporting SAE, the IP destruction, medical record reviews. The list is long and long and long. And then we know it, and it's in the contract, but how to really achieve a good mechanism to bill it, not to miss it. And then then finally, the past few years, did this billing software we're working with. The visit cannot be closed by the CRC when he's sitting, just like a doctor. You're with a patient, you finish your visit. If you don't sign it, it's not going to billing. And then the billing department will chase you down and say, your note is not finished, we can't bill. So I applied the same for the research coordinator. They can't. So then the billing department goes to them and say, you're not done, finish up. Then after they finish it up and they submit it, who said they are doing it the right way? I know it sounds complex, but it's not. It's the person in charge of the budget is also know the protocol, and they go with these items, and they cite it with the software, which is identical. And that's the paper I do, actually. If you see the upper square is saying audit, monitoring visit, IP destruction. These are not on paper, is not developed in the software. So when a monitor comes or the FDA, these are billable to the sponsor. So it has to be circled. And this is the responsibility of the CRC. And the one below is where we use a software for the reminder of the items, and that's how the software look like. And it's saying what's done and what's not done, and that will match the actual protocol. All right, well, will close the cycle. And the last one is the past few years we started investigator-initiated trial. That was really a success, helped us with reputation, exploring new indications, and a financial support to ours. And now, at the current time, as I mentioned earlier, we have about 25 trials, 6 research coordinator, 2 research assistant, PTOT, 2 sub-investigators, and we are planning to move to phase 1 trial, and maybe in the near future also we're exploring the idea of satellite sites. Thank you so much.
All right. Good job, Dr. Hussain. I didn't prepare I did not prepare a slideshow because I knew that Dr. Hussain was going to do a good job, and he did. I just wanted to tell you that 10 years ago, I was giving a grand round at Kansas University Medical Center, and Dr. Barron told the residents that this model is doable. And now, 10 years later, I'm telling you that this model is not only doable, but it is also needed. I'm not provoking you to split from your institutions, but I'm trying to show you another model of doing clinical trials, and I think Valeria is going to show you another model in a minute, and you compare. What is the reason that this model is attracting the sponsors and vendors? Because simply it is a simple way of doing things without multiple layers of approvals. It shortens the time of the study, and that means it is cost effective for the companies. In exchange of that, they are willing to accommodate your fee schedule. And that is also a winning situation for the patients because basically that expedites the approval of a new medication. So it is a win-win-win situation. It is doable, and we're trying to encourage other people to do it. If you have any desire to do an independent clinical trial center, we'll be happy to help you. And again, thank you very much. We are open to, there are so many details that you'll discover sometimes the hard way, but there are certain guidelines you really need to follow. I mean, Dr. Hussein has been doing this for 10 years, and he had 4 FDA inspections. And I did it for 30 years. I had 3 FDA inspections. All of them were clear. No forms were issued. That is very important. The sponsors love to see a good FDA inspection letter. And so the risk of doing this is you'll be in the top enroller always, and you get FDA inspection. But you really, if you do a good job, you should not have any problem with the FDA. So thank you very much, and if you have any question, we can discuss that later on if there's no time. Yeah.
Yeah, we don't have time for questions, but you can catch them maybe during the break. So.
Thank you so much.
Thank you. My pleasure to introduce the next speaker, Professor Fabrizio Benedetti. He's a professor of physiology and neuroscience at the University of Turin. And today he's going to tell us about his research, specifically the placebo response and placebo effect. Is there a difference? Thank you.
Thank you. Thank you very much for this invitation. And I am a neuroscientist, both a clinical and basic neuroscientist. And I studied the placebo effect from 2 different perspectives, from clinical trial perspective and from a neurobiological perspective. I am a neuroscientist, so I use the placebo effect as a model to understand how our brain works. Well, what I would like to do today is to show you that sometimes it is really very useful to distinguish between placebo, I mean these 2 terminologies, these 2 words, placebo effect and placebo response, because this is very important in research, in clinical research, and I would say in medical practice as well. So I have nothing to disclose. And this is an overview of my talk. And you see the first part will be about some problems of definition. You know, there is a lot of confusion, sometimes misconception about the word placebo, placebo effect, placebo response. Should we call a placebo effect or a placebo response? The second part, I would like to give you an example in the field of pain and analgesia, and I will show you that actually we are beginning to understand some mechanism of the placebo effect, which means what is going on in the brain of a patient when we give a placebo, something about the opioid system, the involvement of the opioid system and the cannabinoid system. And the last part, today we can run a clinical trial from a different point of view. I mean, there is a new way to run a clinical trial without giving any placebo, actually. This is quite interesting. You will see in a while what happens with the placebo effect without placebo administration. So let's start with some problems of definition. You see here, for example, that when you give a placebo, you can see an improvement, a clinical improvement. For example, in pain, there is a reduction in pain. The critical point, the crucial point is that the improvement you see is due to many factors, you know. For example, you see here spontaneous remission, regression to the mean, clinicians and patients' biases, and some psychobiological factors. For example, the patient's expectation, what they expect. We call all these factors, the improvement following the administration of a placebo, we call it a placebo response. Because a placebo response is different from placebo effect. Placebo effect is actually only the psychobiological component, you know. For example, patients' expectations. Learning is important. You will see in a while what is going on in the patient's brain when you give a placebo after repeated administration of different treatments, of different, for example, different drugs. And this is quite important because today we are beginning to understand something about what is going on in the brain of the patient when we give a placebo. The distinction is important from a clinical perspective, from a clinical trial perspective as well, because you see that, for example, pragmatic clinical trials aim to study, to investigate the placebo response, not specifically the placebo effect. Explanatory clinical trials, you see here, aim to understand the mechanism of the placebo effect. I mean, this distinction, we feel that it's very important because it is the same distinction of drug effect and drug response. Response to a drug involves and includes everything, included, for example, the psychological component, you know. But the placebo effect, the drug effect is the specific effect of the drug. So in this case, it's not different. The situation is not different. Placebo effect is the specific effect, the specific psychological effect or psychobiological effect, and the placebo response is the clinical improvement, which includes different factors like spontaneous remission, regression to the mean, and so forth. So, what is emerging today from a neuroscientific point of view, from a neurobiological point of view, is that there are many similarities between the action of drugs on the one hand and the action of placebos on the other hand, which means that drugs and placebos share common mechanism of action. This is what is emerging from a neuroscientific, from a neurobiological point of view. So I would like to show you an example in the field of pain and analgesia for the opioid system and the endocannabinoid system. I would like to show you a couple of videos. They are very short. This patient is in a clinical trial. She underwent thoracic surgery for lung cancer, and this is the surgical wound. The surgical wound is pretty painful. This is not surprising at all, of course. So if we ask these patients to perform the full range of movement in this way, you see that actually there is a limitation of the range of movement. This is not surprising because the surgical wound is painful, of course. So if we give a placebo, like in many clinical trials, you know, if we give a placebo and we tell these patients, now I'm going to give you a powerful painkiller, but actually we give these patients fresh water or a sugar pill, you know, and we ask these patients to repeat the same movement. Now you can see that this is a typical placebo effect. You see that now she can perform the full range of movement, what we call placebo analgesia or placebo analgesic effect. So for a neuroscientist like me, the main question is what is going on, I mean, in the brain of these patients? Why is there any analgesic effect? This is a very important question, particularly from a neuroscientific point of view. We did not inject any painkiller. We only injected words, positive words. So we induced a powerful psychological effect. Not all patients respond like this one. You know, I show these patients because this patient is a very, very good responder. And you can see the patient in this video from outside, which means from a clinical point of view, from outside. Now I'm going to show you the patients from inside, from a neurophysiological point of view, from a neurobiological point of view, which means then we ask what happens in the brain of these patients. This is a reconstruction, 3D reconstruction with fMRI, functional MRI, and across different patients. This is an average across different patients. And you will see, this is an animation, you will see that different regions light up after placebo administration in orange, and you will see that in the blue regions actually represent a deactivation and inhibition. So when we give a placebo, you see here that actually there is an activation of different brain regions, both at the subcortical level and the cortical level. And after a while, everything, all these brain areas become blue, which means they are inhibited, they are deactivated. These regions, we call these regions pain neuromatrix because they are very important for pain processing. So if they are deactivated, it is not surprising that actually there is a reduced perception of pain intensity, you know. So from a biochemical point of view, from a pharmacological point of view, this system is an inhibitory system which can use two different neuromodulators, two different neurotransmitters. It very much depends on the previous exposure to different drugs. For example, you see here, if there was a previous exposure to narcotic drugs, you see, which means mu opioid agonist drugs, when you give a placebo, when you replace the narcotic with a placebo is a sort of switch which turns on a memory mechanism for the activation of the very same mu opioid receptors. So there is a sort of memory for drug action. But if there was a previous exposure to CB1 cannabinoid receptors agonist, cannabinoids, basically, you know, when you give a placebo is a sort of switch for a different memory mechanism, which is the activation of the CB1 cannabinoid receptors. So there is a sort of memory for drug action. This is quite important. I have no time in 20 minutes, but this is quite important in clinical trials because if you give a drug in a clinical trial and then you replace the drug with a placebo, actually you create placebo responders, very good placebo responders, but I have no time to discuss this point. So the last point of these 20 minutes is that a new way of running clinical trials, this new way, I mean, a placebo effect can be identified without administration of any placebo. This sounds quite strange, I mean, but I will show you that actually this is possible. This is a very long story. You see, it started in the 90s, and this is the typical administration of a treatment, of pharmacological treatment. This doctor, for example, is giving a painkiller, and according to routine medical practice, usually a doctor tells the patients, now I'm going to give you a powerful painkiller, so you have to expect a reduction in your pain. Well, the question now is, what happens if we give the same drug, the same dose, with the same infusion rate? I mean, nothing changes, but we give the drug in this condition, what we call a hidden administration of the drug, unbeknownst to the patient, which means that the crucial point here is that these patients do not know that any drug is being given. Is there any difference in the action of the drug? I mean, is the action of the drug different if the patient does not know that he or she is receiving a drug? I mean, what is the crucial point here? The crucial point here that what is missing? The psychological component, the patient's expectation. They don't expect anything because they don't know that anything is being injected, you know? Let me show you what happens with a couple of slides. in my last, I think, my last 5 minutes, something. Okay, this is a very long story, actually, but to make a long story short, just in 5 minutes, I would like to show you what happens for 4 different painkillers in these 2 conditions. This is what we call open injection, in full view of the patients according to routine medical practice. In this condition, hidden injection, a computer is giving the same drug, same dose, same infusion rate, nothing changes. And the crucial point here is that these patients do not know that anything is being injected, so they don't expect anything. So the psychological component is missing in this case. Here you will see the reduction in pain, and this is what happens for buprenorphine, which is a powerful narcotic drug. You see that a hidden injection is less effective than an open injection. This holds true for other painkillers as well, like tramadol, for example, like ketorolac, and like metamizole. You see, for example, for metamizole, hidden injection is virtually not effective at all. You know, this is quite interesting from both a pharmacological and a psychological point of view, because we can separate the pharmacodynamic effect, the pharmacological effect from the psychological effect. In this case, it is a psychological effect. You see that metamizole in this case is effective only if given by a doctor when the patient expects something. So the psychological component in this case is very, very important. So how is it possible to run a clinical trial without the placebo administration? Actually, you see here that there is no placebo administration. You know, there is no placebo administration. And you can compare the open administration of a drug with the hidden administration of the drug. The difference between an open administration and a hidden administration is the placebo effect, even though we did not give any placebo. It is also difficult to call it a placebo effect because there is no placebo in this case. Let me show you a clinical trial, how we run a clinical trial in this way. In this clinical trial, we try to answer this question. Is metamizole effective in post-thymectomy pain, which is a kind of post-operative pain? You know, according to classical clinical trials, we have 2 groups of patients. One group would receive metamizole, of course, the active treatment. The second group would receive a placebo. Then you compare the placebo group with the active treatment group, and if the metamizole group is better than the placebo group, you say, yes, metamizole is really effective. This is the classical approach. In this case, this approach is totally different, completely different, because you see that both groups receive metamizole. There is no administration of placebo. In this case, there is an open administration according to routine medical practice. In this case, there is a hidden administration by a computer. There is a full informed consent because this is what we tell the patients. You will receive metamizole, but actually you don't know when the computer is going to deliver metamizole. Nobody knows. We know only at the end of the trial. Let me show you a trial. In this case, you will see this is an animation. You will see the time course, the time, we can say the progression of pain. Here, after an open administration of metamizole, in which the patient expects something, a clinical improvement, expect analgesia, an analgesic effect, and hidden administration by a computer. This trial lasts more or less 6 to 7 hours. This pain intensity from 0 to 10. You see here that we start from We start from a pain intensity of about 5, you know. At this point, the broken line is the timing of metamizole administration. Well, you can appreciate actually that here there is an analgesic effect right after metamizole administration. Here, the computer is delivering metamizole. We don't know when, but it's delivering metamizole. We know only at the end of the trial. But you can appreciate that there is a huge difference between the outcome in this case and in this case. Here there is an analgesic effect. Here there is no analgesic effect. So at the very end of the trial, we ask the computer, I mean, there is a code, you know, and we ask the computer, when did you deliver metamizole? This is the computer response you see after 3 hours. There is no effect. I mean, which means that this is not the effect of metamizole. It is a psychological effect. This is true for metamizole, you know, but for effective drugs, like narcotic drugs, like morphine, for example, there is no difference between this condition and this condition. You would see an analgesic effect in this case as well. You know, this is a new way you can run a clinical trial. In this way, we are working a lot in Switzerland at the World Health Organization, and because in many conditions it is unethical, you know, to compare an active treatment with a placebo. So at the very end of my talk, we are beginning to understand what, from a neurobiological point of view, from a neuroscientific point of view, we are beginning to understand what is going on in the brain of the patients. Expectations are really very, very, very important, and I would suggest considering, the measurement of expectations, of a patient's expectations in any clinical trial. Because expectations, if patients expect at different levels, of course, if they expect an improvement or not, I mean, this can make a really big difference. So at the very end of my talk, let me thank all my collaborators, both in Italy and in Switzerland, where I work, and thank you very much for listening.
Thank you. So we do have time for 1 or 2 maybe questions. At the back there.
Very quick question. I'm very intrigued by your finding in the patient that if patient know they're giving the painkiller, apparently they have a response. If they don't know they're giving the painkiller, they don't have a response. So that make it kind of questionable whether your painkiller really have effect or not.
If the painkiller?
In this kind of context, would animal experiment be helpful to determine whether there is indeed a biologic effect of the painkiller to reduce the pain?
You mean if I understand your question correctly, I mean if there is a real biological effect of the painkiller?
Yeah, whether there's indeed, because if patient was not informed they received painkiller, then they don't have a reduced pain intensity. That to me would suggest there's no biologic effect.
Not necessarily. I mean, because there is a biological effect. I showed you, for example, with a hidden injection, with a hidden administration, that there is no effect, no analgesic effect. In that case, in the example you saw before, there is no biological effect. But in other situations, there is a smaller analgesic effect. So in that case, we have 2 components, the psychological component and the biological component. So it very much depends on the drug we are considering. You are right. You are right. In the case of metamizole, in that case, there was no biological effect because the hidden administration of the painkiller without informing the patient, there was no analgesic effect, which means more or less there is no biological effect, or there is no evident biological effect. But in other conditions, there is a reduced effect of the drug, which means that there are two components, a small biological effect and a small psychological effect. And the total effect is due to the sum between the psychological and the biological effect. I hope this is clear.
So will animal experiment help to resolve the differences? Instead of giving the painkiller to the patients, say you give to mice or any kind of animal models.
Well, if you want to show a biological effect, well, first of all, you can compare a placebo group with the active treatment group. If there is a difference, I can say that there is both a clinical, which means a biological effect. That's the classical approach.
Thank you. I think in the interest of time, unfortunately, we're going to move on to the next speaker. Thank you.
Our next speaker is Professor Valeria Sansoni. She's going to talk to us about setting up a clinical trial unit, the experience at the NEMO site.
Yes, thank you for the opportunity to share our experience. And luckily, these are my disclosures. Luckily, I will go quickly over the first part because it's been covered. So basically, when you are setting up a clinical trial unit, what you want to do is have a good number of trials and have a good recruitment rate and a retention rate. And you want to do this with safety and with good quality. And I will not go into this because it's already been tackled. The thing is, I just want to point out that you may need to focus on having additional training because the regulators say maybe you have to have your regular things every 4 years, every 2 years, but if you are a clinical trial unit, not maybe dealing with emergency every now and then, you want to have refresh theory and practice of how to deal with emergencies if you have a dedicated staff who is not used to emergencies, luckily. And quality comes at different levels. First of all, you have to have a very good clinical coordinator, as it has been already said, and we are very lucky to have one. And for both staff selection and for the coordination of the whole team, and training, again, needs to be very specific, which is based on very many things as well. I will go quickly over this. The quality and risk management needs to be in-house. There needs to be another very good person handling this, and we are also lucky to have one. And it needs to be able to interact with quality checks that are already in place, I suppose, in most of our hospitals. And there needs to be very much of structured documentation and ways to track what's going on. So once you have these things in place, how do you do it? So what's next? And what's next is that you have to think of having core data elements, like we have for the outcome measures. And these are staff, spaces, and infrastructure. It seems obvious, but staff, you need to have very dedicated and specialized roles that have to be very specific, and there's no point in listing them, but they're all there, and they have to be there. And you need to have spaces which, like when you move from a small house to a big house and you think you have lots of space, space is never enough, and you need to plan it ahead of time, and you need to have space for different activities that cannot overlap because it will never work. And the infrastructure, again, needs to be something which is usually best to have within a big public hospital or private hospital or whatever, a hospital that can take care of all the multiple problems that can arise, because as we've heard this morning with all the liver problems, and not only those, of course, you need to be able to get hold of these very quickly. And what's the time frame to get all of this? Let's say you have to start, and we've heard about the phases already, and this is a bit switched compared to other experiences I have heard, because in Italy, to be a phase 1 clinical trial unit, you have to go through a bunch of regulatory documentations and verifications and checks, which mean that you have basically to double your staff. You need to have blinded staff, unblinded staff. The pharmacist needs to be the only one handling the drug. The nurse can only do the nurse, cannot be handling the blood samples, and which this all means very many more things to take care of. So my suggestion, what we have set up at the NEMO site, is to start small with phase 2-3 trials, and you see there the list of things which are initially feasible, or you can think of them, and then the more you get into them, the more you increase the numbers, the more you move into phase 1, you need more. And then what you need to stop and think is all of this feasible? Because this money is not coming from anywhere. It needs to be supported by the work you're doing. And this is why you need to start well with very good people and a very good structure to begin with, because otherwise you can't afford to continue. And how do you do this? You do it with a feasibility and sustainability plan. And again, this is at different levels. It can be at the clinical trial unit level. You have to think of feasibility, but you also have to think of trial feasibility. Sometimes you have to refuse a trial. So for a CTU feasibility, you have to, this is a personal opinion, you have to start with what you know. So if you know the disease, it's going to be easier. If you know the patients, it's even going to be easier, because if you rely on external sources to provide the patients for you, you will not be able to get a hold of what's going on, you will not get a retention rate, you will not understand safety. And you also want to know, since you are giving your patients to somebody else and you're trying a drug and it may be a phase 1 first in human, you also want to know who the pharma are, what kind of people they are, what they're doing, what's the purpose, how they're working, because you want to be aligned and on board doing the same thing. When you think of trial feasibility, there may be some things which may push you to either accepting or refusing, like if you have to go through lots of outsourcing and rely on many burdensome things for patients, you may have to refuse. And so we have set up a local clinical and technical scientific board to approve, which that's a snapshot of it's an online thing that goes around to the different, like the nurses, the physios, the budget people, some of the educational people, to see if we are thinking of the point of view of all the different specialists, to see if some issues come before we go to IRB, so that we're ready to go to approach this. This is more for IITs, but it can also work for the pharma trials. Sustainability, I won't go into this, but everything needs to be accounted for, and you have to cut down on things which may be very good ideas, but there's no money for them. And so this is our checklist to provide a way to look and have a gap analysis. You think of what's needed and you check and think and see how you can improve to do that. Because I think that starting small, anybody can, with the right people and the right spaces, and even though small maybe to begin with, can go through and get a trial unit up. And so this is our experience. So we have started with a structure like you see here, with different levels of dedicated people approaching the different things. And then we have 3 teams. If you go at the clinical operations, so these are all the big bosses, as I call them. And the clinical operations, there's 3 teams. study nurse, and bio working at three teams working at taking care of all the different sites, and there's a separated team taking care of the observational studies. And the staff needs to be excellent staff like the one we have, and the problem of staff is that you need to have dedicated staff, and then there's shared staff. And the shared staff is just as important as the dedicated staff because you need to be covered from different points of view for the different tests and the different clinical parts. So it's necessary to think big and well with very nice people who can contribute and help you with doing these things. And then you need spaces. And it's best if it's bed to bench and bench to bed. So if you know your patients and you bring them in the trial unit, it's easier because you know how to choose your patients. And this is what's happened to us. We started small. We started in 2019, actually 2013, phase 2-3. Then we still kept to phase 2-3, but got bigger space, more staff. And then we decided to move into phase 1, and that's where we had the boost of attention, focus, and opportunities for patients. And you see the colors in red and orange up on the top part of the slide show the observational and the pharma trials. So we are conducting a rather large number of trials. And the numbers, 14, 16, 20, are the staff. And this is also giving a bigger opportunity for the patients, which you see the numbers 33 to 73, considering phase 1 trials. Having 20 patients in a phase 1 trial is a very high number. And we are, this is allowed by the structure that we have given to the trial unit, considering all the previous things said also, mentioned also in the previous talk. And I talked about quality, and this is mandatory. This is what we want, it's what the regulators want, and what the patients want. We don't want to do harm. And there are minor deviations, which of course, the more you work, the more you get them. Luckily, we don't have major ones so far. And there are very many audits, very many regulators coming along. If you are a top recruiter, that's the rule. You know it, that's how you have to face it. And again, this is showing the same type of thing. And so again, standard operating procedures are mandatory. We'll go quickly here, and training and certification too. So, but not all that glitters is gold, as we know, and there are very many criticalities. And so there are criticalities at different levels. There's at the trial conduction level and at the CTU level. So trial conduction level, you need to have a very good structured recruitment plan, and you have to ensure retention in trial. That's critical. Otherwise, there's no point. And at the CTU level, there is a problem that I think is worldwide, which is staff retention, and also clinical and research teams have to communicate. And as far as the recruitment plan goes, as I said, it's best if you start with the patients you know better. And be precise when you indicate the number of patients you have, because it's not nice when you say you can recruit 10 patients and you maybe recruit 1, because it's not reflecting what you're losing your, it doesn't work. Again, you have to have a good structured schedule plan for your visits, because if you have a good number of patients to bring in your clinic, you need to know when to dose them, when to screen them, when to do things. And you do need to do this ahead of time, because otherwise, even if you have 15 patients, but you do not have the slots and the possibility of taking care of them, there's no point in saying you have 10 patients. And you have to consider your screening failures and your dropouts. And so far, out of 80 more patients that we have enrolled in 1 year, we have had 21% of screen failures, mainly due because of the strictness of the entry criteria in many of the phase 1 trials, but we have to account for that. Very few dropouts. And staff retention. So why should I stay to work in a place? So to me, the first thing is you like the job. Then you like the team you work with. And salary needs to be consistent with your needs. There's no saints. Quality of life still has to be good despite the fatigability. So what you can do with this, I have no answer, but I wish I had. But what we're trying to do is to try and fight for improvements, try to get some, have ideas like a short week. That's what we are now having a pilot. The research staff is now having from Monday to Thursday, Friday is out, just to get some less burden on them and try to reschedule things. Or you can try and go and talk constantly to the administration, try to get bonuses, objectives fulfilled, and things like that. This is the other part which is hard. This is what I often hear from the CRC. So they are sick of having missing data from the data entry, the databases. They are get very fed up when they go and look for informed consent forms, which should be there, which everybody swears they were there, and you don't find them. And at the same time, the clinical part says that they have no time, that they are the good ones taking care of the patients, and that the others are sort of playing with numbers and not really doing what they should with patients. So what you need to do, again, I don't have an answer, but you have to try and bridge these two things, and the way we're trying to do that is to have continuous education with the clinical ward, but also with the research part, to try and get them to talk the same language, get them to know each other, get them to work on the same level thinking, and giving value to what, for instance, the PTs are not really doing PT work, they are doing evaluations and assessments, and they may hate it at one point, but if you try to show them why they're doing it and how that is important to get the good data out for the natural history and serve as a comparator for the drugs, they will be rewarded by what they're doing, and they will maybe stick there and do it even better, and so forth with the clinical. So it really needs education, time, and dedication. And so the challenges is that now, because fortunately with all these pharma, there are dedicated startups for being clinical trial units, and they may be run by colleagues who may not even know about the disease, or who may not be as familiar as you, who have maybe worked in the field for so long. And so that's one thing that you have to account for, and I think this is something that we will discover what's best, and if there are real challenges in this new field that's coming up, or maybe that's going to be the future, I don't know. But I still believe that we need to know what we're doing, and we need to know our patients. Staff burnout, again, you have to find ways of doing that. Site readiness, we are all talking about clinical trial unit readiness, but we need to be ready to get all the patients in when luckily all the drug, or at least some of the drugs, will get into the market. We had the example of SMA when we had the drive of the first drug approved, and we had to have lumbar punctures for a number of kids in very short time. And so you need to be ready for the flow that's going to come, and this needs planning. And for the burnout, we are working on a pilot again. So we are sharing a sort of chart with the clinical study coordinators, the research nurses, the PTs, the CRC staff, asking them to put a number on their load. We have called it workload analysis. Again, this is the work done in collaboration with the bosses I showed you before, the team that's working with me. And they are scoring the burden of a specific trial, which may be based on the disease type. If it's kids, it's worse than adults. If it's a certain disease, it may be worse than another. If it has a lot of outsourcing, the number of visits, the time of infusion, etc., blah, blah, and that gives a number which gives a workload, so that then you can distribute the trials to the different teams and see how you can then see if you have space for more recruitment, if you can have space for more trials, or if you realize that you need more staff to come in and help you do that. So these are just examples. I just want to go quick. And again, for site readiness, you need to have a precise plan, and you need to work a lot with patient association supports and pharma support. This is what saved us when we had the flow with the first drug approved for SMA. We had a priority list, which the which the patient association helped us deal with, so that there was no waiting list, and we could give the opportunity to everybody, but with a structured plan. And we actually dosed 107 kids in 6 months in Italy. So that was a very good way to around that. And we, linking to what we heard this morning, a challenge is to have a pharmacological unit on site within your CRC. We do not have that yet. It's a challenge. We're working on it, which will have to house a pharmacologist, a hepatologist, an internist, a nephrologist, and a cardiologist, etc. They do not have to be, of course, we do not have a plant with money, but it needs to be consultants who are dedicated to the trials and who will know what we're talking about and help us regularly meeting, not on an emergency-based need, but on a structured way to approach this. And then, again, another last thing is digitalize. We do not have time, everybody, do not have time to waste on things that can be taken on by AI, including planning for recruitment, for the visits, and dealing with all these things that can be easily taken care of by AI structures. And so this means that you have to create, again, a digital unit within your CRC. And then you have to give time to think of a research unit, not just work, but also think. And finally, have fun and enjoy your team. And if you like this CRC model, there's a slot open for December 26th, and please call us. Thank you.
We have time for a few questions.
Can I apply for the CRC now?
Young fellow, of course.
So Valeria, I think that for retention of clinical research staff, we have found that professional development is very important, right? Sometimes what we cannot provide in terms of competitive salary with the private CRO or other company, we can compensate on the side of professional development and really show them upward in terms of career. Have you found that that's also something that works?
Yes, thank you, Emma. That's important. We are quite flexible, in fact. So we have had some both research nurses and bios who were in the vertical teams I showed you to conduct the clinical trials and do the operational part, who have actually asked to move into the regulatory and startup part because they felt that that would be an upgrade and thinking and doing more of other things. And we have allowed that, and actually it has helped to do that.
There is a question back there. In the back. And I think that figuring out your internal talents and switch roles depending on the talents, that also helps with retention.
Yep.
And everybody has talents and weaknesses, but you can still work on that and sometimes switch. There are so many roles in a clinical research team. So
absolutely right.
Yeah, thank you for this excellent presentation. The work is not lost on me, all the effort that's required to develop a clinical trials unit. One of the things we found important along the same line of what Emma mentioned is that having steps even within a CRC level, entry level, mid-level, a next level to show promotional possibilities along the way, and then moving from someone who's a research assistant to a research coordinator to a project manager, and so on and so forth, and then team lead structures, creating a hierarchy that people aspire to and progressively can grow associated with growth in salary is quite important. I don't know that we can do a Friday off day for us in the US, but it's a great idea. Much success to you.
In fact, what we are recruiting now we are now looking for another couple of research nurses. We are not just telling them that they will just be a research nurse, they will also be a study coordinator, for instance, and that there will be a chance to move along and do other things, depending also on the talent and the type of person you have in front and what their propensity of doing some things better than others. So yes, I agree. We also don't know if we can go with a 4-day week. We're trying.
Thank you.
So we now move on to the last speaker for the session, and it's my pleasure to introduce Dr. Geeta Ramdhari from the Queen Square Centre for Neuromuscular Diseases. She's a consultant allied health professional and has extensive experience in trials in neuromuscular diseases, and will give her experience.
Thank you very much. So I was asked to talk about one of the groups we've heard about a couple of times, which is the allied health professionals. Now, the definition, just my disclosures, but the definition of allied health professionals, I think, varies from country to country. In the UK, there are actually 14 professions, and we even have our own little logo. You can see bottom right there. And that includes physiotherapists, OT, speech and language therapists, dietetics, radiographers, paramedics, lots, orthotists, but certainly many that you'll see in neuromuscular care. In the UK, our professions are bachelor degree level, or there are now accelerated masters for people who have first degrees, and that's for us to get our pre-registration qualification. And we are we're individually small professions, but collectively it gives us a voice strategically in the UK. So when we're actually looking at multi-professional research strategies, we do work as AHPs as a group with our nursing, psychology, healthcare science and pharmacy colleagues as well to push this forward. So if we think about a research literate AHP, so this is often about the culture of the profession and the institution, the departments people work in. So this can be very broad. This could be somebody who is just research literate, who actually is aware of research, applies evidence to their clinical practice, know the guidelines, etc. And that actually can vary. So the culture of the department is really important here. And also they can signpost to available studies that they know about going on in the department or the institution. I think the next level up is where we have the research implementation AHPs. So these are people who actually might then take research evidence and implement it into practice. That might be through quality improvement projects, or they can be enablers. They can actually implement innovations. Then we have the research delivery staff we've been hearing a lot about. These are our clinical evaluators, our trials practitioners. So they support research participants. They also collect data. And in the UK, we have the good clinical practice training that we all have to actually do to make sure that we are adhering to standards for quality assurance. And then we have AHPs who actually are on a clinical academic pathway, from all the way from internships up to professorial, who actually lead their own research. And sometimes the last two can overlap. So I was asked about the Queen Square experience to give you that. So welcome to the team. So there's lots of faces and lots of names there. But I think the thing I want you to notice there is that we're on a continuum in our centre. So this is the Queen Square Centre for Neuromuscular Diseases. So we have our clinical staff, including our colleagues who are on our Neuromuscular Complex Care Centre, in the outpatient department, in our main therapy and rehab department in the hospital. And then we have our research colleagues here listed. We interface a lot with Great Ormond Street Hospital because we're really adult at Queen Square with pharmaceutical companies, and we have a lot of international collaborations. But just to show that this is actually a continuum, some of us span the clinical and research. So we have Pete here, who actually is part of his job to do a bit of both. Same here with Louis, and some of us also have fellowships and funding that enable us to buy time out of our clinical work to actually conduct research. And that might be from a range of funders, and I'll talk about that in a little while. So just now to talk to you about some of our clinical evaluator roles in research delivery. And a couple of people are here in the audience that you probably recognise. So we have Jose and Enza at the top here, who are not only evaluators but also investigators, as they're both either completed or doing doctoral study at the moment in their own research area. Our evaluator roles do centre around the data collection for clinical trials and natural history studies, as we've heard about. They work very closely and sometimes interchangeably with our research nurses, who we work very closely with, and our neurology fellows as well. There are different funding scenarios for our evaluators at Queen Square. So either through commercial trials and all of the evaluation work done by the 4 colleagues you can see here is through commercial trials. And there's a range of different studies going on, and some of the PIs for those studies are in the audience. And then there's a second scenario for these 3 colleagues here, Magda, Louis and Mitchell, where the funding for these positions are from investigator-led trials. So that could either be public or charity funding. So some from NIH. We also have NIHR, which is a UK equivalent, and a lot of neuromuscular charities which also support this. And funding that comes from that source, so either the public funding or charities, often can become described as portfolio trials. And this means that there's funding attached through our local clinical research networks that provide funding for evaluators to support with recruitment to research projects. Now, a while ago, you used to be able to actually develop an individual post around that. Now you can't. So there's sort of pockets of funding. So actually funding a whole person can be a bit challenging, which I'll talk about a bit more in a moment. And also, if there is, if it's before an application has to go in, we have to cost something called NHS treatment costs. So what would this cost if it was delivered in the NHS, if it was successful? And that funding then comes through a pot through the NHS. So that way we can fund if there are practitioners or therapists who are actually delivering. So I do rehabilitation research. So actually a study I'm about to start is actually going to fund some physiotherapists to actually deliver a rehab intervention in people's homes. But there is a real challenge with both of these scenarios. And you know, it's similar to what we've just heard from Valeria and from others, is that, you know, this is often fixed term money. These are often part-time pockets. You know, we don't rarely fund a whole person. And we have real difficulty keeping experienced people, exactly what we were just hearing about. So Vino, who isn't here, but who asked me to give this talk, is leading the Clinical Trials Centre at Queen Square. And one of the things that the team there are doing, a mapping exercise across investigators and PIs across the whole of Queen Square, not just in neuromuscular, to see who is funding research physios, research speech and therapists and OTs, etc., to see who's around. Because if there may be an opportunity to pool resources so that we can then develop into more sustainable roles, keep that expertise, and keep good people. Another aspect to evaluator roles is, and there's 2 of us so far in the centre who are doing this, is actually the role of master trainers through pharma and through the clinical trials. And this is where we are delivering that specific training in outcome measures and protocols. So this is, again, the standardisation, the quality control and quality assurance. And this is just an example, as Charlotte there, when we might be doing some procedures such as time tests, handheld dynamometry, etc., and functional outcome measures. There's many examples. But there are more AHPs now getting involved in those sorts of training roles. This is just us 2 at the centre. There's many more internationally. And actually, the other thing as well is that there's a lot of HPs and have historically been involved in developing measurement tools as well, but also some of the master trainer work and evaluator training is supported by infrastructure developed by some colleagues here. So in the UK, many of you may know about the SMA REACH network, and with the leadership from these 2 physios here, Emma and Robert, lead the physiotherapy side of that network. We've got training and certification through, many of you might know Michelle Eagle, who's done a great job with Atom, and the infrastructure is fantastic that she's done for rolling out trials with all of the quality assurance and certification needed. Anna Mayhew has also done a lot of work on hosting training videos, again, to support some of particularly the multi-component functional outcome measures. And of course, if we're thinking about outcome measures more broadly, actually many of these people have been involved in developing tools. So the North Star Clinical Network and the North Star measure had a big involvement from the physiotherapists, particularly Michelle, Anna, and others were involved. And that's now expanding. And so this is the Newcastle were absolute masters at this. This is Meredith James, who's also now expanded this into the NMDAS, which is a limb girdle functional outcome measure. And of course, a lot of work internationally, as I was saying, again, from excellent AHP leaders. So we have Dr. Kate Eichinger, who many of you may know from Rochester, and Professor Joshua Burns, who was in Sydney, but he's now in the States as well. And they've done a lot of work on the CMT functional outcome measures in children and in adults. And Katie's also done work in FSH and other conditions. And then I think it's worth focusing that it's not just functional outcome measures that we're involved with, and we have leaders, and we have one in the room, Jackie Montez, whose group is doing wonderful work at looking at innovative measurement techniques. So some of the work that she presented last year on smart insoles and using machine learning to really revolutionize how we look at some of this data collection. And also, this is Jodie Allen, who actually is in London, but I've grouped her with the international people. So Jodie's a speech and language therapist, and she's been doing doctoral work looking at ultrasound imaging of the bulbar muscles for dysphagia. And she's part of an international group that looking at standardization of that and how that can be rolled out as well. So the question about how do we keep good people, there was, last time in Stresa, there was a very nice clinical evaluator session that went on, and I know some colleagues were there. And one talk was about how people do their own research, what they call the passion projects at the time. I think that's what we were calling it. Because often people in their roles, either as delivering or even their clinical roles, come up with great ideas. So actually, we're really fortunate in the UK at the moment. The National Institute for Health Research are really supporting us. So one thing that they are doing is doing training now for people who might want to be associate PIs on site and actually stepping up to those more senior roles, a bit like we were hearing earlier. And then this has happened, so we now have AHPs who are PIs in, for example, some of the MSK multi-center trials that have been going on surgical outcomes, etc. And it does allow for greater senior roles and site leadership. And this is a great scheme. So, and hopefully these people to become the PIs of the future in some of the research that we do, and there's a 6-month in-work training. So it's a great opportunity that people can apply for in the UK. And then again, these passion projects, I think they're a bit more than passion projects, because actually sometimes these are the studies that can help to enhance research delivery or enhance patient care. And again, we're very fortunate that the NIHR has really recognised this, and there's a whole stream now of funding for really smart, talented, passionate individuals from nursing, midwifery, AHP, healthcare science, psychology, to be able to get onto a pipeline of clinical academic training. So that can start at internship level, so that pre-doctoral level, and we have at our hospital trust the Centre for Nurse, Midwife and AHP-led research, and I'm the AHP lead for that centre, where we support people so here we've got work in poems, there's physios, OT, speech and language therapists. Rebecca's very interested in FSHD and facial rehab. And then we have doctoral fellowships, and I'm only giving you a small example here, but there are plenty, and certainly at Queen Square, we have doctoral fellows who have had charity doctoral fellowships, NIHR, and again, Alex, some of you will know Alex, who did hers through Muscular Dystrophy UK. And widely across the trust, we've got more speech and language therapists. Kirsty's a music therapist. So we're really expanding the PhDs across our hospital. But many of our colleagues collaborate closely with our medical PIs and come out with some really nice passion projects, as it were, but really important research. So this is on functional electrical stimulation, intensive rehab, spasticity management, so outside of neuromuscular. And then we have research active clinicians. Now, this is Sarah Holmes, and some of you may have met her at this meeting before. She doesn't have a PhD, but she has managed to acquire 2 Lilly Foundation grants in mitochondrial disease for looking at balance impairment, and has actually developed a screening framework with Amanda, who's another physiotherapist, and is now starting to look at interventions. And then we have Claire, who's just, she works in FND and has just managed to convert her early interest into a personal fellowship. And this brings in a lot of money to the hospital. We've got a bigger glut now of postdoctoral fellows, and these are people who are early and mid-career researchers across the hospital. And then, of course, we have AHP-led research groups. There's not so many of those. This is my one. And this is neuromuscular. So here we are doing neuromuscular rehabilitation research. So we've done exercise trials, self-management interventions, orthotics trials, etc. So it's just knowing that not all research is drug. The conservative interventions are still helpful. And this is an example of a 5-year funding program that I've just acquired, where I want to look at how we develop digital and blended rehabilitation interventions, and from understanding the mechanisms to actually implementing them in people's everyday lives. So I love a human movement lab. That's my happy place. So we've actually looked at some of the data from there. We've been able to do a complex modelling of balance impairment. This is in Charcot-Marie tooth disease, just about to publish this. We've then done a feasibility trial intervention of home-based rehab. How do we then support that with digital measures and digital delivery? And we're looking at just co-producing that now. And this is the Better Balance NMD program. So watch this space. Hopefully we'll give you some results of that. So this mainly in CMT and in Canvas syndrome, but we're hoping we should hear soon if we're adding Kennedy's disease to that, and possibly others as well. So what's the point of AHP research? You know, genetic therapies are coming along, you know, you're going to be out of a job. But of course we know that we can, we can change natural history, but until we have newborn screening for all of our diseases, or even earlier, then there is still a need for our rehab. We know that sometimes, as we heard earlier, actually screening for the appropriateness of those interventions, people's compliance, people's engagement, this is where education and behaviour change interventions can be very helpful. Again, we can help with research delivery by thinking about other means of being able to facilitate that. And also there's health inequities, and that's another area of interest. I think I presented on it in Tarrytown, and how we avoid gatekeeping so that there's equal access. So actually our understanding of local communities and how to engage people can be very helpful with that. And at the moment there isn't a global equity of access. So almost finished. In the UK there's been the Chinnery report, which has looked at the drop-off in clinical academics in medicine. This is the nursing midwifery AHP equivalent called the Oscar report, where we're looking at clinical academic careers. And there's where there are bottlenecks, and it's normally postdoctoral, actually. People can't carry on with their careers into more senior levels. And there's a UK-wide implementation group. I've just been invited to be part of that. So we'll be looking at the strategies to try and facilitate those careers. So just want to show my proud picture of the team, and also to thank all of the PIs, some of them are here, whose funding has actually supported the AHPs to be a really valuable part of our centre. Thank you very much.
Thank you, Geeta. Brilliant. We do have time for 1 or 2 questions before we finish. At the front here, on the left.
Thank you very much for this comprehensive overview on how a big center like yours is active in these perspectives. Just a general question from maybe a pure economical point of view. Which, in your opinion, in planning your activities in the next future, the ideal, the optimal ratio in terms of economical resources between institutional resources, private resources, and maybe foundation or some other possibilities to funding the bulk of activity in a center like yours.
Sorry, so is that the economic split between, sorry, just to make sure I understand it, between actually the activity, research delivery activity and the research, the other services? I'm sorry, I couldn't hear very.
My question was, which, in your opinion, the optimal ratio between the institutional funding in a center like yours, private fundings, and charities or foundation fundings, in order to make an equilibrium between research, independent research, applied research, and so on.
I would love to be able to give you a really neat ratio, but this is often quite opportunistic. And also changing, I mean, often it's not institutional funding, but it is external funding for a lot of these, from trials and from funding streams. I mean, we'd like to obviously to grow it and actually have more sustainability, but I think because it is quite piecemeal, this is where the idea of pooling funding and pooling resources to get more sustainable posts, I think, is what we want to do through the delivery centre.
I just add a comment. So that question is a fairly kind of key question, I suppose, but the truth is, certainly in UK centres, and I don't know about other centres, but it may be true, is that it's sort of chicken and egg, that you'll never get everything from your institution. The more you can show, you get external research grants, external donations, the more powerful your argument is with your internal institution. You could answer that question by saying, well, the ideal ratio is the institution pays for everything, you know, but that's never going to happen. And I think that's probably true in most places. And so you need a sort of mixed ecosystem to make it work. That would be my experience.
Valeria?
Yeah, so in line with what Mike was saying, when I was referring to fight for the benefits, it's exactly this. If you have the power to say, look, institution, I am bringing 10, you have to help me because otherwise this 10 is not going to be there. And you can sort of fight and insist, and sometimes it works, sometimes it doesn't, depending on many factors, but that's exactly how you should do it.
Yeah, and I think going back to that point and what Mike said, one of the things we're trying to do within the hospital, the wider hospital at UCLH at the moment, is to reapply for funding for our Centre for Nurse and Midwifery. But one of the things we're doing is we're showing what we have brought in personal. These personal fellowships are actually very generous. So say, okay, right, well, we've supported this number of people. We've only cost you this over the last 3 years. We brought in £60 million worth of fellowship funding. So it is about that. You know, you have to then be able to prove that the cost benefit is there and we're worth your investment.
Thank you. So with that, we'll conclude the session. Thank you to all our speakers.
I just want to, hold on. I just want to make sure people know that the next session, the Young Investigator, Evaluator, and Coordinator session is going to be here right after the break, starting at 3:35.
5 minutes.
Thank you.
Let's make it 10 minutes. Yeah.
10 minutes. You can have 10 minutes.
Good looking.
Thank you. And so we're trying to make it more interesting and maybe structured, and hope you find it interesting and useful. So this time, it's going to be a two-part young investigator session. The first part is going to be a SWOT analysis, and then we will talk about that. And then there's going to be a second part on how to make the best of a meeting, things like that. So why don't you come over? We are being facilitated by...
Okay, this is on now. Great. Hi, everyone. I'm Kristen Gillot-Deoud. I'm the CEO of a company called Elavari Consulting Group, and I will be helping to facilitate this session. So why am I here? Right? So my firm works with all of you, young investigators, healthcare companies, whether pharma, biotech, and we've been doing that now for a number of years. But why is SWOT analysis so important as well, and conference strategy? And it comes down to really understanding you so that you can choose mentors and you can be really deliberate in your networking. And so this is a really great opportunity to work through that, which is why we're here. So I won't go into everything else, but I am a clinician by education and training. I'm a pharmacist. I also have a background in public health policy reform. I know we heard about 340B before. I happened to take over TOP's clinical program in 1992 after George Bush passed the 340B Act and started the 340B program at TOP. So I'm really excited to be here and hearing some of the lectures and getting the opportunity to work with all of you.
Yeah, so we would really like to make it interactive. There's no point in just listening and just being passive, and try to be critical and enjoy it also and play the part, because I think there's always to learn from other people's experiences and thinking about what your weaknesses, strengths are, and we'll get into that. So you will have, or do they have already a piece of paper?
Not yet.
No. So there's going to be a sheet
each of those.
where you will, 2 sheets or whatever, where you will write down what your thoughts are about your way of approaching things, and we'll hear more on how to do it so that we can then give experiences and learn. And when you will ask yourself, why are we doing this? It's because it's useful. When you then, it's a passive way of learning and acquiring skills and thinking. That is not something you read in books simply. It's something that you learn by experiencing and by failing and by restarting again and by rethinking. So it is something that, as an older person, I think I can tell you that it's a way of approaching things which in the end helps. So I truly, invite you to enjoy doing it and try to think about it.
Wonderful. So how did this all start that we decided to focus on SWOT and TOES? And it really comes down to first identifying who you are and helping you to identify what you're looking for in a mentor. And a mentor can't really assist you if they don't know what your strengths are, if they don't know what your weaknesses are, and if they don't know what the opportunities and threats are as they exist today in the area that you want to focus in on. And so this is a really important tool for you to be able to reflect and self-reflect regularly around what your strengths are, what your weaknesses are, and be able to utilize them to support you in your career development and in your career path. So very simply put, and you can see, and did they receive the session in advance, other sheets? The workbook, okay. Did anyone receive pre-work where maybe they saw something on SWOT? Okay, if not, you'll receive it after the session. But, I won't go through word for word all of this, but I will focus on the important aspects of it. So a SWOT analysis, a lot of times, has anyone ever done a SWOT analysis or even heard of it? A couple people? Okay. So SWOT analysis in business is done all the time. So the reason it's done all the time in businesses is to make sure that the right people are on the right teams, the right projects. Also to make sure that there's a go or a no-go on a project as well. So it's very commonly used there, and it was less commonly used personally until about 30 years ago. And about 30 years ago, people started to say, how can I better develop my people? And how can I make sure that we're aligned on what their needs are? And it became something more than just that annual performance review. It became more about how do we really think through our own strengths, our own weaknesses, the areas that we need to develop, and what concerns us. So that's why it's incredibly important to help really identify and evaluate what are the areas that you need to flex more, your strengths, what are the areas that you need to develop or mitigate, which would be some of your internal, your weaknesses. So strengths and weaknesses are always internal to you. Those are things that you have, skill sets, attributes you have, or an area of development that you have. Opportunities and threats are always external. What opportunities you might have with collaborating at this meeting, for example, right? That's an opportunity. A threat might be some of the regulatory conditions or funding conditions, things of that nature. That could be a threat, for example. So how are we doing so far with just understanding the internal and the external and the importance of that? We're all good? Any questions yet? I'm going to call on some of you for superpowers, though, because I'm really curious. Which is my superpower, is that I'm curious. So I will be asking you what your superpowers are. So here's the importance. Again, I think self-reflection, always a good thing. I think we probably all self-reflect. But this really allows you the focus of being able to really assess those strengths and those areas of development. But why it's most important is it helps you to align with what you're really looking to achieve, both in that time period of a year, for example, or if you do this regularly over a 3-5 year period of time. I personally, I have 47 employees and about 147 contractors who work in the division that I spend the bulk of my time on. Before every performance review, everyone does their own SWOT and their own TOES. Before I accept a mentee as a mentor, because time is limited, so you want to make sure that your skills can best be utilized to support whoever's your mentee, I ask for every mentee to provide me with a SWOT and a TOES so that I can make sure I'm the right person for them. And if they have other needs, I can help connect them to someone who can mentor them in some other needs that maybe I'm not the right fit for. So that's why this is so important to each of you. And it's important to take the time to do this so that you can pick the right people to help support you. You have great coaches, great sponsors, great people within your programs that are there to support you, and there's opportunities to further expand your network with the right mentors to further help you grow. Now, as well as the career planning, the self-reflection, it's really about strategy too, and thinking through how you want to make sure you're leveraging all the different opportunities that exist in the most strategic way to effectively to leverage and to, I don't want to say exploit, but I think it's the best word, exploit your strengths effectively. And then confidence building. I know anytime I ever heard throughout my career, even today, as I have 360 feedback from people that work with me, I always appreciate the confidence building and just knowing where I am with my development. And I think that that's a useful tool for all of you too in decision making and the interactions that you have. So it probably seems a little daunting if you haven't done it before. But as I said, it's as simple as really thinking through your strengths, your weaknesses, which are both what? Internal or external? Yell it out. I heard some of you say it. Internal, right? So those are both internal. And then thinking through your opportunities and your threats and leveraging your strengths to overcome your weaknesses, leveraging your strengths to leverage your opportunities, and leveraging your strengths to mitigate your threats. So it's taking this and making it into a more actionable plan that can assist you. And some of those things might be as a strength, maybe it's that your strength is you are naturally curious. Maybe your strength and your superpower, added superpower, is you like to connect. You like to collaborate. So those things allow you to develop better opportunities, right? Because you're going to leverage opportunities to collaborate more often if a strength of yours is liking other people and liking to engage with people that have differences in perspective and things like that. Okay. Any questions yet? Are you guys all looking forward to doing a SWOT? Yeah? Yeah. It's a lot of fun. It is a lot of fun. And it's something that, you're going to start it today, but I'm sure it's going to change, too. It's going to change as you evolve in your career. It's going to change as you reach certain pinnacles and different stages of where you are today versus where you are in a couple years. I know my SWOT analysis has changed a lot over the years. My toes have changed a lot over the years. Not these toes. My toes matrix has changed a lot over the years. Probably those toes have changed a lot over the years, too. But it's an opportunity to just really make sure that we're always being proactive in our planning. We're really enhancing all the actionable strategies, again, that you can take advantage of right away. So with that, we're going to start on our SWOT and TOES matrix here in the next few moments. So again, easier than you may think. List your skills. And skills can be what your qualifications are, what, again, some of your more softer skills are, which I think a lot of times we take for granted. Soft skills are probably some of the most undervalued skills and probably some of the most important ones. So you should really consider those as well. The experience that have kind of guided you to this point, as well as any attributes that you think would be advantageous in any of our roles that would be available to us. So an example here might be that you're a strong communicator. An example might be that you have specialized training, you've attended leadership experience courses, you have some leadership, you understand how to put together a really strong RACI, again, responsible, accountable, consult, inform, right? So you have the ability to do those things and to leverage people effectively in that manner. So those could all be strengths. Huge strength with everyone in this room. You're all naturally curious by definition, right? Your roles as investigators make you curious. So I think that that is a huge strength and a huge attribute of every investigator. I think a lot of you as young investigators also have an incredible diversity of perspective that maybe on people that have done this longer, sometimes they don't have some of those same perspectives. So I think you come with some of these amazing strengths right off the bat. And of course, as individuals, there's different levels of that for sure. But weaknesses too. A weakness could just be, my biggest weakness right now is technology. And technology is so fast, and it's moving so fast, that I feel that that's one of my biggest weaknesses. So what do? I bring people into my network that are really strong with technology, that really understand it, that understand how to prompt AI effectively, that understand how to do things that I don't necessarily have a strength in, so that I can leverage them more effectively. And that's an opportunity, again, for you as you start to determine who a mentor might be, is how you try to mitigate any of those weaknesses, who else you bring in, what other collaborators you bring in. And then, of course, opportunities. An example there would be different programs that are available, mentorship programs, different opportunities when you come to the conferences. And we're going to go into conference prep and planning and how to leverage those opportunities and opportunities in LinkedIn as well, but how you develop your network so that you develop more opportunities. And your network isn't just in academia. Your network can also be with medical collaborators at the pharmaceutical and biotech companies that are all here. Many of them are here. It can also be with others in industry or even outside of industry in IT and technology. But there's always opportunities to kind of expand your network in that regard. And then, of course, threats. I think probably some of our biggest concerns and challenges right now in healthcare are a lot of the healthcare regulations and kind of the changing landscape with some funding and things like that. But again, through developing some of these other opportunities, even in this ever-changing environment, there's opportunities for us to grow. I'm going to pause for the panel because I've been doing a lot of talking, and I want to make sure that the panel kind of integrates in any specific clinical feedback and some questions for the group.
You can talk. Yeah, oops, I don't know if that fell out.
Do you want this mic?
I think it's okay. I think I should be okay. I think just going on with what Kristen had said, like, all of us have some weaknesses and some strengths. Some of them we don't identify in ourselves, but, it's always important to recognize your strengths. And, we have some worksheets there. So if you want to go ahead and write up your strengths, weaknesses, as junior faculty, we don't realize how much, what our strengths are. And so it's important for us to recognize that and build up on that. That's important for us to do. And even our weaknesses, identify our weaknesses and how can we mitigate that. That's important. That's what Kristen mentioned in Taos, that's what you're doing. You're trying to use your strengths and reach out to opportunities that you have. And there's a lot of opportunities you can have here in this meeting or in any meeting, or how else can you have to look at strategies to find those opportunities and grab those opportunities as you're reach out to like your mentors or try to find a mentor. These are the places that you can find your mentors in. It's a great opportunity to see who your seniors are. You have excellent researchers here, and all of the, you can reach out to them and see like who would be a good mentor. You can identify like which areas is your interest in, and then try to find a mentor in that. And I think we all went through that at some time point in our life. And I have to say, even I started off like with the NMSG meeting many years ago. And Rick Barron, Dr. Barron was my mentor for many years. So I think that's important to identify your mentor. I don't know if you want to add anything.
Well, maybe why don't we just take 10 minutes and you just try to give time for yourself and just write it down and think about the things that we just talked about, and then we can just walk around and help you and maybe, just exchange and give our examples if needed to help you concentrate on your own. And then we can maybe wrap up and come up with some conclusions on this part, which is not a beginning and end in here. It's the beginning of, or maybe the continuation and implementation of what we have all been thinking about, but it's now the time to maybe just give ourselves these 10 minutes to think about it, and then we can maybe discuss more. Any other things you want to say?
No, I will encourage you. I want to just see if by hands, how many of you have a mentor, one mentor for your research? Okay, how many of you have a mentoring team? Okay, so use this exercise of a SWOT. You can really use it for your next meeting with your mentoring team. So don't think it's, think as an exercise to really move certain things forward. The other thing is when you have your yearly faculty review, which I don't know if you have in other countries, but certainly in the States, you meet with your chair or division chief. And usually it's to see where you are with, also your research or next step or, your next promotion. That's another setting where having these exercises what can put your idea in a more cohesive way, and also for your ask, right? Because this is going to lead to say, okay, what do I need to overcome some of the threat? And those are the people that can help you, right? So, but you need to articulate it very clearly of what you need. Otherwise, they can't help you. So use it that way.
Okay, 10 minutes, and then we can discuss, and we'll come around and help.
Actually, we can go around and help them.
Yeah. Yes.
Okay, so this is a good sign. We're gonna get back to the next part. What I love is that I was walking around to the tables, as were others, and seeing a lot of filled in forms and lots of discussion and people helping people with their strengths and people realizing they had a lot in common, so that's really great. So now we're gonna go on to the TOES matrix as well. And now taking everything that you just learned about your internal strengths and weaknesses and your external opportunities and threats and thinking through how you make that actionable. So how do you leverage your strengths to make sure you execute more effectively on your opportunities? How do you leverage your strengths, again, to mitigate the threats? And how are you aware of your weaknesses so they don't blind you from seeing an opportunity or seizing on an opportunity? And how do you also make sure that you understand your weaknesses so that they don't compound or further affect a threat? Taking notice of them, how they relate, right, your strengths and weaknesses to opportunities and threats is really important, so that you can make sure that you're flexing on your strengths appropriately and you're also identifying the right mentorship team to help support you. So you all have that second worksheet, and now we're going to go ahead and do the second worksheet for about 5 minutes. 5 minutes, and we're gonna do a hard 5 minutes. I'm gonna time myself here. Okay.
Yeah, I think a lot of people.
Most of them did it.
Oh, how many of you already completed that? Some of you worked ahead and got the toast done too already?
Yeah, maybe we should just keep going. So
Keep
that
going?
we can-
Okay. We'll keep going. Okay. Do you want them to talk? Do you want anyone to give an example then, or no? Because now we're going into conference.
Maybe just one example, quick example for each, and then we could just...
Does anyone want to share their strengths on their toes? So strengths to opportunities? There were some good ones out here. I saw them. Anyone? Sure. If you, I can run the microphone.
Good projection.
I'm Brianna from Rochester. So one of my strengths that I wrote down, I feel like I'm fairly hardworking. I guess I'll say I am hardworking rather than adding qualifiers. One of my weaknesses is probably networking is what I think about myself. Just that social, going and talking to people and meeting people. And, sure. I think being at Rochester, I have a really great mentoring team, so I think that's already an opportunity that I have to work within that team. And threats, I mean, anyone in America would probably agree, loss of funding is a huge threat.
That's really great. So thanks for sharing that. Did you have an opportunity to think through, so your strength being super hardworking, how that would mitigate maybe some of the shyness or lack of networking, maybe?
I didn't write them down, but I'll come up with them. So I think with the hardworking, when I think about threats, I think because I'm hardworking, I would be able to potentially apply for more grants or be more willing to put the work into those, because some of them are quite significant. Within that as well, then working within that strength, having the backup of a strong team, and then that team really has provided a lot of the networking and helping introduce, and then you meet people that then introduce, and I think that's been a good duo.
So first, and I'm sorry, your name again, Brianna. So first I want to say, Brianna, you did a perfect job with first assessing strengths, weaknesses, opportunities, and threats, but also identifying through the TOES matrix how you were going to leverage. You even talked about your really strong team and how, although maybe your strength isn't going out and networking, how you leverage your team to put you in some of those situations that you can still benefit from the hard-working aspect of maybe writing more grants to overcome some of the funding as a threat. All of those things are how you really operationalize the TOES matrix. So you made something that maybe looked a little daunting, and I am here as proof watching. She didn't get a chance to write that down. So she just did that in her head, connecting the dots, which was fantastic, because that's really what we should be doing all the time. So really great job with that, and thanks for sharing. I know in the interest of time and wanting to get on to some of the other section of this workshop, we're going to switch gears a little bit because so many of you did put down as your opportunity for development or weakness that you would like to strengthen your collaborations. And so this is a really great opportunity to now shift gears into how you do that and how you leverage one of your greatest opportunities. As we went around the room, I know we talked about this a lot to the tables I went to, one of your greatest opportunities being external is that you've got to come to this conference. And most of you get to attend multiple conferences. So how do we leverage that as an opportunity? How do we ensure that you're flexing on your strengths, you're mitigating some of your weaknesses to leverage some of the opportunities that you have in front of you, like this conference and other conferences, but we'll focus on this one. So how do we network for collaborations when you're here? So years ago, I was at Tufts University, I shared, and I asked to go to a conference, and we had very limited funding. And I had a really great sponsor there who said, yes, but I need you to give me a justification for why you want to go. And my justification was very simply that the sessions looked really interesting, and I thought I would learn a lot, and I'd be able to take those learnings back. And I was denied. I was denied. And I couldn't understand why I was denied. And I thought, isn't this what I'm supposed to do? And I was afraid to go in and ask why was I denied initially. But I was denied, and so I started talking to other people, not necessarily talking to my sponsor, my boss. I was talking to other people saying, I can't imagine why I was denied. Why was I denied? And they said to me, well, how will that really help you? How will you show a return on that investment and the time you took off, which required other people to fill in those hours and the workload? How will you show a return on investment for what you brought in? What will you bring in from attending the conference? And I was perplexed. I thought I was a pretty bright person. I thought I have no idea what they're talking about. I thought going to the conferences, I was going to get more of my CME credits. I was going to maybe talk to some of the speakers. I didn't really have any other plan beside that. So two of my peers who had been there a little bit longer than me came back and they said, are you going to meet with anyone from industry on the medical affairs team to understand what studies they're doing? Are you going to meet with any of the speakers that are speaking on areas that you're most interested in? Are you going to meet with any other sites to see what they're doing and hear about what they're doing? And I answered these questions by saying, well, I'm going to try to meet up with people that I was in program with and who I did my interning with. And they said, yeah, that's not really enough. You're not really leveraging the opportunity, so you're not going to get approved to go to these things. And funding was really tough back then, and so you really had to have a reason why you wanted to go. So it caused me to think really differently, and that was many, many years ago, many, many years ago. And it caused me to really take a different approach. And I know even a few people, maybe even in this room, have worked with my company and know that we always reach out before we're going to a conference and ask for meetings, 10, 15-minute meetings to determine collaboration opportunities, areas that there may be a synergy. And so it's incredibly, incredibly important to set clear goals. So I would just say, don't let my mistakes be your mistakes, right? I misjudged the opportunity of conferences early on, and it really had a negative impact on me for about a year and a half of being able to attend some of these conferences that I applied to attend before I understood the real impact and how to leverage it differently. So definitely set some clear goals, have an objective of what you're looking to do. And of course, sessions are part of it. You should be attending the sessions. They're great sessions. But should you also identify who some of the speakers are that are really doing some really great research in advance and find ways to connect with them, some of the foundations as well, to meet with them and understand what types of work they're doing and how you can work differently with them and understand just what projects they have going on. How you work with industry to understand their pipeline and potential projects that are going to be happening there.
Christy? Yeah, so maybe we can share the sheet.
Yes, of course.
So the thing is now, just out of, again, taking the advantage and the experience here, to maybe ask ourselves when we are planning to go to meetings, whether we go exactly for the CMEs or whether we go because we have to present something, we are forced to do that, or whether we instead plan and think ahead as to what we really are focusing on, whom we want to meet, if there's a plan or other things that we can take the best of the opportunities. And so we thought that we would sort of share this sheet with all of you to think as to maybe help us next time when we go to another meeting to think ahead and plan and do maybe a more structured way of approaching the meeting without maybe getting lost in too many things and forgetting to take an opportunity or something like that. So that was the sense of doing this. I don't know if you want to add something.
Yeah, so just to say a couple words, and I'm just thinking about Emma's question to you about whether you have a mentor and then whether you have a mentorship team, and how many of you didn't raise your hand for either of those concepts, which maybe you're just being shy, but I think that's probably true for some of you. And I think if you take one thing from this lesson is that you can be the most hardworking, smart, intelligent person, but if you don't have a really good mentor and mentorship team, it's going to be very difficult to succeed. And so, you know, mentors can help you in so many ways. They can make the connections if you're shy. They can put you in the right places. They can identify opportunities that maybe you can't identify on your own. And so that's just so critical. If you don't have a mentor, that should be the number one thing on the top of your sheet of paper is when you get home is figure out, you know, whose interests are kind of in the same vein as yours, and is this someone who can help you out, that has patience, that's willing to give you opportunities even, you know, at their cost, and that's willing to share credit and collaborate. And you know, mentors and mentees those relationships can go a long time and generate benefits that you have no idea about. And so the other thing about that is a mentorship team is, you know, it's good to have a primary mentor, but certainly to have a team that is diverse, that has different skill sets, and can really get you to where you want to be. And you know, a lot of people don't realize this, but promotion committees, as you go at higher rank and are applying for assistant, associate, and full professor and tenure, is that they require letters of recommendation and support outside of your own institution. So a lot of people are like, oh, I'll get my buddy, I trained with them, or I did this or that. But it's really important to have people outside of your own institution. Again, it just opens up the network to you. It gives you more opportunities. It's good for promotion, and it's actually quite satisfying. And so when you come to these meetings and you know people from other countries and other entities, you know, it's just a richer collaboration. And I just even look at the people on this committee and all the relationships and studies we've done together. It just is really rewarding and something that you should put on your list. Thanks.
So the other thing, actually, you can do an exercise. You don't have to wait for your next meeting. You can put down a goal for tomorrow. Who are you going to meet tomorrow? What collaboration are you going to strike tomorrow? Or who are you going to ask one of your senior, maybe colleagues, to introduce you to someone that you want to get to know, maybe to add to your research team or for future projects. So you can do it tomorrow. And the other thing I want to say also is that the NMSG, some of you already mentioned, they know, but the steering committee has also people that will gladly mentor if you reach out, even on a specific project or grant or at large. So that's another opportunity through the NMSG. So take advantage of it. And the whole team and members are listed on the website for the NMSG. Sometimes they rotate out, but
Yeah, I was just going to say that you know, this is the perfect meeting to develop those collaborations because it's a cloistered meeting. Nobody can leave the hotel really, and so as opposed to some larger meetings where you know, it's hard to find people or track them down. You know, that's one of the reasons actually I really like this particular meeting, and I did it when I was in your shoes as a young investigator. So I think I would take the time tomorrow or tonight, actually, the poster session also ideally set up for this, or the reception afterwards, I believe, and go and find 3 people and just say hi to them. You know, I think we're all pretty friendly as a community. Yeah, pretty friendly as a community. And in many instances, the senior investigators in the room have too many ideas or too much work or too many projects that they're able to accomplish on their own. And so I think offering to help with do work if you're hardworking is a good and outstanding kind of ideal place to start in terms of thinking about that. And I guess from the mentorship standpoint, I mean, it may be not clearly defined for you, but you all already have a mentor because you're sitting in this session. So somebody, you know, sponsored you to come here and thought this was a good idea for you, and then probably made you put a poster together of some sort. And all of that, whoever did that work for you is serving in a mentorship role, whether or not it's formally defined or not. So you want them to do 3 minutes to...
3 minutes.
And maybe should we just focus on the first page? It's a long worksheet. Maybe should we just focus on the first part?
It's like he was out there with his 2 children and his wife.
So it's a family business.
Where did you go?
For leather, like belts and
For what?
shoes.
Yeah, shoes.
A leather
mostly
shop.
belts and bags and
That's good.
Good old Italy, you know?
the last time we're here, I got a belt there, and I love it. And I was like, wear it with you. No, you can't. You can belt. You can't wear it. So I was like, we're going back to Sergio's.
Yeah,
and we're
yeah,
getting
the
some
backup.
belts. I'm going to wear it with sweatpants if I want to. So.
There you go.
So you should give people a minute to ask questions for if they have burning questions.
On the first floor?
Yeah,
One of
I don't know for sure, but that's where they
Yeah,
were
that's
last.
probably,
That's where
yeah.
they were a year ago.
Are you going to Vienna as well?
No, because I didn't want to fly back and forth to stay this long. It's too much. Yeah, I'm gonna miss it. You're
We're
going?
going to see Susie's family.
Yeah. Bless your heart. That's a lot of.
works
Your fly
out.
business?
I will on the way because I have a clinic in Abu Dhabi.
Oh, so then,
Yeah.
okay,
Did they,
that
so
will
that's a
pay.
go, Nick? Did they?
So that will pay.
It's the most interesting thing they have done in the last few years. So, because they're not just coming from, I see the patient.
They come
coming
from
from Russia, Spain, Italy.
To the, cool.
So is that going to be MCV East then too eventually, or how's that?
So they're entering a partnership that we can't talk about. It's not approved by the state legislature to do a medical school. So VCU, MCU Medical School. It'd be LCU.
All right. Fingers crossed.
Okay, so you've all taken a few minutes to write down your goals for tonight, for collaboration opportunities tonight and tomorrow. So now we're going to shift gears before we close out a little bit. How many of you wrote down your superpower on your name tag? Your superpower? Hands? Great. So we're going to start with you. Yes, with you, because you are fantastic and you and I had a great conversation. Oh my goodness. So share your name and your superpower.
Okay. She's not happy.
Okay. My name is Olympia Carbonar. Okay. Oh God. Okay. Well, I have this idea from you, so I put tenacity.
And what was it?
Tenacity.
Tenacity.
Very good superpower. All right. Anyone from this group? Oh, wonderful.
I wrote organization and planning skills.
Planning and organization.
Yeah.
Organized
Really
people.
important. I may need you to mentor me on that. So thank you. All right, over here. One of you. Sure.
My name is Lizzie Eisenhoff, and my superpower is that I'm detail-oriented.
Detail-oriented.
That's great. Do you want to share?
I'm Anya Venezia, and I wrote Good Listener.
That is excellent. Very important. I'm looking for a mentor for my adult sons to help with that. So thank you. I'll be reaching out.
Hello, I'm Andrew Snedden, and I'm good at general knowledge and quizzes.
General knowledge and quizzes. I really like that. That's broad. That's a specialty.
What's that superpower?
Trivia, general knowledge and quizzes, trivia, yeah. That's impressive. Okay, well, let's try to beat that.
Okay. I'm Katie. I put multitasking.
Woman.
I'm James, and I'm organized.
Organized.
And if nothing else, he's a good listener, and he actively turns it into a behavior immediately. So well done, James.
Sorry. My strength? My superpower is that I'm very outgoing.
Which explains why you were helping out and running around and helping us, which is awesome. Thank you.
I'm a clear thinker. Clear thinker.
Clear thinker.
Clear thinker. Clear thinker is even more important, right? For sure. So that's great.
So I'm Zubina Khan, and my superpower is I'm a multitasker. I'm working on 3 projects.
That's great. So multitasking. So, because both of you said multitasking. Do a
To
lot of
women,
you feel?
I just want to emphasize.
Yeah. Do you want to? So that's great, but do you feel sometimes work balance is a little tough with multitasking so much? Okay, I was just curious, because that can be a strength, but it can also be a weakness, right? So I always wonder that, because I find myself there too. So we should start talking to make sure we don't overdo it with that.
My name is Shifa, and I am My superpower is perseverance.
Yep.
My name is Bruna, and my superpower is endurance. I studied as a physical therapist, and I fell in love with neuromuscular disease, so I went through medicine, neurology, neuromuscular, and now PhD in neuromuscular disease.
So, yes, that would definitely be the definition of endurance, I would say, for sure. That's great. How about anyone else over here? There we go.
Hi, I'm Raquel. I guess my superpower is that I'm rational. So.
I'm Elena, and my superpower is elasticity.
So her superpower is elasticity, and so I love all of these superpowers. They're so important, and I think they're all, by definition, some really great strengths, right? So what I love about that, especially, is that you're able to overcome a lot of things, right? You can kind of mold, yeah. So what I'm also hearing through everyone's superpower, and a lot of them, that they're all exceptional, and it's always great to have these strengths, is just always be conscious, and I know I talked about it with time management, with multitasking and just being present, right? It's important to be present, and sometimes you have too many things going on, it's tough to be fully present. But also just recognize that sometimes the downslope of your strength is actually your weakness. And so it's trying to make sure that you manage and flex your strength appropriately, and maybe not too much, because otherwise you can become too elastic, right? So those are some of those things to just kind of be mindful of. But these are all really, really great superpowers. How about yours?
I'm Susanna, I'm a psychologist, and my superpower is curiosity.
Wow, go figure. So we are definitely aligned with that. I'm always curious. So do you ask questions about everything? Are you always trying to figure things out, or someone asks you something, you ask? Okay. So then you're better than me, because that is the downslope of my strength, is I ask a lot of questions. Go figure. I'm asking all of you all these questions. How about in this group? Who wants to share?
Hi, I'm Andrea, and my superpower is my hate, of course.
Your height. Okay, but you're sitting, and so now we can't guess your height. Okay, I'm going to say. Okay, so all right. So I'm about 5'8". I have a 6'1" and a 6'2", so I'm going to guess that you're 6'7". Okay, I was going to say, I know you said it first, and now you're not going to believe me, but I was going to say 6'7". Wow. Next time I play basketball, I'm picking you. Volleyball. Okay, very good, very good. All right, who else? Let's see.
My name is Chris, and I put interest in ethics, so I like to discuss, and well, that's what I got.
That's very good, very important too. How about you?
My name is Julia, and I also put tenacity. So
people with similarities in this room, which is great.
It's already taken, but I also put super height, but I'm only 6'1", so I'm just a little bitty person. Yeah, so pretty small. But I put that because I think it forces a little bit of confidence, and forces a little bit of, like, people will see you and you have to talk, and they remember you even if you might not remember other people. So I think it's helpful being super tall or moderately tall in my case then.
I think that's great. How about you?
Yeah, I picked passion. I can be passionate about my work and other things.
That's great. So passion is really, really important, a great, great strength. What would potentially the downslope of passion be? I've been accused of this a little bit, so.
You get passionate about too many things, and then you don't get them all done.
That's one. So what others might say about me, not you, because you're so wonderful, but is that sometimes when you're really passionate, it can come off as intensity to other people, and so it can really land sometimes. So you've got to kind of monitor that from time to time, but never ever let it go away. That's so important. How about this group?
I would say resilience, which I think is resilient, which I think is a little bit related to the people we're talking about, tenacity, consistency, endurance, which I think that is a good thing for research in the sense of we need to be prepared to fall and reborn again. But the downside could be that we end up a little bit like burnout of all this falling and trying to rebuild up again. And so I start to feel like I'm losing it. So that's why maybe it's more like resonating much more to me now.
No, that's really great. And it's great self-reflection on that too. It's an area of potential downside.
I put down organizational skills and self-driven person as my strengths.
I put down staying calm.
Everyone needs someone on their team and a mentor that is kind of the calmness coach, right? The person that keeps everyone calm and never gets too high with the highs, too low with the lows. So that's really a great trait to have. I may be calling you for some assistance on that. No, okay, thank you.
I've put down enthusiasm.
Very important. Anyone else want to share? Oh, we still have 2 more rows.
I put that I'm a rational thinker.
A rational thinker. So there's a lot of similarities in this group. I don't know if everyone's sensing that. A lot of you are saying similar things, right? So I think first, that's wonderful. So I hope if you haven't had a chance to meet all of you, each other, that you leverage that opportunity for sure. But I'm definitely hearing a ton of similarities. And they're giggling now because they know they're next. And so we're going to go ahead.
I'm Josh. I put down open-mindedness.
I think that's a really good superpower. Yeah, that's great.
Can you repeat that?
Open-mindedness.
Oh, yeah.
I'm Christina Viguera, and I put connection, so I can connect to others.
That's also a really great superpower. So one of my mentors is, her greatest strength is her ability to connect other people. And she does such a great job with it that she can see things that none of us would ever think. She thinks of socializing ideas, projects with multiple different people. And even if you don't see where your place is with it, she can help you find it. So it's a great, great superpower to have.
So I'm just checking the time here. I want to make sure people have enough time to
Turn it on.
I think it's on. Can you hear me?
Yeah.
Yeah. So should we
We can
wrap it up here? I think everybody, from here, what I would take from this is to continue to work on your SWOT and TOES. And then, everybody has a little bit of homework to do over the next 12 to 24 hours here at the meeting, achieving some additional goals. I think for the sake of time, this table will hang behind for a few minutes in case people have individual questions that you'd like to ask, but otherwise, yeah, that's it, right? Where are they supposed to go next? You tell us.
No, we'll meet for the posters.
Posters at 6. That's where you can also mingle and strike your next collaboration. And if you're shy, ask someone you know to introduce you to someone else. So that's your job for 6 to 8.
And don't be shy.
Don't be shy.
Thank you, everyone. Really great job.
Yeah, I'm gonna go to Milan on Sunday and just spend about a week, maybe do some day trips, and spend a little time with him, and then go back home on Monday. So, Barty's away in Japan. Stella, she's back home, but she's in Boston. So we're all kind of scattered around for a bit, but yeah, She can't find it.
Plucked her eyebrows on the way, shaved her legs, and then he was a she. She said, hey babe, take a walk on the wild side. Said, hey honey, take a walk on the wild side.
He has a path, a very clear path.
What type of job is she looking for?